Hello, welcome everyone. Welcome to our Women's Heart Health Education Day. Thank you so much for coming. My name is Sandra and I'm one of the nurse educators here at the Heart Institute, and I'll be one of your in-person moderator. With me is also Stephanie LeBlanc. She's one of our nursing coordinator and a member of the Canadian Women's Heart Health Alliance. And she's also joining me as the in-person moderator. And we've also got two nursing colleagues back there, Kristy Strecko and Zandra Koopman, who will be our virtual moderators. So thank you again for everyone. We're really delighted to see all of you here. I can see here in the audience a sea of red, which makes me really delighted. So yeah, I'm glad that everyone's wearing red and raising awareness for women's heart health. And that's what we're here today to do. Raise awareness, but also be educated about women's heart health issues. So before we begin, I'd like to actually start with our land acknowledgement. So the University of Ottawa Heart Institute acknowledges the unceded traditional territory of the Algonquin Anishinaabe and the people of the Algonquin Anishinaabe Nation. We recognize all Indigenous people in the region from all nations across Canada who have also made Ottawa their home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. We dedicate ourselves to moving forward in the spirit of partnership and reconciliation. Together, we take the responsibility for the heart health of all people in the region. So we'd like to share some quick few housekeeping items. The first is that we have our digital event guide that's available to you. Here you can find our agenda for the day as well as speaker bios. So please use this QR code with your device or use the link that's in the Microsoft Teams chat. If you would also like a certificate of attendance for today's event, please email myself at the email noted on the slide there. And then just a couple other friendly housekeeping items. So for our in-person participants, we just ask kindly that you would put your devices on vibrate or silent. And then we'll also have Q&A after our presentation. So we'd just kindly ask you that if you have a question, just to raise your hand and we will pass the mic for you to speak in it for your Q&A. And then for our virtual participants, we're really glad you're here today too. And we just also want to encourage you to enter your questions and comments in the chat, and you'll be moderated by one of our virtual moderators. And all sessions today will be recorded and shared with the participants following our event. Okay. And last housekeeping items is that if you haven't completed our pre-event knowledge quiz yet, please go ahead and do it. You can scan the QR code here, and it's about a 7 multiple choice question. It's a good way to test your knowledge before you start learning today. And after completing it, your name will be entered in a draw for some prizes. So lots of incentives to participate. And then it is my pleasure to welcome our opening remarks speaker, Bonnie Bose. Bonnie Bose is the Vice President of Quality, Risk, and Health Information and our Chief Nursing Officer here at the Heart Institute. She oversees the Division of Prevention and Rehabilitation, the Women's Heart Health Clinic, and the Canadian Alliance for Women's Heart Health. Her expert leadership and support are one of the main reasons for our annual education event and all the changes that's really made through the Heart Institute to support women's heart health. So welcome, Bonnie.
Thanks, Sandra, and thanks to the little team of nurses all over the place that are making this day happen. It's exciting to be here on this Wear Red Canada Day to do an education session on women's heart health. Of course, Wear Red Canada is a day that's focused on education and advocacy for women's heart health. And it's the day before Valentine's Day, so it's very fitting. I think we have I don't know how many people we have in the room, but we have 300 people registered today. There's about 160 online, almost 170 now. So please take the opportunity to not only learn from your guests, our guests today, ask questions, and share knowledge with each other, because I think that's always really important on these days. So why are we here? What's the problem? The problem is that heart disease is the biggest killer of women. Not everybody knows that, though. There's not a lot of public knowledge about heart disease in women. Women are understudied, underdiagnosed, and undertreated for heart disease. Historically, research has been done mainly on men or not separated by sex. Because of that, there's no sex-specific outcomes, and the body of research for women's heart health is still very small even to this day. From a research point of view, it's still really early days, and this is where our knowledge will grow and change over time. So these days are really important because there's always new research and understanding happening. There's a lack of awareness by clinicians on what's known about women's heart health. Specific differences have historically not been taught in medical nursing or allied health education. When I went to school, there was general knowledge about cardiac disease, and we didn't learn about any female-specific risk factors or how symptoms might manifest different in women or what diseases might be more prevalent in women. The media is another problem. Signals from the media and other social and cultural sources emphasize the male experience of the heart attack. So we developed this mental model of what a heart attack looks like, and it's a middle-aged man with maybe a bit of a gut having a heart attack. Because of these mental models, clinicians can develop diagnosis suspicion bias, and which leads to women being underdiagnosed. Public education is also focused on men quite often and male experience. Therefore, women aren't as knowledgeable about specific risk factors and warning signs as they should be. So that's why we're here today. Today, you're going to learn about a patient's learned experience as it relates to women's heart health. There's going to be some information on known and emerging research in the field. Some information about female-specific or dominant conditions like cardio-obstetrics, MINOCA, NOCA, and SCAD, and about women's heart health and diabetes, psychological considerations, and women's heart health, nursing education, and more. So we hope you get a lot out of this day. And like I said, try to share knowledge with each other. And when you leave here today, use the knowledge that you learned to educate and advocate for women's heart health. With that, it is my pleasure to introduce our first speaker today, Dr. Thierry Mesana. Dr. Mesana is a renowned cardiac surgeon, scientist, professor, and has been our CEO at the Heart Institute since 2014. One of his many accomplishments as CEO was to enable our Women's Heart Health program here at the Heart Institute. One of the strategic pillars, in fact, one of our 4 strategic pillars is promoting cardiac wellness with a focus on women's heart health. Dr. Mesana will be presenting an overview of women's heart health, discussing some of the female-specific risk factors and types of heart disease more prevalent in women.
Thank you very much, Bonnie, and thank you, Sandra, and the whole team. I know you guys have worked hard on this, and I'm very, very impressed. First of all, not only the attendance in the room, and I apologize for not wearing red. Is pink okay, or it's a transition to red, right? So anyway, and thanks to the almost 180 now participants online. But usually when you have that kind of meeting, you have not as many as in a room. So I'm very, very impressed. Yeah, so you said it. I saw from the beginning of my tenure as a CEO 10 years ago, when we started the Women Heart Health Center, I was extremely, first of all, proud to lead the way for this initiative. I think it's a very important healthcare initiative. I'm very proud that the Heart Institute has become a beacon in Canada and even in the world. There is actually every other year, there is a World Summit on Women Heart Health, which is actually led by the Heart Institute with heart and stroke. But really, the Heart Institute is the pillar. And not only that, the Heart Institute is basically almost the soul, and maybe the soul actually, support to the Alliance. So a lot of people take advantage of the Heart Institute leadership across the nation. So I'm going to do a short overview, but basically most of the things I'm going to say, I guess you know it or you're going to hear it a bit later. And I'll share with you a last slide, which is a bit kind of my legacy to this program and how I can see the future. A lot of people ask me always that, the main question that the CEO has, I think there are two questions you get as a CEO. How do you going to get the balance of the budget? And second, how are you going to find enough money to do things like that? And the third, but you never get the right question. What is really important? And I think this is very, very important. So I'll just do like maybe 15 or 16 slides. I'm not sure how many there are now. Like, okay, let's go ahead. And did I move it or you move it? Okay, I do move it. All right, so I got it. Thank you. I'm a surgeon. I can still do things by myself. Yeah. All right. So this is a few numbers, but it's always good to remember them. So 1 out of 3 women worldwide have heart disease. 1 woman dies from heart disease every 20 minutes. So since the beginning of this meeting, we already almost have 2 deaths in Canada for women. It kills 5 times as many women as breast cancer. Heart events are actually quite common even in young women, and that's quite scary. And heart disease in women, like for men, actually, is a lifelong management. And it's all about not only secondary prevention when, of course, the woman had the problem, and then you have to take care of the problem and then make sure you prevent the problem to occur or other problems to occur. It's most primary, trying to educate very early in the game women for heart disease. And I think this is really an important goal of this Women Heart Health Center. And the thing which is also striking is how the healthcare professionals actually lack expertise. So an event like today is important, but I hope there will be even a lot of doctors there, because I believe that many doctors, actually, even cardiologists, don't have all of them, not here at the Institute, of course, but maybe in other places. Some of them may lack knowledge about women's heart health and diseases. So, and really, because they are less aware, because they are functioning, like Bonnie was saying, with kind of a preconceived ideas. They have some fixed image, or it's not well taught at universities, faculty of medicine, or even in nursing schools, or other settings for education in cardiac care. So it's just that there's a lack of emphasis on this. And I think it's a problem. And of course, you have the same disease that you find in men, like I call actually the four pillars, the big four, I call them: the coronary artery disease, valvular disease, which is coming way more often. And actually, I've been a valve surgeon for many, many years. In my practice, I'm probably the only surgeon in this place that had probably 50-50 between men and women, because I did a dominant practice in valvular surgery. So in mitral valve, for instance, I had fixed as many valves in women as in men. And for any kind of valve, it's the same. So in valvular disease in particular, There's not like this 75-25 that you have in coronary artery disease. There is really this 50-50. So, and valvular disease is the tsunami of the 21st century in cardiac disease, along with what? Arrhythmia, which is another big pillar of cardiac disease. And the ratio of women having arrhythmia is also close to the one with the men. So I think aging put vascular health and cardiac health for women way more important than in the past because the population is aging. On top of this, of course, you have the specific disease that you can see in women that you don't see in men. And you have a list there. And basically in coronary artery disease, the most scary thing you can have as a woman is certainly SCAD, spontaneous coronary artery dissection. I think there'll be a talk about that a bit later, and I'll show you a couple of slides about that. But there's also all this microvascular dysfunction. They have smaller arteries. I have operated on many women coronary bypass surgery, and they are not as easy as to do. It's not as easy to do bypass in women as in men because the arteries are smaller. The calcification are thin. It's not like these big, I call that the highways you can have for big guys, and they have like a highway, like a coronary artery. You can easily do like a 7-0 suture. You know, when I used to do a lot of coronary bypass when I was way younger surgeon, actually for women, I would use an 8-0 suture, which is almost invisible because the arteries were so thin and so small. I remember when I came here in 2001, it's an anecdote. So when I asked nurses in the OR, do you have 8-0? They say, 8-0? No surgeon never used that in here. I say, I need them. And they call me Mr. 8-0 for a while. But until they found out it was way better, but they didn't like it. The nurses didn't like it because they didn't see the suture. So they couldn't, and the needle was so small, they couldn't even hand it to me. So I had to take needle myself. And then I had big loops because the arteries of women were so small. So you need to have this refinement, this artistic approach of a woman coronary artery. I was very sensitized to that actually when I was a surgeon. And then you have different disease, but the main thing is really how some women can suffer of heart disease during pregnancy. And I think this is a major concern, which is now better addressed, thanks like center like we have, and very specialized doctor. So Bonnie told you that, understudied, underdiagnosed, undertreated, undersupported, underaware. And of course, the signs are different. They are missed. And there is this craziness of you have young women going to the emergency department, they have a chest problem, they have chest pain. And some people will say, oh, come on, it's their head. It's in their head. This is bad because really this is taking a big chance for the woman to die. So this is what I call the lack of education, awareness, and sensitization. So of course they are delayed, they are missed, the symptoms are different. They are like not as obvious. So, so sometimes it's not really exertion. It can be by emotional stress. This is actually why people say, oh, it's in their head. Because, you know, you have a stress, you have a chest pain. Oh, come on, relax, it's going to go away. Well, actually, no. No, it's not going to go away. You may have a SCAD, a spontaneous coronary artery dissection, and die from it. Maybe because of stress. But it happens to men too. I've seen that in men too. But in men, it's always all stress because they lift big weight and stuff like that. This is why they have their stress. Yeah. And there are some risks specific to women, in particular, as I say, pregnancy, menopause, higher risk after menopause of heart disease, and they have some specific OBGYN problems, of course, polycystic ovary syndrome. And they have, and you know, for instance, like they have more autoimmune disease. So autoimmune disease are more frequent in women. Sorry. And I just read a paper recently, is totally related to genetics. It's not related to any kind of stupid thing. It's genetic. It's whereby chromosome X. And there's a recent paper that actually showed this is the main reason why women would have more autoimmune disease. This is not an invention. This is not in their head. They are not fighting against themselves because they're women. It's because they have chromosome X. Yes, of course, it characterizes a woman, but it's in a chromosome. It's a gene, right? So this is where there is a misunderstanding of a lack of knowledge. And now we have these papers coming through that show us why women are more sensitive to some diseases more than men, because they're just different. And there are also these risk factors. Of course, they touch them the same way, like diabetes, smoking. But in fact, in women, this conventional, I would say, shared risk with men are actually more dangerous in women than in men, which makes the problem even more complicated. Physical activity, it's another problem, as well as men and human. It seems to be that in women, physical inactivity and obesity hurts more women than men. And of course, I already told you about the specific women condition like polycystic ovarian syndrome and actually menopause. So early menopause, actually before age of 40, actually increases dramatically the risk of myocardial infarction. So all together, you can see that a pregnant woman actually must have a very, as soon as you see potential risk for cardiovascular problems, it becomes really a red flag. You really have to pay attention to this pregnant woman because they are exposed to many things: hypertension, stroke, arrhythmias, heart failure, and each time they have all of them, the risk is multiplied. So this is really a specific, this is why I'm so proud that you now have a cardio-obstetric clinic and it's running very well. Dr. Garuba, I think, is the leader there. She's great and we're very lucky to have her expertise and from others. So basically, when you look at women through the lifespan, there are specific tranche of age where you have to think about when they are younger, you make sure you educate them properly because it starts very early. The education starts early, not when they are like 50 years old, when they're like 10, 15, 20 years old. And then they have to be conscious of the family history when they grow up. And then they have special condition when they're young that you have to take care of. And of course, you have the story of the pregnancy. I talked to this about that. And then you have the post-menopause. So there is this is not like men. This is very different. So you cannot see a woman the same way. You have to have all these different phases of life, which is, most of them are, I would say, hormonal dependent, but in fact, that's the way it is. So there's a lot we can do for helping them, for helping women reduce the risk of cardiovascular disease. Prevention is a very important part of medicine. The bad news is it's not funded well appropriately. Like in a system like Canada where it's on fee for service, for physician, actually there is not much advantage for physician to practice prevention. Although when you look at prevention, if you do good prevention in healthcare in a country as a nation, you're going to dramatically improve the entire healthcare system. That's exactly, I'm sorry to say that, that's exactly what Canada is not doing. It's just focusing on the end of the game. Hospitals, procedures, all of these things. But that's very good. You have to save lives. But how many more lives are you going to save if you really act preventively and you educate people early in the game? In 30, 40 years, this is the only way to save the healthcare system, to act early so you have less of this dramatic situation that we are just trying to resolve at the last minute and focusing on money spent in hospitals, which is important, but of course, the prevention could eliminate a lot of that, a lot. So briefly, the SCAD, but I think I'm not going to spend too much time on this. So the spontaneous coronary artery dissection, this is a dramatic complication, and it can happen in a or something, little calcification. So basically, it's kind of a separation of the arterial, the wall of the coronary artery, and then the blood doesn't circulate anymore and form clot. And you have to intervene emergently and actually stent these arteries, but the stenting is not easy either. So it can be a very dangerous PCI actually. So, and again, when does it happen? Peripartum, during pregnancy, during some emotional trigger, like I said before, And I was joking, but that's true. It happens in men when they do like too much exercise and they believe they are all Schwarzenegger. So yeah, they try to become Schwarzenegger, but they have to lose the belly first, right? When you say that, I looked at my video, say, am I okay here? Anyway, so, but the real truth is that SCAD is 90% of SCAD are in women, and they are in young women, and it is really very scary. And almost a quarter of them happen during pregnancy. So it's really a dramatic complication. You have a woman carrying a baby and threatened to die from heart disease, sudden heart disease in minutes. So I think this is a combination of one of the most scary things you can see on a human being. So we can, it's hard to predict. It's hard to prevent, I guess, but better knowledge is important because you have some of these women again that have been sent home with coronary artery dissection. I have a memory of a couple, not because they thought it was in their head, and then they had to come back, and then they have a massive MI, and they have heart failure, and it didn't end well. So you're going to hear about that. So you have to learn, I think, awareness, education, all the healthcare workers, doctors, nurses, everybody should know all this new terminology like MINOCA. It's a myocardial infarction with non-obstructive coronary artery disease. This is what I showed you. There is really nothing before the dissection. The artery was just fine. INOCA is just ischemia with non-obstructive. So you have chest pain, but you do an angiogram, it's normal because it's a microvasculature problem. It's different in men and women. And you have ANOCA, which is really angina, which is kind of clinical expression of actually INOCA or INOCA, whatever. Couple of slides to finish. So 10 years ago, when we started the Women's Heart Health, there was no Women's Heart Health clinic. I wasn't happy about that because I believe the clinic is the face of the Heart Institute in the community for women having cardiac condition. So I was very happy when gradually, with all the teamwork, this had evolved and getting bigger and bigger, and even seeing that when Dr. Coutinho left, it's still going and even busier than ever, which is great. So that means this is the strength of the Institute. The Women's Heart Health Clinic, to me, is a priority for the Heart Institute in our wards and for our community. Very important. So as a CEO, I'll make sure that in my legacy, this clinic will be supported and not depending on soft funding. I think it has to be part, and I know the government doesn't fund it, but we have to make sure it happens, whatever is the support of the government. Because so if you manage well the Heart Institute budget and business, you can support many things without having right away the funding of the government. And hopefully one day, the government will understand the value of women's heart health and prevention and start funding this. But that's the way we do things at the Heart Institute. We don't necessarily wait until we have the money from the government to do things. We try to do things that are important and then demonstrate that works with data, and then it gets funded. That's what I've done for the last 10 years. This is how you end up with twice the budget that we had 10 years ago, and 1.5 times bigger institute, and 1.5 times personnel, 1,200, 1,800. 50% bigger institute, twice the budget from 10 years ago. This is how we can have this, the women's clinic. So it's important to have the clinic. But the thing is, you need to have the right people in this clinic. So if you're woman, it's not because you're a woman that you should go to the women's heart clinic. You may have, because you can go to any clinic for heart if it's not really specific to women condition. If not, you're going to end up with 2 cardiologists seeing half of the population and the rest of the world seeing the other half of the population, the men. So that's the work that has been kind of tuned up, where really the women going to women's heart health clinic have specific condition, heart conditions to women. And I think this is the great job that the team is doing now. So I'm going to finish. How many minutes do I have? Done? I think I'm done. Okay. Okay, so I just quickly, the alliance is very important. Maybe more, you're going to hear more about that. But let me finish with this. So as I said, strategically, because this is what healthcare is going to. So if you look at this women's clinic, this women heart health center, we need to continue to develop and secure the clinic, to have a right clinic model, the right patients in it, and to stabilize the funding. You need to develop the database. Thanks to a generous donation, we have actually money, we had money to develop the database to have the data available. I think it's very important we get our own data, not just publish on data from like public health sites or whatever. We need to have the data of the women in our community. It's very important. And if you start early, in 10 years, you have tens of thousands of data on women heart health, which are very reliable, entered in the database controlled by the Heart Institute. And hopefully you will have also the other centers across the nation participating in the registry. So you have to use the number 3, so you have to use women heart health, I think, as a platform to expand prevention wellness into the population. I heard actually one of the surgeons say, you know what, your women heart health is great, but now I'm going to build a men's clinic. They say, well, then you have kind of what, the men's clinic, women's clinic. Why do you want to have a men's clinic? Just put the women's clinic for now and then we'll see. So we have to redesign the alliance support. The alliance is too much, I'm going to say this up front, is totally relying on the Heart Institute. But you have so many centers. We have to find a way that everyone contributes to the national approach, not just the Heart Institute, because there is absolutely no money for that other than the Heart Institute money. So if, as a CEO, I didn't want to support this, the alliance would not exist. I would say, no, I'm not going to put money in that thing if no other CEO does put any money, right? So the last thing is, because we are pioneers 10 years ago, we need to continue to be pioneers. To continue to be a pioneer, you need to work harder and harder. You know what Nelson Mandela was saying? Nelson Mandela was saying, when you get to the top of the mountain, which is probably about where we are now with this clinic, the only thing you can see is all the other mountains you have to climb. This is it. Thank you. Question? I stay here? Okay, I stay here.
Thank you.
So questions?
Yes, thank you so much, Dr. Mesana. Are there any questions from our in-person audience or virtual? Well, I have a question for you, Dr. Mesana. As a surgeon, what are some of your surgical considerations for women? So, for example, in the case of a woman with SCAD.
Well, usually they are not surgical indication. It's better to treat them non-invasively with a. I think that the surgery in a coronary dissection is not really the best. You have to graft to bypass the artery very far down to correct the dissection, and you know, I think the best thing is to have a PCI there. And I mentioned a bit the coronary artery consideration. I would say the valve is very different. Treating repairing a valve in women is I would say it's harder, because once you get it, you know, I've done probably thousands of them. And I think the way I approached mitral valve repair in my career was always like an artist. So I would remember actually every single valve that I have repaired like a painting. So yeah, I visualized after the repair, and I would always do what I call precision surgery, which is basically, you believe that all the defect of the valves are the same, but they are not. There's always something you can do, a little touch-up at the end of the case that actually can benefit the patient. This was my approach to mitral repair, and in particular for women, because they have smaller valves, and you have to be extremely precise by the millimeter, because if you miss one stitch, you can have a little leak after the surgery, And I never accepted to have any leak after surgery. This is probably why, the results always stayed for a long time. As soon as you have a little leak after the surgery, after 10, 15, 20 years, it becomes a bigger leak, and then you have to re-intervene. So in mitral repair, for instance, people say the rate of reoperation is about 1% per year on average. So after 20 years, you get 20% of patients have to be reoperated, and probably in women is higher in the literature. But I think Dr. Shan has put my 20 years follow-up on mitral repair. I don't have 20%. I have 2%. So this is 0.2% a year. It's not, it's 0.1%, it's not 1%. That's things you need to, the transplantation is different too for surgery. When you have a woman for transplantation, smaller chest, you can't take a big heart. Aortic dissection, aortic disease is tougher because they have smaller aortas and they can actually dissect spontaneously quickly on the suture. So there's a lot of things that a surgeon needs to be aware of when he operates a woman. I'm not sure it happens all the time, but when I had a woman on the table, I was always particularly cautious to everything because I know that as soon as you have a complication in a woman, it always got way worse than men. The reserve, the physiological reserve to fight a complication in people with smaller body size as women is not the same. Does it answer your question?
Yes.
Yeah.
I think we have a question virtually as well.
So we have a question online. The question is, most of the information so far has focused on cisgender women. Is there any research currently on how transgender women experience heart disease?
I may not be the best person to answer that question. I hope there is, but maybe someone has an answer. Bonnie. I think they should be, but I've not been aware of big paper recently on that. I know it's going on, but.
Yeah, that's a really good question. We actually have a project going on right now looking at transgender women and the effects of hormones, socioeconomic status, and a number of factors as they relate to women's heart health. When we did the background on this, there was very little research. It's almost nothing. So like I said, with research, it really is emerging. I expect that there's an interest in this now, and it will be learning over time. That's just why it's important to be doing these every year so that we can constantly be up to date on what's new coming out. But yeah, the answer is no, but sorely needed.
Yeah.
The next question is, how does PCOS increase the risk of cardiovascular disease?
PCOS. I am the worst guy with the acronym. So what does it mean?
It's polycystic ovarian syndrome.
Oh, okay. All right. Sorry. Apologize. So what the question was, what?
How does polycystic ovarian syndrome increase the risk of cardiovascular disease?
I would say there is certainly a hormonal context and also maybe some inflammatory context as well. And but I would say with all humility I can have, it's not my area of expertise. Maybe Dr. Garuba can answer this question better, but I would imagine this is the reason. Hormonal context and maybe more inflammatory disease. Heart really, maybe at the end of the day, we find out that every single heart disease is all inflammatory, including valves, including even at the old age. Coronary artery disease, there's a lot of inflammation. We have a lot of basic scientists doing research on that, actually, in people like Katie Reiner and people like that. So they found things. Yeah. More? No? Yes? On here. So in French, we say, you have more appetite when you start eating. So then there was no question initially. Now you have more and more questions. Sorry, the microphone doesn't work very well. Go ahead.
I'm wondering why for those women have diabetes, they are much more likely to have cardiovascular diseases in the future compared to men.
I think it's related to the microvascular problem. Diabetes is already associated with microvascular disease. So I think women having also being prone to more small arteries and microvascular disease I think it just magnifies the issue. That would be my guess. But there's a lot of research to be done. I don't have maybe a final answer. It's hypothesis, but a sound hypothesis.
Thank you.
Thank you, Dr. Mesana. That was great. I'm going to introduce our next speaker, Nadia. And Nadia is one of our Heart Institute alumni, and she currently works for the International Transportation Association. She is also a mom to 3 children. And her story is that after the birth of her 3rd child, Nadia suffered a myocardial infarction caused by SCAD, spontaneous coronary artery dissection. So she is here today to share with us her journey with living and recovering from SCAD. So welcome, Nadia.
Okay, so I just click through, yeah. Okay, perfect. Hi, everyone. Thank you so much for having me. I'm really happy to be here. It's been a while since I've been back to the Heart Institute. I do like some volunteering, and I sit on some of the committees, and it's always nice to come back and meet new people and see fresh faces. So thank you for having me. Let's see if I can work this. Oh, we already did this. You know all about me. So here we go. So yeah, cuteness overload, you know, a proud mom. So for some 30 odd years, I had the cliche life. I graduated, I got a job, I had a big fat Italian wedding, we bought a house, we made it a home, we traveled, and we had 2 babies, and I was happy, we were happy. Before time ran out, and because the first 2 were so cute, we decided to have a 3rd, and this is Nicholas. So Nicholas was born almost 8 years ago, February 24th, 2016. And he was good. He was cute. He was easy. He slept. And I did what all new moms do. I watched Netflix and chilled, literally, but that's all I did. And when Nikki was 7 weeks old, I also did what all new moms do. I dressed him up in his finest clothes, and I took him off to show him off at work. So I guess the story begins on that fateful day. Almost 8 years ago, I lay on the cold, dirty floor of a public washroom. So I work for Transport Canada, and I did then, and I still do. Technically, right now, I'm seconded to an international road association. But that's my building right there, located on the corner of Queen and Lion. And so that day, after a lovely lunch with some of my colleagues, I proceeded to the offices to show off the baby. So I arrived at the concierge desk and felt a surge of anxiety and the need to flee, to be away from people. I equate it to how you feel when you're not prepared for a presentation, or someone asks you a question that you should know the answer to, but you don't know the answer to. This like need to flee, like you just anxious, nervous. I need to get out of here before anyone sees me kind of feeling. I wanted to crawl under the desk in the lobby and lie down on the floor. And so just to get a visual, to get to my offices, I needed to cross the lobby and take an elevator to the 19th floor. And I remember I was standing there at the commissionaire's desk wondering, like, how am I going to make it those 20 steps? Like, I just felt very nervous, very anxious. I didn't know what was going on. I just felt like the world was like crashing in on me. And then I had to walk like 10 steps past the elevator. So I didn't really know how I was going to do this. And I really, like, to this day, I don't know why I didn't say something sooner, why I continued with this plan to go up to the offices. I just figured that whatever I was feeling would pass. Anyways, so I belittled, this picture's getting kind of boring. I should update these slides. So I belittled what I was experiencing. I wasn't understanding what was happening to me, and it never crossed my mind that my heart was deciding it was spontaneously done for the day. So I headed to the washroom, and I was violently ill. The baby was somewhere with someone, I'm not sure, I don't really remember. And my colleagues were watching me lying on the floor in the washroom while I insisted that I was fine, or that I would be fine. And there was one that tapped into my Italian Catholic guilt, and channeling my ancestors, she declared that if something happened to me, it would be on her. She told me, she said, you know, you have 3 kids, if something happens to you on my watch, it's on me. So I'd prefer if we call. And I was like, well, yeah, you have to do that, of course. So as I lay there trying to think and listening to the others, I was acutely aware that my brain wasn't working as it should. So like I couldn't make connections. I couldn't finish thoughts. I remember like a peripheral discussion happening about, okay, well, the paramedics are coming. She's probably going to go to the hospital. Like, what are we going to do with the baby? And I couldn't work it out. And I mean, the obvious answer is to call the husband or the mother or something, but like I couldn't get there. I couldn't think past myself. So while I was laying there waiting, I began to realize that something was actually probably seriously wrong. So like, what did I do? Like, how did I let this happen? Like, I like to control things. I like to have everything where it's supposed to be, when it's supposed to be. And this was not part of today's plan. So I convinced myself that it was mastitis, and I tried to convince everyone else as well. So mastitis is a painful condition. I've never had it, but it causes chest pain, very similar to how I was feeling. And so I rationalized that that's obviously what it was. Simple, easy fix. I'll stop by the doctor. I'll get some antibiotics. I'll be on my way home. We'll bring the kids where they need to go tonight. Everything will be fine. Of course, hindsight is 20/20. And now I look back and realize how ridiculous it was that I didn't know the signs. So for me, for a woman, these were classic textbook Hollywood heart attack signs: severe pressure and pain in my chest, weakness, numbness in both arms, excessive sweating, and I was very, very ill. So once the paramedics arrived and triaged me, it was clear that I was experiencing an event, and I was fortunate enough to bypass the normal triage routine of the Ottawa Hospital emergency rooms and was rushed to the Heart Institute and wheeled into the cath lab upon arrival. So I don't remember much about those first few moments. Like I can remember being in there and the lighting. I remember the lighting. But I do remember answering no to all their questions. So, do you smoke? No. Do you do recreational drugs? No. Do you have a family history of heart disease? No. I ate kale and grapefruits. I exercised regularly. I did what I was supposed to do. And maybe it's because I'm a little bit vain, but it still counts. And I lived a healthy lifestyle, but really at that moment, none of it mattered. So, oh, that's from something else. Sorry about that. So I kept hearing SCAD. So nurses and doctors running through my information. She's 37 years old, 7 weeks postpartum, breastfeeding, no other risk factors. It could be SCAD. So I felt like I was in a parallel universe. I didn't understand what SCAD was. I had 2 heart caths done. After the first one, it was explained to me that it was the best of the worst scenarios. I had experienced what they thought was Takotsubo. Okay, so everyone's happy and relieved that, you know, nothing serious is really wrong with me. I'm going to be okay. Everything's okay. Except that I was getting worse. I wasn't getting better in the time that followed. So within another 2 hours, I was back down to the cath lab, and things actually had gotten worse. So they knew to look for it, and they missed it the first time. It's that hard. So during the second heart cath, 3 dissections were noted. So if you look at the slide here, and you're obviously much more familiar with this than I am, but this is how I was explained what these meant. And these are actual photos of my scans. So the first image shows a shortened artery, and it just stops. So 100% of the blood flow stopped, 100% occluded. So as Dr. Mesana spoke to this earlier, their hand is forced. When this happens, they need to restore the blood flow and open up the artery. So the first dissection in the RCA, the right coronary artery, required 3 stents to open up the artery and keep the blood flowing. And in the second image, you can see, I think those blue arrows, at least this is how it's explained to me, were where the stents were placed to open things up. I had another major dissection at 70% occlusion in the left anterior descending artery, but that one they left to heal on its own, and I'm assuming it has because no one's gone in to find out, and I'm still here. So the standard of care, and I believe this still rings through today, is to leave a SCAD to heal on its own unless there is no other way. So once it was all over, or so I thought, it was explained to me, okay, Nadia, you've had a rare type of myocardial infarction caused by spontaneous coronary artery dissection, or SCAD, which is typically attributed to elevated hormone levels, in my case anyways, during pregnancy, which affect the integrity of the interior of the artery walls, making them fragile and subject to tearing. So I went back up under watch, confident that the mechanical rebar reinforcement they had provided me would do the trick, but I didn't get better. I kept getting worse. And this is the part that I really stress with fellow patients and healthcare professionals, like you are your own best advocate. I had just had my third child, and the pain of that experience was very fresh in my mind. And it did not come close to comparing the pain that I felt that was radiating in my upper torso. So I felt as though, like, you know, those cartoon characters that you see sometimes, like the old school ones, where like rocks are being pulverized. Like that's how I felt. My bones, my shoulders were just being pulverized. That type of pain. And I actually asked, this is a little bit embarrassing, but I actually asked to be knocked out. I said, like, can you just like put me out of my misery for now? Like just knock me out and it'll be fine. And he said that wasn't allowed. So after a day or two of very severe pain, they realized that I'd gone into heart failure and things got a bit more serious if they weren't already. What isn't apparent, I guess, is that it takes a few days to determine how much damage is sustained after an event. And in my case, it was significant. So I woke up in my bed with a teeny room full of doctors and nurses around its perimeter and an ultrasound technician at my bedside. And as was explained to me by my husband, who was cowering in the corner, what you could see clearly on my echocardiogram was that the left side of my heart was beating or trying to beat, and the right side was just quivering. So things weren't working the way they should. So this probably explained the bone crushing pain that I was experiencing. So the next few weeks weren't pretty. I don't know if we have, yeah, here we are. The next few weeks weren't pretty. I had tubes coming out of everywhere. And my CCU room looked like Times Square with all these monitors and beeping machines and everything. And I spent several weeks at the Heart Institute while the critical care unit successfully, thankfully, got my heart beating regularly again. And while my heart was remodeling itself and I was at the Heart Institute, you have to keep in mind that we still had 3 kids that needed to be cared for and shuttled around. So there's no way that you can do this alone. Like it's actually not possible from a hospital room. So, and when you do this and you go through this type of experience, you really do realize that there's, you know, everything changes and you have to restart. There's a before and there's an after. It took my body about 2 years to recover, and I can try to describe to you, if it's helpful, what it looked like on a day-to-day basis. For example, I had a 90-year-old neighbor who lives next door to me. She's 96 now, and she's still doing great. And she walks with her caregiver every day, 3 or 4 times a day, around the block, nothing crazy. But I couldn't keep her pace. Like I couldn't even try to keep her pace when I got home. Like I was just inch by inch. I had to time the trips down to the kitchen so that I could minimize the amount of times I had to climb back up the stairs. I would often stop halfway to rest or sit down by the cabinets in the kitchen just to breathe. And I couldn't, like, this stays in my mind, I couldn't stir a bowl of pancake batter. My kids wanted pancakes, and this was maybe like 2 months after I'd been home. So I was like, okay, yeah, and well, fine, sure. So I didn't have the breath to do it. Like I could not stir the bowl. So that's what heart failure looks like, and it sucks. Over those 2 years, I kept replaying that day and the days that followed in my mind, deciphering every moment, looking for a why, a what if, and some clue that would unravel the whole puzzle for me. And I was starting, honestly, to lose sight of the horizon, trying to understand something that no one could explain. It's literally called spontaneous. For an engineer who looks for the rationale behind everything, it's a really difficult notion to process. Thankfully, I had a very supportive team at the Heart Institute led by Dr. Sharon Shi. I also spent a lot of time with my psychologist who helped me walk through the mess, the depression, and the PTSD that followed. Life's worst moments often make the best speech material, and that has never been true than after I survived a heart attack. This is just a shot of some red stuff that we've done in the past, and some great people that I've met along the way. I really do think it's important to advocate for this. So to look at me now, I'd like to naively believe that none of you would guess what the past 8 years of my life looked like. Since my little heart attack, I've completed many 5K marathons slowly. Right there with Dr. Coutinho, she's up on the rightmost here, who promised not to leave my side just in case, because I was quite nervous to do it the first few times. And I've climbed mountains, went overseas. You know, I've done things that any normal 40-ish-year-old woman would do. So I had no idea what was happening. I'm an educated woman with a science background. I'm fairly, I think, well-read. And in my family, we've dealt with a myriad of health issues. And yet, as a woman, I have grown to believe that I would likely die from breast cancer. I certainly had no idea what was happening to me, and I think it's really, really important to advocate for this. We started something with high school students a few years ago as part of the work that's done here, and I really think it's important to get to these girls young to explain that this is something that could happen to them, and I'm really, really passionate about this. So I had no idea what was happening to me, to the point that even as I lay on the floor of a public washroom with a crushing pain in my chest, the thought that I was dying, still 8 years later, of a heart attack didn't even cross my mind. Anyways, that's my story. And I'm really happy to have shared it with you today.
No problem. That was such a great presentation. Such an honor to hear your story. Really,
my pleasure.
Yeah. I'm just wanting to see if we have any questions in the chat or in person here.
Okay. Good. Oh,
there's a question there.
Yeah.
Hi there. I was just wondering, because I have a 18-year-old who's just finishing up high school, and he tells me that it can be quite challenging to get presentations about all kinds of interesting things. How hard was it for you to get in the high schools to talk to them? Because I think that sounds fantastic to start sharing it at that level. The only reason my kid knows is because I work here, sort of thing. So
yeah,
I'd love to hear more how you did that.
So I wish I had written down everything. So it's part of a program that's run here by, I think it's with the Alliance, as part of the Alliance, one of the committees. And we developed a whole like module where we don't actually have to go into the class. So my story, like, it's recorded, my son gives his point of view, and just to get a teenage perspective, and it's moderated by another teenager. And so the whole thing can you just press play and it can be shown in classrooms, and it is shown in classrooms across Canada. So it's widely disseminated, so we can definitely get you that information after if you'd like. Here, because I'm in Ottawa, and I really think that if I can go into a school and they want me, and some schools do it on repeat, every year I go into the same class. Typically it's a healthcare class, but I think like when you go into a class, it gives like a real, it's a different experience, right? So, yeah, so it's not hard. It's about making connections. But yeah, we can definitely share the information for sure. Yeah, it's already, you just have to press play. So. Okay. That's sweet. Thank you. Thank you so much. Okay, great. Thank you. Thank you.
Good morning. Our next speaker is Dr. Garuba. She's a cardiologist and an echocardiographer at the Ottawa Hospital General Campus and the Heart Institute. She leads the Cardio-obstetrics clinic at the General and the Women's Heart Health Clinic here. She will be presenting today on the effects of pregnancy on the heart and the treatment of cardiac patients while pregnant. Welcome, Dr. Garuba.
All right, good morning, everyone. I hope you're all doing well this morning. I hope everyone's appropriately caffeinated, as I am now. Thank you very much for giving me the opportunity to speak with you today on this annual Women's Heart Health Education Day during Heart Month, which is February. I'd like to speak to you on a topic that's quite near and dear to my heart, both from a personal and from a patient care perspective. So cardio-obstetrics, or Pregnancy and Heart Disease 101, is the title of this talk. So I am privileged to be the interim director of the Women's Heart Health program here at the Ottawa Heart Institute, and I also lead a cardio-obstetrics clinic at the Ottawa General Campus, where we look after women who are at the intersection of pregnancy and heart disease. Two topics or two concepts I'm sure most people don't expect to intersect, but we'll dive into the talk and see how that goes. Okay. Just, oh, it's touchscreen. Well, no. Gotcha. Okay. All right, so today, I'm hoping by the end of this talk, you'll be able to understand what cardio-obstetrics is, but more importantly, why does it matter? We'll understand, or we'll talk through how pregnancy affects the heart. How do we assess maternal cardiac risk or risk to the mother in pregnancy? How do we approach heart disease in pregnancy? And what initiatives or resources are available for patients and healthcare providers? So what is cardio-obstetrics and why does it matter? And I think the best way to illustrate this is to go through two cases, or three cases rather, obviously names, details, etc. changed, but of women that I've actually encountered in the course of my practice. So Annabelle's a 29-year-old woman, just recently delivered her first child at 2 weeks postpartum and comes in short of breath with leg swelling. Her ECG shows sinus tachycardia, a fast heart rhythm, and a left bundle branch block, so a conduction disorder. Immediately, it's thought she might have a blood clot in her lungs. She's scanned for that. It's negative, but an ultrasound of her heart is done and shows she has severe heart muscle dysfunction with a left ventricular ejection fraction of 25%. Her heart's dilated, her valves are leaking, and she is diagnosed with something called peripartum cardiomyopathy, so heart muscle dysfunction associated with pregnancy. So what's the management plan? Can she breastfeed? Are there any issues for future pregnancy? Next case is Hannah, who's a 36-year-old woman, first pregnancy at 28 weeks with twins conceived through IVF. She comes into the hospital with crushing retrosternal chest pain and is diagnosed as having an anterior STEMI, so a major ST elevation myocardial infarction, a major heart attack. She undergoes a cardiac catheterization and she's found to have SCAD, spontaneous coronary artery dissection, as we've just learned from Nadia's very courageous story. SCAD is of her main artery, the proximal LAD, which is 99% blocked. She receives 2 stents. She's put on aspirin and a second blood thinner, clopidogrel, but now is faced with what is the plan for her delivery. And next, we have the case of Constance, a 31-year-old woman who's not yet pregnant, but contemplating pregnancy, who has Marfan syndrome. On her echo, she's found to have a prolapsing or ballooning mitral valve with mild to moderate leakage of that valve, and her aorta is dilated. Her father's brother, her paternal uncle, died of an aortic dissection, so she's worried about her risks in pregnancy. Does she need any intervention prior? So what exactly is cardio-obstetrics? So cardio-obstetrics is an expanding subspecialty within cardiology that focuses on the prevention, the early detection, and the appropriate management of cardiovascular disease in the context of pregnancy. So within cardio-obstetrics, we deal with anything from counseling preconception for those with established cardiac disease, management of cardiac disease or new cardiac symptoms that come up during pregnancy, and that can run the gamut from diseases of the coronary arteries, diseases of the aorta, diseases of the heart muscle, of the heart valves, abnormal heart rhythms during pregnancy, blood clots that come up during pregnancy, diseases of the pericardial sac or the sac around the heart, and so many more. And also what we sometimes affectionately call the fourth trimester, which is the time after pregnancy when women who may have had hypertensive disorders of pregnancy, preeclampsia, gestational diabetes, etc., where those women also need care, and even for up to a year after pregnancy, where it may be important to manage future cardiovascular risk. So as I mentioned, we go through all trimesters of pregnancy and as well preconception and postpartum. Some of the questions that we commonly get asked are things like, what is mom's risk of having a heart issue, a heart event, or decompensation of her heart condition during pregnancy? Does mom require a C-section as a result of this condition? Does she need cardiac monitoring during labor and delivery? Do we need to change any medications during pregnancy? Does she need a cardiac intervention prior to delivery? Can she push if she's having a vaginal delivery? Is breastfeeding contraindicated or forbidden? Should the current pregnancy be terminated because the risk is so high to mom? Is future pregnancy off the table? Will her heart function improve, and are heart medications required lifelong? So these and so many more. So why does cardio-obstetrics actually matter? So there is an increasing prevalence of cardiovascular disease in pregnant women. And part of this is because in the last couple of decades, women are sometimes there's an older age at first pregnancy. And of course, cardiovascular risk increases with age and with an accumulation of risk factors such as high blood pressure, diabetes, etc. But other reasons, we now have better treatments for congenital heart diseases, which may have prematurely ended the lives of young women who now are able to grow up and reach their reproductive years and beyond. We also now have better diagnostic ability. So there's some conditions, some inherited heart conditions that before we weren't able to diagnose, but now we can. And so women reach their reproductive years, and we now know that they have these conditions. Now, in Canada, there was a landmark study called the CARP-REG study that was done between 1994 and 2014 that looked at almost 2,000 pregnancies and studied which of these pregnancies had cardiac complications, what were their outcomes, etc. And the study showed that about 16% of pregnancies across that decade actually had cardiac complications, and 4% of those were extremely serious, including things like congestive heart failure, clotting of valves, dissection of the aorta, heart attack, cardiac arrest, stroke, etc. And almost half of these cardiovascular events were actually preventable. So that's one of the main reasons to me why this topic is so important. Cardiovascular deaths are the most common cause of maternal mortality in the US and increasing so in Canada. So about a quarter of all deaths of pregnant moms are because of heart issues, whereas all other causes are on the decline. Cardiac deaths are on the rise. So things like infection, bleeding during pregnancy, etc., all those causes are decreasing, and yet cardiovascular deaths are rising. In addition, women are at significantly higher risk of future cardiac disease if they have adverse pregnancy outcomes, including things like preeclampsia, hypertensive disorders of pregnancy, and things you may not expect, such as delivering babies that are large for their gestational age or babies that are really small for their gestational age, preterm delivery, or recurrent pregnancy losses. These are things we term APOs, or adverse pregnancy outcomes. They are so important now and so closely linked to future cardiac risk that we now use them when we're calculating cardiovascular risk for patients that we see. So if your cardiologist or your family doctor asks you about your pregnancy history as part of establishing your cardiac risk, don't be surprised. The obstetric history is very much a part of the cardiac history. We sometimes talk about how pregnancy is often a woman's first heart stress test for those who will become pregnant. So Cardio-obstetrics cannot exist without a team approach. It requires collaboration from maternal fetal medicine, from cardiology, from anesthesiology, cardiac surgery, internal medicine, nursing, social work, pharmacy, neonatology, genetics, etc. There was a study published in the Journal of the American College of Cardiology in 2020 that showed that when pregnant women were managed by a cardio-obstetrics team, maternal outcomes were better, and readmission rates to hospital for cardiac reasons after delivery were much lower. Now, more locally, the Canadian Cardiovascular Society in July 2021 published their clinical practice update on cardiac management of pregnant patients, and it highlighted how outcomes are much improved when formal cardio-obstetrics programs are introduced into a center. So how does pregnancy actually impact the heart? Quite a bit. So cardiac physiology changes quite dramatically during pregnancy. Cardiac output increases by about 30 to 35%. Stroke volume, so the amount of blood that the heart pumps out with each beat, that also increases because volume expands as the mother grows a fetus. Heart rate increases as well, and systemic vascular resistance, which is sometimes a surrogate for blood pressure, tends to drop in the first and second trimesters, but rises in the third trimester, as we mentioned, so blood pressure does the same. Other changes can also happen in the heart structure itself. So heart chambers can enlarge ever so slightly, and that's considered normal to accommodate for the increased blood volume. Valvular regurgitation or slight leakage through the valves can increase again because of the increased blood volume, increased cardiac output, and increased heart rate. However, what's not normal is that heart function should not drop during pregnancy. In addition, pressures in the lungs should not rise during pregnancy. And lastly, the aortic root and ascending aorta, those dimensions in a normal aorta and normal ascending root should not change. So that helps us differentiate what we see on heart testing when women who are pregnant come with symptoms, and we can help advise on what's normal and what's not. There are lots of other physiologic changes outside the heart, particularly in the liver, the gut, the kidney, and the function of all these organs can impact how medications in pregnancy are absorbed and excreted. In addition, pregnancy is known as a hypercoagulable state, meaning there's an increased risk of blood clotting during pregnancy, both in the veins and in the arteries. When it comes to drugs in pregnancy and breastfeeding, so we used to use this classification system of A to X. So A, safe in pregnancy, B, no, we have no risk in animal studies, but no good studies in pregnant women. C, some harm. D, a lot of harm, and X, absolutely contraindicated, do not use. So in 2015, the FDA in the United States kind of phased out this categorization. But when you look up drugs, there's they now give nice narrative summaries to account for the fact that not everything is as black and white. And some drugs that may be considered slightly harmful, if the benefit to the mother far outweighs the harm, there is still some utility to those drugs. The Canadian Journal of Cardiology, in their 2021 issue on management of the pregnant patient, actually put out this nice table that is color-coded. So things that are in green are drugs that are considered absolutely safe. Amber or yellow is drugs that have, limited or conflicting data, but in some circumstances we still use. Drugs in red, absolutely contraindicated. And then blue is for breastfeeding. So the drugs that are considered contraindicated in breastfeeding, even though they can be used later on. And it's very helpful for us to be able to refer to these types of tables when looking after women. In terms of medication, contraceptive choices actually also play a role. And I'm sure most cardiologists never thought they would be the ones counseling on contraception, but it really is important. There are certain differences in some of the choices that we can make when patients have cardiac issues and are contemplating the right option for contraception for them. So copper IUDs, intrauterine devices, for those not familiar with the term, or progesterone-only IUDs tend to be our preferred option. Things that hormonal-based contraceptives, that especially those that contain high levels of estrogen, tend not to be favored because they tend to increase the risk of fluid retention and of blood clots as well. Barrier methods, of course, are always, and by barrier methods, I mean condoms, etc., are always fine, but the risk of failure is quite high. And that matters when women may have some very high risk conditions for which pregnancy is completely contraindicated. As well, when we think about what imaging tests we use, we have to think about radiation exposure to the fetus. So we measure radiation exposure in units of milligray, and we know that anything that causes fetal exposure of less than 50 milligray is potentially acceptable. So ultrasounds, MRIs, there's essentially no radiation from that. A chest X-ray is 0.002 to 0.1 milligray, so far below the 50. That's the cutoff. And even some of our, more radiation-heavy tests, so CTs of the chest, coronary angiograms, etc., still fall within this limit, depending on, of course, how many times they have to be done. Between 50 and 100 milligray, we do tend to see some impact to the fetus in terms of potentially cognitive and physical development. Above 100 is considered teratogenic, so at higher risk of developmental issues for the fetus. Important to know, let's move forward. Important to know that iodide contrast does not actually impact the fetus, so the use of contrast itself is not forbidden in pregnancy. However, the contrast used for MRI, which we call gadolinium, is contraindicated in pregnant women because it crosses the placenta and has high risk of fetal abnormalities. So how do we then assess what a mom's risk of cardiac issues are in pregnancy when she has established cardiac disease? So we use a table called the Modified WHO World Health Organization Risk Stratification Model, and it characterizes certain cardiac conditions from class 1, class 2, class 2 to 3, class 3, and all the way to class 4. So class 4 would be where pregnancy is absolutely contraindicated. These are the highest risk conditions. Class 1 is sort of mild things. So, mild valvular leakage, a repaired congenital heart issue like a repaired atrial septal defect or things like that, minor arrhythmias. So these are things that really have no higher risk than the general population, and risk increases as you go up. So class 1 would be sort of 2 to 5% risk of cardiac issues, all the way up to class 4, which is 40 to 100% risk. Some of the highest risk cardiac conditions for which we actually advise patients to not get pregnant, and in some cases maybe even to terminate pregnancy during if they have this condition are. So I've divided them up into vascular conditions, conditions of the ventricles, and conditions of the valves. So vascular would be things like spontaneous coronary artery dissection, because pregnancy-associated SCAD actually is much more severe than regular SCAD and can present with cardiac arrest, shock, infarction or heart attack involving multiple arteries and very extensive dissections. If patients have severe enlargement of their aorta, pregnancy is often also contraindicated because the risk of dissection is too high. If people have bicuspid aortic valves, where the aortic valve has 2 doors instead of 3, pregnancy is not contraindicated, but it depends on whether they have an associated enlarged aorta with that. And many of the other what we call vascular syndromes, so syndromes that weaken the walls of the arteries. A pregnancy may be contraindicated in those. For ventricles, having a history of previous pregnancy-associated heart failure or peripartum cardiomyopathy, where the heart function has not improved, that's a contraindication. If heart function has recovered completely, pregnancy may not be contraindicated, or pregnancy may be permissible. Heart function for other reasons where the heart failure for other reasons where the heart function is still very low, or where patients are actively having severe symptoms of heart failure. I think that's obvious that pregnancy is not advised. Patients with severe pulmonary hypertension, it's not advised to be pregnant. And then when it comes to valves, severe symptomatic aortic stenosis, so narrowing or obstruction of the aortic valve, that would be a contraindication. And severe mitral stenosis, that should say severe mitral stenosis, not just symptomatic, that would be a contraindication. There are other risk predictors. I tend to use more the modified WHO because it gives a nice accurate quantification of risk and tends to account for a much larger gamut of conditions. So when patients come to see us, how do we approach managing their conditions or managing what they come with? So we start first by categorizing their risk. So using some of those risk prediction tools or risk prediction models that I've shown. That's the first step. And the second step is we decide what to, if they're already pregnant, so some do come for pre-pregnancy counseling, but if they're already pregnant, we talk about how we manage. We may order some tests to define the severity of their condition or what their functional capacity is. We determine whether or not their condition is stable or unstable. We stop medications that may be high risk to the fetus or not able to be used in pregnancy. We start treatment with appropriate medications. We determine how frequently during pregnancy patients need to be tested. So for instance, is it once a trimester, a couple of times a trimester, etc. We plan for any procedural interventions that may be needed prior to delivery. And some conditions are actually inherited. And so we advise on whether the fetus, the baby, also needs an ultrasound done either during pregnancy or afterwards. We recommend genetic testing where appropriate, and in some cases, we have to advise on pregnancy termination. Next, we have to make a plan for labor and delivery, labor and or delivery, because not everyone is advised to go through labor. So often this involves a multidisciplinary planning conference with the pregnancy heart team, like we discussed. We make recommendations about the location of delivery. So is mom safe to deliver at her local hospital, or does she require a high-risk tertiary care center? We talk about whether or not mom requires a cesarean section or is vaginal delivery appropriate. We make recommendations about anticoagulation. So blood thinners may need to be stopped closer to the time of delivery because of high risk of bleeding. We sometimes comment on whether or not an epidural is warranted or advised or potentially not possible. And we talk about what kind of monitoring the patient needs during testing. So does she need a central line, an arterial line, any other special types of cardiac monitoring throughout? Does she need an IV line with filters to prevent air bubbles from getting in, which is important for women who may have a hole in the heart or shunts where blood can cross from one side of the heart to another, where it shouldn't actually. We talk about, are there restrictions on how much intravenous fluid she can receive? If the patient has a cardiac device, such as a pacemaker or a defibrillator implanted, does that device need reprogramming for delivery? And is there a need for her to be in a CCU, a cardiac intensive care unit, or a regular intensive care unit for monitoring afterwards? And then once delivery has taken place, we advise on a plan for recovery and postpartum. So being watchful for fluid overload. We talk about breastfeeding and medication safety in breastfeeding, if that's the plan. We talk about resuming blood thinners. We talk about contraception and what the implications are for future pregnancy. And we also kind of put together a plan for testing postpartum. We refer to cardiac rehabilitation as appropriate, and then we talk about genetic or family counseling. So after delivery, we've kind of touched on all these things, but I want to specifically highlight the point about assessing and counseling of future metabolic risk. We've already mentioned contraception. I put up this table earlier, so I'll just move past that. But the pregnancy and postpartum periods represent what we call a golden window of opportunity to try to address some things that may not have been addressed in women of this age group. We use this to try to mitigate some of the disparities that exist in healthcare provision to women at this very critical point in their lives. We try to identify women who might be at excess risk, intervene, and try to initiate targeted and effective follow-up. So this image up there describes some of our risk factors for cardiovascular disease in the future. And while we're all very familiar with some of the traditional risk factors that's on the, I guess, your left-hand side of the screen, things like diabetes, smoking, obesity, physical inactivity, hypertension, elevated cholesterol, what used to be less emphasized in the past, and now that's of great emphasis, especially for our program, is things like preterm delivery or high blood pressure in pregnancy or gestational diabetes. So things on the right hand of the screen. And these are the things that we feel we can have the biggest impact in. So what our aim is to educate patients that the risk of having future cardiac disease is 2 to 5 times higher if you've had a pregnancy with preeclampsia. And that risk increases depending on how early in pregnancy the preeclampsia developed, how severe it was, and how many times one has had preeclamptic pregnancies. We know that women who have preeclampsia may actually develop coronary artery disease up to 10 years earlier than their female counterparts who never had preeclampsia. And so one of the things we hope to address at this time is try to get their blood pressure normalized postpartum as quickly as possible, try to mitigate other risk contributors. So things like weight, things like any concurrent diabetes, any other potential lifestyle measures, etc. We try to recommend annual screening of blood pressure, cholesterol, glucose profiles to make sure that they do not develop some of these concomitant risks throughout. The aim is also to counsel on behavioral changes or behavioral modifications throughout the first year of pregnancy that may help set up really good lifestyle habits to try and mitigate some of this risk in the future. And we advise on things that can be done in future pregnancies, such as taking aspirin throughout the next pregnancy, if the next pregnancy is possible, to try and reduce the risk of developing preeclampsia. So lastly, what sorts of resources exist? What sorts of things should we know about? Where can we refer patients if we have patients that may fall into these categories? So there is the Cardio-obstetrics clinic at the Ottawa Hospital. It's run out of the general campus. And as I mentioned, it's a subspecialty clinic for women who have heart disease, and we look after them pre, during, and postpartum. Women who have cardiac complications of a recent pregnancy, or pregnant women who may have symptoms that are concerning for heart disease, even if it's not been diagnosed yet. And we do work very closely with our OB and maternal fetal medicine colleagues. So how to refer, if you are part of the EPIC network, it's ambulatory referral to cardiology, TOH or Heart Institute service area, and just click on cardio-obstetrics. So this is a long laundry list of cardiac conditions that we do see. It's pretty broad strokes. So we're quite, we do see pretty much almost everything. The Canadian Journal of Cardiology in this issue, in their supplemental material, has actually a list of Canadian cardio-obstetric programs across the country. So if patients don't live in Ottawa and its surrounding areas, there are other places within the country where patients can be referred for management of pregnancy-related heart disease or heart issues in pregnancy. So that's there. Now, postpartum, there are some clinics specifically aimed at reducing postpartum risk for the hypertensive disorders of pregnancy I mentioned. So our cardiac rehab program here, we actually have a program that's specifically dedicated for this purpose called the Cardio Prevent program. And here are a few across the country. There actually aren't many. And the hope is that, over time, as greater awareness, as the awareness about postpartum cardiovascular risk increases, more of these programs will be set up so that patients can have access. So in Alberta, there's the postpartum preeclampsia clinic. In Ontario, we have 3. So Kingston has a maternal health clinic. Ottawa has our Women's Heart Health Institute, obviously. And a part of that is the cardiac rehab cardio prevent program. There's actually also the internal medicine postpartum vascular disorders clinic at the Ottawa Hospital for women who may need a bit more nuanced care and may have things beyond hypertension and gestational diabetes to address. And in Montreal, there's the Maternal Cardiovascular Health Clinic as well, and the contact information of all of those clinics is up there. There are also educational modules that are put together by the Canadian Women's Heart Health Association, and these are up there. And for more resources, you can visit the website of the Canadian Women's Heart Health Association, cwwh.ca. And there are other self-learning modules with a QR code up there if you're looking for more information. So thank you very much for your attention. That concludes my presentation today, and I'll take any questions you have.
Thank you, Dr. Garuba. Kristy, do you have one from online?
Yes, one of our online questions is, Wolff-Parkinson-White syndrome an increased risk for pregnancy?
I would say it depends. It depends on whether, so just for those in the audience who don't know what that is, so Wolff-Parkinson-White is a an abnormality in the heart that increases the risk of arrhythmias. So it's a sort of an extra channel, an extra channel that exists within the heart that can conduct electricity at very fast speeds. Is there a risk in pregnancy? So potentially, because in general, the second trimester onwards increases the risk of arrhythmias in pregnancy. If you have a pre-existing arrhythmia, it can actually get worse during pregnancy. So there is some associated increased risk. How we manage that, medication, other ways, and we would recommend specific monitoring that's needed around the time of labor and delivery. But yes, there is a slightly increased risk that the arrhythmias could be triggered during pregnancy. Go ahead.
Another online question. Are there risks associated with contraceptives in the long term after the contraceptive has been stopped or removed?
So is there risk associated with the contraceptive? Is there risk associated with having used it once it's been stopped?
Yes, I believe.
Is there cardiac risk associated with it? Potentially, but usually within the first year. And I actually have to say it depends on what contraceptive, because there are some that wear out, within a month or two of having been stopped. But there are some like Depo-Provera, which is an injectable progesterone, where the contraceptive effects last for 8 months up to a year after the injection has been given, and there's still circulating hormone in your system. So for contraceptives like that, yes, there is still ongoing risk, potentially long after the contraceptive has been discontinued.
Do we have any other questions from in the room or online?
Dr. Mesana has
Oh,
one.
Dr. Mesana.
Very much.
Yeah, sorry. So thanks a lot for your work and taking over the clinic, and it's very exciting to see you at this level. So I have a question. So maybe it's a stupid question. Is there any correlation between life expectancy and the number of children that a woman bears? My grandmother seems to say that the more you have babies, the longer you're gonna live. That's it. She died a long time ago.
Yeah, that's interesting. So while I don't know that the actual number of children, but certainly there are certain cardiac conditions which women may be at risk of, depending on the number of pregnancies that they have, or the number of, I should say, fetuses they're carrying with that one pregnancy. And as well, there are certain things that women are at risk of never having been pregnant at all, and this being their first pregnancy. So I've always wondered about that. Preeclampsia, for instance, there's an increased risk in women for whom that is their first pregnancy, which is really shocking and alarming. If people knew that, they might never even want to get pregnant in the first place. And things like peripartum cardiomyopathy, so heart failure in pregnancy, there's an increased risk if you're carrying multiples. There's also an increased risk of preeclampsia if you're carrying multiples. So while the total number you've ever had in your lifetime, I'm not certain. Certainly the number being carried within that particular moment does carry increased risk. Yeah. That's a good question. I'll look it up to see how, I don't want to contradict a grandmother though. I don't know.
No, it's just to initiate the question.
Questions? Thank you very much, Dr. Garuba. Okay, before our coffee break, I'd like to introduce Kara Murfitt to talk to us about the education of women's heart health here at the Heart Institute. Kara is a seasoned nurse educator in our cardiology and cardiac surgery inpatient units, who has been instrumental in the development and rollout of staff education in women's heart health.
Hi, everyone. And like Stephanie said, I'm one of the nurse educators here at the Heart Institute, and I was asked to speak to you about some of the educational developments we have done here at the Heart Institute for staff with regards to women's heart health. And some of the amazing initiatives that the staff have taken upon themselves as well for their colleagues and for their patients. So cardiovascular disease is the #1 killer of women over the age of 35 worldwide, and yet there remains a lack of education surrounding women's cardiovascular health. A literature review conducted by the University of Ottawa Heart Institute Women's Heart Health Alliance found that there were very few educational initiatives on the topic of women's heart health and even fewer geared towards nurses and allied health professionals. Acknowledging this lack of educational opportunities for healthcare professionals was the impetus for us for developing days such as these. And I am proud to say that this is our second annual Women's Heart Health Education Day. So thank you for coming, and the response has been amazing. There's many of you guys here in the audience, and there's many, many more online. So it's been great. So what else have we done to bridge this gap to ensure we are providing high quality care to women with heart disease? Back in October, as part of our nursing rounds, Nazli Parast, who is our APN for the Women's Heart Health Clinic, and Nadine Elias, the manager for Women at Heart program, did a presentation for the staff here at the Heart Institute on why and how heart disease is different in women and some of the services that the Canadian Women's Heart Health Centre offers. It was a very informative day. All the staff were welcomed, and it was recorded for those who were not able to attend. The other thing we did was, again in October, we recruited and trained approximately 30 staff, both nurses and allied health, and we recruited them to be women's heart health champions for their area of work and their unit. We also opened this up to the regional centers as well to ensure that we had champions sort of across different centers. As the lead for the Women's Heart Health Champions, Nazli put on an education day that provided information and the tools and resources that these champions would need to be champions on their unit and to pass along the information to their colleagues. That day included lived experiences by our patient partners. They talked about the importance of a champion role on their units, and they even allowed some time for brainstorming on how they can promote change in their area of work. And I have to say that since that education day, the champions have not disappointed. They've been very hard at work. Here's some pictures of that day. So we have you can't see it, but the big picture is the education day for the champions. And the one to your left at the top corner there is also a picture of all the champions. So some of the initiatives that they started to do was in the Cardiac Rehabilitation and Prevention Center, that team is working on a program called Introduction to SCAD. And it's a program to help ensure that their patients are receiving standardized information and standardized care. They're revamping one of their sorry, I'm missing the word, the satisfaction survey, sorry. They're revamping one of their satisfaction surveys to include some more questions related to the SCAD patient. They are also making sure that staff have the information and knowledge that they need to understand and care for these patients with SCAD. The other picture I want to show you is the one on the bottom left there, and that is an education board that one of our champions on H3, she put together. So H3 is one of our inpatient cardiac surgery and cardiology wards. And she put this board together so that patients and family and staff as well could take a look and take some information home with them and educate themselves. So it's a really good example of an accessible way to disseminate the key points to women's heart health. The other one I wanted to mention also, though, before I get into the women's heart health sway, is the cardiac imaging nurses have also started an initiative down in their unit. And the objectives of this initiative are to develop and implement a more comprehensive standardized nursing assessment of female-specific cardiovascular disease risk factors for these patients undergoing cardiac CT scans, and to educate and raise awareness of the risk factors with these patients. Two of these nurses are actually going to be talking to you later this morning on this, so I'm not going to get into any more information on that because I don't want to give any spoilers away. But the last thing I do want to tell you about is the women's heart health sway that we have developed. So this is a learning module that we created. It was launched in June of 2023. And so we first decided to launch into newly hired nurses. So as part of the orientation package, the educators provide the link to this SWAY, which is the platform that we use to create this learning module. And so we send it out to the orientees as part of a supplementary self-directed learning. And there is a quiz that is embedded into this SWAY as part of the learning experience. And we also asked the champions during their education day if they could review it and provide feedback for us. So they did, and we made the changes that they suggested. And I'm happy to say that this SWAY is now available to everybody. It is posted on our Heart Institute website as well as the Heart Hub for those of you who are staff of the Heart Institute. And for those of you outside of the Heart Institute, the QR code is there on the screen. It is also posted throughout the room. And so please feel free, scan it, learn from it, use it, and our point and what we want to do is we want to provide some accessible educational opportunities and ongoing learning for everybody so that we can all bring forth knowledge and understanding of women's heart health to those.
All right, so it is my pleasure to introduce our next speaker, Dr. Jodi Heshka. Dr. Jodi Heshka is an internal physician specializing in hypertension, diabetes, dyslipidemia, and general cardiology. She practices here at the Ottawa Cardiovascular Center as well as the Heart Institute, participating in the Women's Heart Health Clinic, hypertension, and aorta clinics. And she really brings a wealth of knowledge to our topic today, and she'll be talking about diabetes in women. So welcome, Dr. Heshka.
Good morning, everybody. Thank you for having me. I'm very excited to be here. It's always nice to be with a bunch of other women and a few men. I see everybody sort of snacking away on their pastries. Don't worry, no judgment. Everything in moderation, so it's all good. Okay, so I'm going to talk to you a little bit today about diabetes in women. As you can imagine, this is a huge topic. So we're barely going to skim the surface today, but hopefully I'll send you away with a few take-home key points. And probably the first thing to realize is how much we really don't know about diabetes in women. Unfortunately, a lot of the data originally was derived from men, of course. And research looking specifically at diabetes in women is still lacking, but is growing. So as you're going to hear today, heart disease in women is understudied, underdiagnosed, undertreated, undersupported, and in general, people are underaware. Diabetes is no different. So when it comes to diabetes, again, women, as I mentioned, are understudied, in particular with the way that their risk factors and lifetime hormonal changes affect the development of diabetes, the risk factors for diabetes, and the treatment of diabetes. And again, we're underdiagnosed, we're undertreated, undersupported, and generally speaking, underaware. So it might sound trite to say this, it might seem quite obvious, but a woman's risk for cardiometabolic disease starts in the womb. Our X chromosomes, our sex hormones, our genes interact with our environment and psycho-socio-cultural factors to determine our own individual cardiometabolic pathophysiology, to determine our clinical presentation of cardiometabolic disease, and our response to therapy. So not surprisingly, our female hormones affect diabetes. Female hormones play a role in energy metabolism, body composition, vascular function, and inflammatory responses. And together, these are what lead to the development and management of diabetes and obesity, as well as the development of micro and macrovascular complications of diabetes. One of our two female hormones, estrogen, is well known to enhance insulin sensitivity and reduce hepatic gluconeogenesis. So not surprisingly, the converse, or estrogen deficiency, plays a big role in insulin resistance. Insulin resistance, of course, has a number of downstream effects that overall significantly impact the development of cardiometabolic disease, whether it's at the level of the pancreatic beta cell in terms of impaired insulin secretion, reduced glucose uptake in the muscles, changes in the liver pertaining to glucose metabolism and lipid metabolism, and at the level of the adipose tissue, where insulin resistance increases lipolysis, adipocyte size, and inflammation. We now know that obesity and adipose tissue is a powerful, powerful inflammatory risk factor. So there are gender differences when it comes to type 2 diabetes that we don't fully understand. These gender differences pertain to our risk factors, our risk predisposition, the clinical features that might be present at the time of diagnosis, as well as psychosocial factors, and ultimately the way in which we manage women with diabetes. If we look a little bit closer at some of the ways that women differ from men in terms of diabetes, we know that although men present younger with type 2 diabetes and might have diabetes for a longer period of time, women develop type 2 diabetes at older ages and at higher BMIs. And as a result, they have a much higher risk factor burden because by the time they're being diagnosed or presenting with diabetes, often they've got concomitant obesity, hypertension, cardiovascular comorbidities, et cetera, et cetera. And so you can see how the risk factor burden is much higher. Women, of course, go through hormone changes throughout the course of our lives, from periods to puberty to menopause and so on and so forth. With menopause, we lose fat, we gain fat and lose muscle and bone mass. And this has been associated with higher mortality risk in women with type 2 diabetes. And this risk is much higher in women than it is in men who have a similar BMI. With menopause, our fat distribution changes. It tends to become more android or more apple-shaped and less pear-shaped. And we know that that apple-shaped body habitus is a significant cardiovascular risk factor. We also know that unlike in men, where testosterone can be very beneficial in terms of cardiometabolic health, in women, androgen excess actually increases the risk of developing type 2 diabetes and cardiovascular disease. We see this in the very well-known condition of androgen excess, which is PCOS. So women with polycystic ovarian syndrome have elevated androgen levels, and they have an up to 4-fold increased risk of glucose abnormalities. Because these women tend to develop PCOS when they're young, these glucose abnormalities also develop very young. So there's a high lifetime burden of disease. As well, women who have non-alcoholic fatty liver disease, which can occur with or without diabetes, have a much higher chance of developing type 2 diabetes, particularly if they're young and have non-alcoholic fatty liver disease. And this is a scenario that doesn't really seem to be as strong in men. So what about gestational diabetes, which is the only diabetes condition that affects women? Well, I think it's really important to recognize that gestational diabetes is a chronic cardiometabolic disorder. It is not just glucose intolerance in pregnancy. There are often beta cell abnormalities, insulin resistance that predate the development of gestational diabetes and follow the resolution of gestational diabetes. Gestational diabetes identifies a woman who is at very high lifetime risk of cardiometabolic disease. What do I mean when I say cardiometabolic disease? Do I mean just developing hypertension or diabetes? No, I mean this woman is at very high risk of developing heart failure, heart attack, stroke, atrial fibrillation, to name a few. Yet, our care for many women with gestational diabetes ends when the baby's born. So you can see here, this is how gestational diabetes, along with hypertensive complications of pregnancy, can be correlated or interrelated with a number of other cardiometabolic diseases. You're going to hear more today about hypertensive disorders of pregnancy and some of the other unique cardiac diseases that affect women. Up to 11% of pregnant women will develop gestational diabetes. 20 to 30% of women with GDM will develop type 2 diabetes within 5 years. Women with previous gestational diabetes have been shown to have higher carotid intima media thickness. So this is the plaque accumulation in the carotid arteries. They're found to have higher or more abnormal levels of endothelial function, increased epicardial fat thickness. And these are just some of the ways that we think that women with gestational diabetes are at increased cardiovascular risk. Something that is also more unique to women is the fact that we are more affected by psychosocial factors, and in particular when it comes to type 2 diabetes. So for us, low levels of education, socioeconomic status, occupational status, income levels all more strongly correlate with developing type 2 diabetes than they do in men. Night shifts, interestingly, have been shown to increase with risk of diabetes in women. This is not seen in men. Physical inactivity increases anxiety and depression with stronger effects in women as compared to men. This, in turn, has been clearly shown to reduce self-care and adherence to medical therapy, two things that are cornerstone to managing diabetes. Women with prediabetes and diabetes, as I mentioned, have more endothelial dysfunction, more fibrinolysis than compared to euglycemic women. This difference is not seen in men. And obese women with diabetes have impaired endothelium-dependent vasodilation, again, a difference that is not seen in men. This is why evidence has shown, or one of the reasons we hypothesize why evidence has shown time and time again that the relative risk for a woman compared to a man of developing coronary artery disease and fatal coronary artery disease is much higher. Diabetes can also affect the structure of the heart. So insulin resistance correlates very nicely with LV mass. And this seems to be stronger in women than in men. Postmenopausal hormonal changes also may play a role. Women with type 2 diabetes and obesity significantly have higher LVH or greater LVH, and LVH in and of itself, left ventricular hypertrophy, is independently associated with congestive heart failure and CV mortality in women. Finally, there's the effect of diabetes on heart failure and a woman's risk of getting heart failure. So among all the risk factors for heart failure in women, be it diabetes, atrial fibrillation, MI, kidney disease, hypertension, obesity, smoking, left bundle branch block, diabetes is by far the strongest predictor. There is a 5-fold increased risk of developing heart failure in a woman with diabetes than there is in a man with diabetes, where the risk is only 2-fold increase. Also, women who have diabetes progress faster along the heart failure continuum and are more likely to develop heart failure at young ages. And of course, women are more likely to have heart failure with preserved ejection fraction, which is a quintessential cardiometabolic disease, than they are to have heart failure with reduced ejection fraction, although certainly they obviously can get both. So when it comes to managing women with diabetes, we need to start by recognizing that depression, anxiety, and eating disorders are very prevalent in women with diabetes, and this affects care. They tend to have neuropathy, particularly gastroparesis, more than men do. They tend to have more vascular and renal damage, heart attack, heart failure, especially with preserved ejection fraction, and stroke. Yet despite this, women receive less intensive or aggressive care for diabetes, less treatment, and they more often than not don't get to target, or at least not as much as men tend to. There are differences when it comes to managing diabetes in women. So some of the differences include the fact that basal insulin may actually not be very protective when it or very useful when it comes to treating women with diabetes. There may actually be adverse cardiovascular outcomes with insulin use. Sulfonylureas increasingly probably should fall out of our toolbox when it comes to diabetes management. In particular, in women, they are associated with greater increases in weight gain and fluid retention. Because women tend to present with obesity as well as type 2 diabetes, GLP-1 receptor agonists perhaps should be first line, maybe even above metformin in managing these women because of their potent effects on both weight loss and glycemic control. Women are more prone to have side effects with metformin. Men tend to have fewer side effects and also tend to get more A1C reduction with metformin. SGLT2 inhibitors, of course, are cornerstone therapies in any patient with diabetes and cardiovascular disease, but don't forget that women do tend to have more side effects, namely genital urinary yeast infections. What about the management of diabetes using non-antihypoglycemic agents? So of course, whenever we're managing type 2 diabetes, we always want to make sure that we're controlling the cardiovascular risk factors. Well, it's important to know that statins have excellent evidence for benefit in both men and women, but interestingly, women may actually have greater reduction in coronary atheroma when they're treated with high-dose statins. Unfortunately, women frequently are not appropriately treated with statins. They are often written off as being statin intolerant whenever there's a perceived side effect. And more often than not, they also don't get re-challenged with different statins. ACE inhibitors may become less efficacious over time, so that's something to keep in mind when we're managing women who have diabetes and hypertension or chronic kidney disease. Women also tend to have more cough. With heart failure, we tend to use big doses of beta blockers. Interestingly, women seem to maintain a good survival benefit even with lower doses of beta blockers, and they tend to be better tolerated. And finally, in research that was done looking at ARNIs or Entresto and heart failure, there was, of course, the population of middle-aged women that, unlike men and other women, really did seem to benefit from treatment with ARNI, particularly with HFpEF. So, at the end of this all, we're here today to talk about what we can do. How can we help women with diabetes, and how can we prevent them from developing cardiovascular disease? So first of all, we can address psychosocial issues, particularly modifiable social factors that contribute to obesity and type 2 diabetes in women. We can find ways to encourage women to be more active. From the second that little girls get up and walking on their feet to the time they're 95 years old, we need to be encouraging women to move and be active. We need to enroll women in cardiometabolic rehabilitation programs, much like we have here at the Heart Institute. And we need to develop these programs, not just in amazing academic institutions like the Heart Institute, but at all levels of the community. We need to monitor women with prediabetes and diabetes much more closely, in particular around vulnerable times, so around pregnancy and in the perimenopausal period. We need to ensure that cardiac risk factors are well treated and that women get to target based on current guidelines and standards. And we need to continue to raise awareness and encourage education and research in cardiovascular disease and diabetes management in women. So I thank you for your time. I hope that's given you a little bit of insight into the world of diabetes in women.
Dr. Heshka. Oh, are there any questions online? Yeah.
So the first question, given the risk of heart failure in women living with diabetes, should we be ordering regular echoes as part of their diabetes management?
That is an excellent question, and that's one that is debated time and time and time again. Of course, there's obviously a cost to the system with ordering echoes, yet we don't currently have any guidelines guiding us on echoes. I think where we can start is by asking relevant questions, asking about shortness of breath, asking about exercise fatigue or stamina, and appreciate that any exercise intolerance, any shortness of breath should be investigated with an echocardiogram in a woman with diabetes. Right now, the evidence is still out as to whether or not the cost of the system is worth it. You can argue that the benefit to each woman is certainly there, but we don't have a lot of evidence to really support whether or not we should be doing that routinely, and if so, at what interval, and so on and so forth.
Thank you. The next question, are type 1 diabetic women at a higher risk than women with type 2 diabetes?
The evidence suggests that women with type 2 diabetes are at higher risk, likely because this is more of a true cardiometabolic illness, where there are often higher adipose tissue levels that promote inflammation. The nature of the illness, the pathophysiology is different. The comorbidities often are a little bit different. And so certainly the bulk of comorbidity does seem to be with type 2 diabetes. Not to say that obviously women with type 1 are at very high risk as well, but in a different way. And heart failure with preserved ejection fraction is very much a condition that goes hand in hand with diabetes, obesity, atrial fibrillation, that collection of comorbidities.
Thank you. Can you explain the link between basal insulin and the adverse cardiovascular effects in women?
Yeah, so there's been some research that has suggested that insulin can promote weight gain, and more than that, can promote salt and water retention. And we know that obviously weight gain and fluid retention have detrimental effects on cardiac structure and function.
Thank you for your presentation. You have mentioned in your presentation about the impact of night shifts.
Yes.
And as a nurse, for 27 years, I have a question. Was there any studies done on nurses comparing when they enter the profession and, like, let's say 2025 down the road, what kind of impact does it have on our heart health, diabetes?
Yeah, that's a good question. I'm not aware of any specific study looking exactly at, nurses starting their career and then ending. We do have a lot of data from the Nurses Health Study, which is a long-term study, a cohort study that's been done in the United States. And that's where a lot of this information, just in general, knowing that, or in general pertaining to night shifts in women, inadequate sleep, where some of that data supporting that link with cardiometabolic risk has come from. But in terms of, studies specifically looking at a woman with a nursing degree, I'm not sure.
Thank you.
But I think it's a very relevant question because nurses are doing night shifts.
I think we should make some suggestions for our wellness program.
Sure.
To include it part of the wellness promotion as well, and maybe offer nurses like free gym membership.
That's a great idea. I'll support that.
Thank you. Very great presentation. And I'm just wondering, is the treatment for women with gestational diabetes similar for the women with type 2 diabetes?
Yes and no. So of course, during pregnancy, many of the anti-hypoglycemic agents are contraindicated. So the cornerstone therapy for a woman with gestational diabetes is diet, lifestyle, some metformin, insulin. Those are pretty much the therapies that are used, unlike a woman with type 2 diabetes, where in my opinion, the emphasis should be also diet, lifestyle, insulin only if absolutely necessary, and really focusing on medications like metformin, GLP-1 receptor agonists, and SGLT2s. Those latter two can't be used in pregnancy.
Thank you.
Should PCOS become a statin-indicated condition after careful reproductive planning, of course?
I believe so. I treat my PCOS patients with statins. I'm fairly aggressive. I think it's a low-risk medication with high potential benefits. And I think when you think that this is a cardiac risk factor, we should be treating it as such, whether it's PCOS, diabetes, hypertension, chronic kidney disease, these all warrant statin therapy, in my opinion.
Another online question, how to treat or prevent fatty liver disease?
Yeah, so again, you know, there's pharmacologic and non-pharmacologic therapy. I'm a big advocate of non-pharmacologic therapy, so a heart-healthy diet, low in refined carbs, low in saturated fat, regular physical activity, working on achieving a healthy body weight. If that is insufficient to help prevent or slow the progression of non-alcoholic fatty liver disease, then, you know, really we're looking at treatment of dysglycemia, if there is any, treatment of dyslipidemia using statins, and GLP-1 receptor agonists like semaglutide have been shown to play a big role in treatment of this condition.
Yes, thank you for your presentation. I'm not certain what the statins are. I'm not medical, so I don't know what the statins are.
So cholesterol lowering medications. They're our #1 drug therapy for high cholesterol. We also use them not just in the treatment of isolated high cholesterol, but we use them in the prevention or risk reduction of cardiovascular disease.
Great presentation. What about compliance? Do you find women are easier, more compliant, less compliant? How do you find this? I would imagine better, but more compliant.
Yeah.
But is that really a difference? Do you feel?
Absolutely. Absolutely. Women tend to have more side effects with medications. So I think when it comes to doing a good job treating women in general, the therapeutic relationship is very, very important. So any time that's invested into that relationship is gonna serve you well in terms of helping these patients achieve their goals. In particular with diabetes medications, they tend to get a lot of weight gain with insulin, sulfonylureas. So being aware of that, being sensitive to that, being sympathetic to that, you know, if a woman is also struggling with obesity is very important. And really focusing on using therapies and lifestyle strategies that work with them within their unique home life, their unique needs, goals, is really important. When it comes to managing women in general, but I think women with diabetes, it needs to be highly, highly individualized, and that takes time and it takes sympathy.
Given the small risk of diabetes with statins, is there one that may have less risk for women?
Not really. And the risk with statins is small. It is there, but it is small. And I think, again, it's important to take a step back and look at the big picture. The very small increased risk in diabetes with statins certainly pales in comparison to the potential benefits of statin therapy. So it's always a matter of weighing risk benefits. And with statins, the evidence is pretty good for benefit.
Thank you. What would the target LDL be for women with diabetes, and how much statin is normally required and which one is preferred?
Yeah, so there's no, so first of all, the target for women with diabetes, assuming there's no heart disease, stroke, they haven't had a prior cardiovascular event, then the target is to have an LDL below 2. We will use pretty much any statin. So some statins are tolerated better than others, and even those can be very individual. You know, for women who need aggressive risk reduction or who are far from target, we tend to advocate using more potent statins because you get more bang for your buck. But certainly if there are issues with statin side effects or tolerability, then using gentler statins often are very well tolerated and often it can be used very easily in women who are previously labeled as being statin intolerant. So the big gun potent statins tend to be atorvastatin and rosuvastatin, or Crestor and Lipitor if you're using the brand name. And the gentler statins tend to be things like pravastatin, simvastatin.
Thank you. What is the typical follow-up for postpartum women after a diagnosis of gestational diabetes?
Again, that's a good question. And I don't think, and certainly my family medicine colleagues here in the audience could correct me if I'm wrong. I'm seeing women who are well advanced on the spectrum of cardiometabolic disease. I don't see patients who are relatively well, get gestational diabetes, and then go back to being relatively well again. So I think it differs depending on who you're seeing. I don't think there's probably a lot of consistency. I think it really depends on where you are. We're lucky here in Ottawa that we have a cardiometabolic program here at the Heart Institute where we welcome women who have a history of gestational diabetes so that we can talk to them about risk factors. And we follow them for a good period of time until we see that they're well on their way with education and lifestyle change and so on and so forth. At other levels, I'm not sure. And we know quite clearly that there are plenty of women who may or may not have an NP or a family doctor, who may or may not have a consistent obstetric follow-up postpartum. Many of these women would have euglycemia before, even though they might have beta cell dysfunction and so on. They get the gestational diabetes, it resolves at the time of delivery or shortly thereafter, and that's it. And I think that's a population where we really need to do a lot better. That's a key primary prevention population.
So much, Dr.
Oh, my pleasure. Yeah. Thank you.
Thank you to our audience for all those great questions. I think Dr. Heshka had a PowerPoint session, rapid fire there of questions. So thank you so much, everyone. I'm going to introduce our next speaker, Dr. Heather Tulloch. She's a clinical psychologist and scientist, and she works in our Department of Cardiac Rehabilitation. And today she'll be sharing about the effects of mental health on women and caring for the female patient with both heart and mind issues. So welcome, Dr. Tulloch.
So thank you. I feel like I'm starting the same way, which is we don't know a lot about women. Much of the research has been done on men, but I'm going to summarize it as well as I can for you. Of course, I have no conflicts. Or I shouldn't say of course, but I don't. The of course part is that we all have emotional reactions after there are, you have a new cardiovascular event or a diagnosis. Things like, women have told me that they feel fearful of another event. Sometimes they worry about doing strenuous activity. They're talking about changes in their identity and frustrations in changes to their lifestyle. Sometimes their stress, of course, was changes in work. They're not able to work potentially for a period of time, and that may cause some financial stress. They may also have stress related to caregiving. There was a study that actually asked men after they had a heart attack, what did they worry about? And they said worried about burden they put on their spouse. And when they asked women what they worried about taking care of others. So it's interesting, right? All the feelings and thoughts that come to a woman's mind after having a heart event. There's also some on the other side. So those ones were mainly sort of negative, but then there's also things like gratitude. So sometimes women will say, I just feel very appreciative of the care that I received. Or sometimes they feel relief because they say, I knew something was wrong and finally I have a diagnosis. And so there's just this gamut of emotions that sometimes, or that women will experience. And I think one of the take homes here today is that these feelings are normal. It is normal to have some emotion, right, after you've had a cardiovascular event. And so I think as healthcare providers, it's important to give that message because sometimes people will come into my office and go, but is it normal that I'm feeling this? Yes, the answer is yes. And that right there can help bring down some of that distress. So I'm going to talk about a couple patients. This first is Miss Y. She's an 80-year-old woman who was diagnosed with heart failure. Her husband passed away a couple years ago, and she does have adult children, but they don't live in town. And she's had more difficulty managing some of her household tasks. Her symptoms are getting a little bit worse, so she's struggling a bit more, and she's feeling alone and a bit depressed. And she said, you know, this morning I tried to finish off my laundry, then I cried a little bit. It was hopeless. I'm not capable of doing what I used to. Sometimes you just get fed up. I just ate what I wanted. I put salt on anything and I didn't care. And I'm sure, I mean, all of us have times this, maybe we don't have a diagnosis of heart failure, but there's times where we go, I don't care. I'm eating that chocolate or whatever it is. But certainly when you're feeling those symptoms, you do get frustrated and feel down at times. Just to make sure that we're all on the same page, you know, we all talk about feeling depressed at times or having a down day, but certainly a clinical depression or major depressive disorder is when you have at least one of these two symptoms, so depressed mood or a loss of interest in things that you typically enjoy, and then four of these other list of symptoms. And these things have to be there for at least a 2-week period for most of the day, nearly every day in that 2-week period. So when we talk about women with heart disease, we know that from the literature on prevalence that it's about 20 to 40%. Now that's a big, you know, gap there or range. Some of that is because how it's being measured. And so certainly there's questionnaires that are used. Sometimes people use a clinical interview. And so there's some variability because of that. But in one of the more large studies that was across 24 countries, they showed that about 31% of women, as compared to 20% of men, did have depression. And interestingly, the younger women did seem to be, or more of them seem to have these feelings than some of the older women. And I'm a psychologist, so I do not prescribe, and I'm really not a pill pusher. In fact, I might be the opposite. But it's interesting to me that in this study, only 2% of the women were prescribed antidepressants. Now, again, antidepressants is not necessarily the thing to give to everyone. What that tells me, though, is that providers, which typically, you know, in family practice, that's one of the quickest things that you can do. And you don't have to be on a big wait list to see a psychologist, for example. So if only 2% are getting that, think of the amount that are not getting any treatment, right, at all. Depression is, in fact, a predictor of poor cardiovascular outcomes, and there is a dose relationship. So the strongest association is when depression is chronic and severe. And unfortunately, women are more likely to have earlier onset, 2 times the number of episodes, and more severe depression. So that does place us in a higher risk of having either incident or recurrent events due to this link with depression. Now, speaking about depression, often I don't really speak a lot about suicide, but we certainly have had an increase in the number of patients that are talking about suicide since the pandemic. And certainly men are more successful, if that's the right word. They do more follow through and die by suicide than women. However, if you look in the sort of lower right quadrant, you can see that the number of women that are hospitalized for self-injurious or suicidal type behavior is a lot higher. And so it is quite relevant. And as I mentioned, during the pandemic, we did see a doubling of individuals talking about suicide. And so we just need to be alert to that. And I want to mention that you do not have to be a mental health expert to talk about suicide. Just like you don't have to be a cardiologist to do CPR, right? You just need to have a little bit of empathy, and you need to be able to just think about what are the links? How am I going to link this person to a person that might have more information and resources? That's really the goal. So that was depression. I'm going to move on now to Miss B. So she's a 35-year-old woman who had spontaneous coronary artery dissection. She continues to have some recurrent chest pain. She does have a history of anxiety, and as far as her social network, she's married, has 2 children, and she's working full time. And so she said, you know, I was under an extraordinary amount of stress. I was just wound up all the time. I just felt like something's going to break me. Something's got to give because this can't keep going on. And then it did. So I'm going to talk for a moment just about generalized anxiety. So that's when there's excessive worries about sort of your day-to-day things, and they can be difficult to control those worries. And I often talk about in our stress management class of like a little hamster on the wheel, and you just can't get him off at night when you're trying to get to sleep. So it starts to affect your sleep. And then, of course, when you're not sleeping well, you've got things like irritability and fatigue and difficulty concentrating. Now, there's also cardiac specific anxiety. So when you're worried specifically about your cardiac symptoms or potentially another event, and I'll talk a little bit about that, as well as trauma. So, and I'll follow up with those, but those are different types of anxiety. The literature on anxiety in the cardiovascular world is actually quite small, and the results are mixed. But still, what we have out there is showing that about 40% of women do endorse symptoms of anxiety, which is kind of a double that to men. The symptoms do tend to be the highest while you're in hospital or close to that, which makes sense, right? It's just happened. And then they do sort of come down over time. The one thing that we have to watch is that those that have really high scores do tend to actually get worse as opposed to better over time. And there have been some reviews that have looked at the link between anxiety, the various types, so whether it be PTSD, generalized anxiety, phobias, or panic, and that link to adverse events with cardiac disease. And we do see that there's about a 30% increase in cardiovascular incidents, as well as recurrent events. Now, one of the questions that I often get is, does the individuals who have non-obstructive cardiovascular disease compared to those that are more obstructive types, so like a SCAD versus someone that's had a heart attack due to blockages, whether they're more prone. And there's a little bit of evidence so far that's saying yes, although I think the jury is still out. Part of that is potentially because many of these patients, they haven't had any sort of health history in the past, so it's that much more of a shock and worries them. And also many of them are younger and they're taking care of families, which worries them. So I'm going to move down to Miss S, and she's a 60-year-old woman who survived a cardiac arrest. She has an ICD in place, and she's had shocks on 2 occasions. And she really has this intense fear of having another shock. She actually goes to bed with 2 phones, just in case one phone doesn't work, she can still call to get help with the other phone. She will not go out without her daughter in case something happens, in case she has another shock. And she said, you have this fear in hospital, but there's this bit of comfort that these people know what to do. Then you go home and then you have this whole numbing fear, stone cold fear. There's this residual anxiety, always alert for another shock. So now I will jump into the trauma part. And certainly, we all say sometimes, oh, I had PTSD from that. But really true PTSD, post-traumatic stress disorder, is when you have these conditions. So an exposure to an actual or threatened death, presence of intrusion symptoms, so things like, having flashbacks or distressing dreams, persistent avoidance, typically of something that reminds you of the event. And that's actually why some people don't want to come back to hospital, because it reminds them of that, or come to medical appointments. There's also negative changes in their mood or cognition. So sometimes, of course, there's fear, and also some inability to remember some of the events related to their cardiac event. And then changes in reactivity. Often patients will talk about sort of a really exaggerated startle response, or that they're always sort of on high alert. And all of these symptoms have to have occurred for at least a month. So we know that in the general population that about 10% of men, 10% of women and 4% of men have been diagnosed in their lifetime for PTSD. In the cardiac population, it's up to 30%, and it really does depend on the type of cardiac diagnosis or event, as well as the individual's history. For women in particular, there was a study that showed if they had just 4 of the symptoms, that it actually increased their risk by 60% of having another cardiovascular event. And just along those lines of trauma, certainly early childhood experiences do put individuals at risk, especially if those are happening before the age of 16. And there is sort of a large effect size that has been found for individuals that have had physical or sexual abuse in linking to their cardiovascular event. I will say that much of this is due to individuals in these circumstances do tend to have, or some will have lifestyle factors like, you know, smoking more, drinking more, that actually is linked to the heart health, not necessarily just the trauma. So this article actually tried to take all of these various psychological stressors and look at them combined and see how they're linked to adverse events for cardiac events. And what they found was in these 44 studies, they found that there was a 21% increased risk for women who had psychological distress for a major adverse cardiovascular event, and that 37% for men. So they said, well, men with psychological stress actually are at higher risk. So, I mean, for the women in the room, this is kind of good if this is true, right? For us, but sorry, for the men in the room, I'm just kidding. But, you know, I don't fully buy it because certainly most of the research, there's only 1 in 4 of the participants are women. And even in this meta-analysis I was just talking about, only 24% of the studies actually did sex and gender-based analyses. And so I think we just don't know yet, really. Because, of course, here's another study that showed the reverse, that for each unit increase in psychological distress, that there was actually a 44% increased risk for women, but not for men. So the jury's out. Now, where are all the links? Well, there's a number of them. And so I like this chart that sort of talks about some of the risk factors and how it affects some of our biological mechanisms. So, for example, pregnancy and postpartum, there's, of course, hormones that do sometimes dysregulate our autonomic nervous system and cause some inflammation, for example. And certainly, stressors affect many of our behaviors as well. Like I mentioned earlier, maybe smoking more or not exercising. Often women will say, well, I didn't have time. I had to take care of the family, so I didn't have time to get to the gym. So there's a number of factors that then feed into why women may be having these events and how it's linked to their psychological distress. So now that we know all that, we have to ask. But I have to say, I hope we look more like this than the last picture. But we have to screen. So one of the things, so this is a study, a review that actually looked at various screening measures for patients with heart failure in particular. But I'm going to highlight, and they do as well, the patient health questionnaire, the PHQ-9. This is something that we use here at the Heart Institute. And it's a really quick questionnaire that screens for depression. This is one that's recommended by the American Heart Association. I will note that there is a suicide item on here, so certainly do have some safety in place if you are providing this questionnaire. I recommend not doing it, you know, sending it to the patient at home and then following up a week later, right? You want to make sure that you're doing it in clinic. If there is some suicidal ideation, we do here at the Heart Institute, built into EPIC, with our suicide prevention policy, have what we call the .harm prev. So it's a smart phrase that actually pops up these questions. So if you are talking to a patient and you're thinking, oh my God, what do I ask? There they are. You don't have to think, and you can follow up with them. If you're not here at the Heart Institute, certainly there are things like the Columbia Suicide Rating Scale that there's actually an app. So if you, again, you have someone, you can have this on your phone and you can just be, you know, so again, you don't have to think in the stressful situation. For anxiety, what we use here is the Generalized Anxiety Disorder 7, so GAD-7. Again, it is more of a generalized as opposed to cardiac specific, but it does give us a sense on how women are feeling. And it does give you a bit of a sense of, okay, if they are in the mild range versus the severe range, maybe in the mild, we just do some watchful waiting, and in severe, we have to make sure that we do a referral. So speaking of referrals, now that we know all this, we don't want to screen and then do nothing. Yay, it's great we know that there's some distress, but we need to do something about it. To me, the first stop is cardiac rehab. Cardiac rehab has mental health benefits. And I kind of see a step care approach where cardiac rehab's the first place to start. You get them moving. Much of the time, all those normal feelings that I talked about right at the beginning do sort of subside, right? They're there with other patients, they get some education, they start to feel better. The problem is women are less likely to be referred, they have lower levels of program completion, and there's a number of barriers to their participation. Nonetheless, they do benefit. However, there's some recent research that shows that really gender-tailored programming does lead to greater reductions in distress like depression among women compared to some of the more traditional programs. And we are trying, and we've changed a number of things during COVID, and it's interesting, we've had more virtual options, and our rates of women participating have really increased, which is great. I will also say, though, do not delay a referral to cardiac rehab, because when there is delay, there is an increased risk for depressant symptoms among women in particular. So that's cardiac rehab. Now, if we're going to talk about psychological interventions, there's been a number of meta-analyses that have shown that doing a psychological intervention does decrease things like depression and anxiety. And there's actually some evidence that shows that there's some reductions in revascularizations or recurrent events, as well as cardiac mortality. The problem with a number of these, studies that have combined all these studies together is that the provider is varied. So we don't really know who's the best person to be doing this. The intervention content can be anything from, I met with you once to help you do some breathing, to a full 1 year, cognitive behavior therapy, luxury intervention. So it is hard to say. Plus, on top of that, they don't do a lot of sex and gender-based analyses. So in my lab, and I think Stephanie's here, there she is, wave Stephanie. We did a scoping review where we looked at the published studies in the last 20 years for women with heart disease, looking at the outcomes of depression, anxiety, and stress. And we found 8 randomized controlled trials. So only 8 studies, but at least it's something. It was better than it was a year ago or a couple of years ago when I did this. But what we found was for depression, there were 7 studies that measured changes in depression. And there were, again, quite a variety of different types of interventions. Some was cognitive behavior therapy. Others were more behavioral, where they were doing sort of like SMART goals and that sort of thing. And then things like meditation and relaxation techniques. However, only 2 of these studies out of the 7 had positive results. And the ones that seemed to be the most sort of successful were those that had cognitive behavior therapy, motivational interviewing, given by a clinical psychologist or a clinical nurse specialized trained in mental health. So that's depression. For anxiety, there were only 3 studies that actually looked at anxiety, and they used things like mindfulness, as well as a virtual reality condition where they actually had this virtual reality where they would go into this reality where they were coloring those, what are they called, mandalas, those really pretty pictures, and then another one where it was more behaviorally based with a nurse. But only one of those had really positive results, and it was the mindfulness. Unfortunately, we don't know who delivered the mindfulness, but we know that that strategy was successful. And then finally, for stress, there were 4 studies that looked at stress. 3 out of 4 actually did well. So, and again, it was sort of various types of intervention, whether it was cognitive behavioral, different behavioral sort of self-management stuff, or meditation. And there was everything from a health education or peer leader to nurse to the computer doing the virtual reality. So what did we conclude? Well, it was really hard, quite frankly, to conclude. What I'm taking right now is that, stress management, because it tends to not be at a clinical level, it's stress, we all have it, just providing different strategies, whether it be cognitive behavioral, whether it be some more behavioral things, or whether it be, relaxation or mindfulness, a lot of these things will help. For anxiety, looks like mindfulness is the thing at the moment, but again, there's some limitations. And then depression, the one that seemed to be most helpful is CBT. I struggle when I say this out loud. You can see me sort of being uncomfortable as I say it, because many of the studies were comparing to cardiac rehab traditional. So it's like, well, if they're both sort of improving, maybe cardiac rehab is really great too. So the jury, I've said that probably 3 times now, is still out. And there are some limitations, as I mentioned. Many of the studies were older, many had small sample size, one only had 15 women in it. Many did not even report on ethnicity, only the ones from the US did, and they were mainly white women, so how does that translate to others? And only one actually included individuals with mental health expertise. So we need to do more research. So you're probably thinking, what can I do, right? This is all great, all the research, la, la, la. What can I do? So what I say is please try and get a really standardized screening protocol into your clinics. I think it's really important to screen, and you doing that right into your medical record is most helpful, because then it sort of pops up and you think about it. When there's so many things coming at you, you don't always think about it. And then, of course, have a nice triage algorithm where you say, okay, if they're in this sort of zone, then this is where I'm going to put them, or this is where I'm going to suggest to them. And so then, of course, refer to treatment and create this list. I always say, have a list in your back pocket. People don't have time, obviously, to intervene and do a full, 1 hour session as a psychologist might. But if you have a list that you can say, hey, here's some things that you can do, which I'll go through a few things right now. So some of the resources. The first one that has actually come out of COVID is Access MHA. How many people here have heard of this? Okay, just a few. All right. So this now is being sort of sold as the one-stop shop where patients can actually go online themselves, fill out a form, and they'll get a call back from sort of an intake worker with some training in mental health, and they will go through what the concerns are. So if a patient has, my mom has dementia and I need to know some resources on how to help, you can call, they will give you some direction. So it helps you navigate. Or if it's for yourself, I feel like I'm down and depressed. It's overwhelming. I don't even know where to start. Then they can help you sort of navigate. So that's number one. The resources here at the Heart Institute, we have a stress management program. So it's a 6 weeks program. We do it both virtually and in person. And what we do is it's really an introduction. I call it the buffet of techniques, where we give them a little bit of a taste of various, breathing techniques, mindfulness techniques, and then they see what fits for them. I say, take what you like and leave the rest. And then you can go and look at this further. So if it's mindfulness that they like, well, then they can go do the 8-week program of mindfulness later. Managing emotions, that is sort of one step up now, where we use a lot of those stress management techniques, but it's a 9-week program mainly for individuals that have cardiac-related anxiety, and we really use that cognitive behavioral therapy to help address so their thoughts, their emotions, and what they're doing to really try and help them cope better with those concerns. There's also a number of patient support groups. I think peer support is really important, and we do have a number of nurse-led interventions here, or education programs. So we've got education classes, we have our women's heart clinic, which Nazli has been running. We've got our heart failure support, we've got our ICD support, and there's also our patient alumni, which was very active before and seems to, I think, to be getting going again, which typically provides some, some education, but also just a chance for patients to connect with each other. I won't talk too much about Women at Heart because they'll be talking later, but certainly there's a peer support program. I'm like waiting, I can't wait to get some of the data from the randomized controlled trial that they're doing, but certainly there's some promising preliminary data for this peer-led program. Then just some other resources that we have on our website that I'd like to highlight. One is our top 10 tips for emotional health. We have a top 10 tips for healthy sleep, one for stress management, and then there's others for exercise, healthy eating, etc. So you can just Google in at the Heart Institute to find these that you can just hand out to patients. There's also some other self-management workbooks that are free online. So if individuals, now this is more for individuals who have sort of mild to moderate. Often when they're more moderate to higher moderate to severe, it's more difficult for them to do some of these self-management sort of workbooks, but they are available. There's also some other online resources that we have. Certainly, there's Anxiety Canada has some free CBT interventions. Kelty's Key, which comes out of BC, has some free self-management. And if you actually live in BC, you actually get also contact with a counselor. And then, I was talking about the mindfulness earlier. There is a free 8-week mindfulness program for individuals if they want to do it online. It's fairly low budget, but it is structured and it provides the training as it is. There's other things in the city that are at a cost, but that's one option. Just a quick note about suicide. We do have this new 988. Has anyone heard of this yet? Excellent. Okay, so just like 911, we've got 988. And we also have the mobile crisis team here in Ottawa. So certainly if you feel like someone is in crisis, then you can put in a referral right through Epic. So if it's an individual that's here with us, then you can put in an ambulatory care referral to psychiatry and click off the mobile crisis team. And that is where I will end. But I have to always say, if we need to treat the heart, but we also need to nurture the mind. Thank you.
So much, Dr. Tulloch. Are there any questions from the audience or chat? Yeah.
How do patients from other hospitals access these support groups? Is it a self-referral versus a physician order?
So it kind of depends on which one. So if we're talking about the stress management and managing emotions that we offer here through our psychosocial services, you do need a referral from an internal person, cardiologist, nurse, etc., that goes either to our cardiac rehab program and then accesses psychology services or directly through their cardiologist. If a patient is from outside, but they want to be referred to cardiac rehab, they can do that. And then we have sort of a triage algorithm in there to see whether the resources are available. Everything else, though, is sort of accessible online, and I'm happy to share these things later. So if people want to look back and pull out any of the resources. Yes. Hi, Helen.
And just wondering if you could comment a little bit on going back to the cardiac rehab. You said get them in early, gets them moving. Can you just comment on whether you would suggest that for all heart patients, like all female heart patients, or would you treat the people who have like those younger, healthier MINOCA type patients like SCAD? Would you have the same advice?
That's an excellent question. I don't think we know, but I'll speculate a little bit. I think we have now some good programs that address the various groups. So maybe in the past when it was very traditional and some of these younger patients felt out of place, like, geez, this guy's talking about golfing and I'm like trying to run after my 2-year-old, and it actually might have made them feel a little bit worse. But I think now we actually have some good programming where, we have one of the physiotherapists, for example, that tends to do the intakes with the majority of the SCAD patients and really addresses some of their individual concerns. Therefore, I think earlier is better. Absolutely.
Thank you.
Great
That's the
question.
answer I wanted to hear.
Yeah. She didn't tell me that before, by the way. Yeah.
Hello. I was just wondering, for the consult to the mobile crisis team, is that something nurses can initiate, or do we have to get a referral from a physician?
No, it's wonderful. You can do it. Anyone on the team can actually do it. Yeah. And you can actually, if you need to, even just give them a call just to kind of feel out whether it's something that you should be putting in or not. They will actually take your call as well. So, yeah. Great. All right. Well, thank you, everyone.
Okay, our next presenter is Vicki Skinner and Christine Brewer. Vicki and Christine are both nurses in the cardiac imaging department. They will present their Women's Heart Health Quality Initiative with female patients undergoing cardiac CT. Welcome.
Good morning, I'm Vicki Skinner. I'm a registered nurse here at the Ottawa Heart Institute. I have no conflicts to disclose. My experience is 30 years plus a nurse here. My background includes obstetrics, vascular, cardiac, surgery, and cardiology. My most work experience is in diagnostic imaging at the CT scanner. And the only disclosure I have to disclose, I guess, is I'm passionate about women's heart health.
I'm Christine Brewer. I'm also a registered nurse that works here at the Ottawa Heart Institute. My past experience includes ICU, emergency, CCU here in the Heart Institute, and most recently down in diagnostics at the Heart Institute.
There we go.
Our initiative began in the fall of 2022 at the Women's Heart Health Education Day that was here at the Ottawa Heart Institute. Our staff attended it and we took home that we are indeed understudied. What's all those four things that I wrote down?
Just read it.
Under treatment, under awareness, under supported. Lots of anxiety out there among women, and it's all in our head and stress. So we decided to undergo an initiative. Women have a unique, non-traditional risk factors, such as gestational diabetes, preeclampsia, pregnancy-induced hypertension, depression, breast cancer with radiation treatment, and autoimmune diseases such as lupus. Heart disease is the #1 killer fatality among women, and yet there is significant knowledge gaps about these risk factors. So we decided to take charge and launch a quality initiative project to bring our questions forth during our interview.
So to begin the process, we did a literature review of non-traditional cardiovascular risk factors for female patients, which was basically looking at, we did an environmental scan of other facilities and their cardiac diagnostic programs to see what their nursing tools, what they were assessing for. We found at the time that there was limited assessment tools focused on cardiovascular risk factors for women.
We did a team collaboration. We collaborate with many team members within the Heart Institute, cardiologists, the Women's Heart Health Clinic, our healthcare experts, psychologists, and our DI team about ideas how to improve practice in our clinical setting about women's heart health. We received lots of feedback from our team, and eventually we developed a QI project, which is a quality initiative. Our quality initiative objectives include to develop a more comprehensive standardized nursing assessment of the female Pacific cardiovascular risk factors in the cardiac community tomography interview, to share the practice, to share with these patients the women's heart health education materials, and to teach them about the female Pacific cardiovascular risk factors. We also created and implemented a patient survey. The planning of this project took many months. We have reached our goals. We developed a nursing assessment question and patient survey that we give out during our interview. The engagement of the patients partners through our focus group, and an application for the QI project was submitted, and an application for the research REB board that was a QI project. We finalizing the nursing assessment questions and the patient surveys and the women's heart health resources. Our education day was training for the DI nurses about the Women's Heart Health Project with Dr. Krosler and Nazli Parast. Making it happen, we registered our QI project within the University of Ottawa Heart Institute, and we sent documents off to the ethics to review.
So we ran a focus group where we did a focus group panel with a group of our patient partners for their input on their initiative. We went over what our questions were going to be. We received input on the questions to be asked during the interview prior to CT scan. We made changes in the way that we were asking our questions and the questionnaires based on their feedback.
So our sample questions that were asked during the interview to obtain data include their traditional risk factors, if they had smoking or genetics, depression, and we also included our non-traditional risk factors for women, your pregnancy history, gestational diabetes, anxiety, depression, breast cancer, treated with radiation, and lupus. At the end, we also, of our interview, we give the patient a survey to fill out, and it's patient-friendly, easy awareness survey, and it's easy to understand. Our sample questions are up there. We got good results from them, and our key objective was take away from the interview is to empower our patient with knowledge.
So we did a diagnostic staff in education day and prepared for our quality project. Dr. Crozer and Nazli held an in-person in-service where we educated about our women's heart health, cardiovascular disease. We did peer-to-peer training where we taught the other nurses how to use our nursing assessment tool, how to ask the questions specifically, and also how to document all this in EPIC. So we did receive some printed handbooks from the Women's Heart Health Clinic in English and in French, and the Women's Heart Health Clinic webinar information handouts. We also printed out our patient surveys in English and French to be given to the patients after the procedure. And the rollout of our quality initiative happened June 1st at 2023. And this is some of the data that we have gathered after our rollout of our quality improvement project. So this is a 6-month review of our nursing assessment as documented in EPIC. There's a lot of numbers up here. The big thing to take away from this is the percentage of female CT patients, which is on the 3rd line down, and it goes across 6 months. And you can see we're capturing about 50% of our patients are female. So that is a lot of people that we're educating about this. This is the most common female reported non-traditional risk factors at 3 months and at 6 months. And you can see that we're capturing a fair amount of people are screening for at least some non-traditional risk factors at 3 months and 6 months. I like this one actually a little bit better because it shows that across the 6 months, we're capturing at least one, and if not two, non-traditional risk factors for women in all of our patients. There is a small subset of not documented, which you'll see to my right, her right. And that's just mostly just learning, a learning curve and things not being charted in EPIC. So that's an ongoing issue that we're trying to correct. So the additional nursing assessment questions are capturing the patient-reported non-traditional risk factors. We're capturing about 14 to 20% of patients monthly are screening for at least one non-traditional risk factor. So that's a lot of patients. The limitations of our data, like I said, some of the fields aren't always being documented on an EPIC, and that's just a learning curve on, new documentation, which we're working on. So we did do patient survey responses as well. After we were screening all the women for CT, we gave them our little survey. Total number of survey responses were 157. Again, the big takeaway from this screen, because this is before your appointment visit, were you aware of some of the risk factors that increase the possibility of heart disease in women? And the light green not aware and also somewhat aware is a fairly big subset of people of women that were not aware of the non-traditional risk factors. So that's a lot of people that receive some really good education about all of our resources and non-traditional risk factors. So that's a lot of people. And also the next question before your appointment visit, how aware were you of the resources in the Ottawa Heart Institute, which then again, like the not aware is over 50% of not aware about the Women's Heart Health Clinic, which is super important that these women know this information going forward because there's lots of great resources online. And also this one makes me super happy because it says this is the following your appointment visit, how likely they are to review the education booklet and seek further resources. And the extremely likely is at a little bit over 50%, which makes me super happy that people are interested in getting this information and empowering themselves with this. And also, this makes me really happy too, because following the appointment visit, how confident do you feel about talking to your primary care provider about your cardiac risk factors? And people put 43 and 45% as confident, are very confident that they were going to take this information and talk about it with their primary care provider. So the survey data, as a summary, did show that most females had limited self-awareness of their overall risk factors, as well as the resources here at the University of Ottawa Heart Institute. Survey data showed education intervention to be positive for the patient, and that most female patients, about 80%, were likely to review the booklet that we suggested and other women's heart health resources, and that the majority of the female patients felt very confident going forward that they were going to speak to their primary care provider about their risk factors. And the limitations of the survey data, as always, collection of surveys were not always done consistently in the last couple months, but that's something that we're working on going forward.
Our next steps is to continue our pilot data collection until about June of this year. We did a French translation of the nursing assessment questions, so we're bilingual. We included the QI project as part of the University of Ottawa Quality Improvement Plan to showcase what the Women's Heart Health Clinic work has done in DI. We have we're developing a manuscript to share with the outcomes of the Diagnostic Imaging QI project. And our big future is to do an external pilot of the region, like cardiology regional imaging rounds, to present our information and the questions forth. So why do we keep doing this? Our goal is to develop, to educate, empower women to learn the information and take forward to the referring practitioner about their cardiovascular health.
And we thought we'd end our presentation with a really great quote from Jade and Goodall, and it really encompasses why we keep doing this. And it says, what you do makes a difference, and you have to decide what kind of difference you want to make. Thank you very much.
Thanks.
Do we have any questions?
Thanks. I have a comment, a call to action, and a question.
Okay.
Yeah, my comment is congratulations. This has been a great project. And congratulations also on being accepted to do national conference presentations related to it. And I think the more work you do on it, probably the more will come with that. So that's my comment. Great job, guys. And also thanks for the QIP project. I'm always looking for QIP projects. The call to action is you went to one of these education days and this project was spawned from that. So who's going to be the next one? So it would be great if we have more projects coming from these days. Good job. And the question is, if somebody wanted to implement this in this area other than DI, could they borrow your tools and work and adapt it to their patient care area?
Yeah, that's what we want to do.
And the questions that we put together also have gone through ethics, and we've actually gone through the process of having them looked at, so they are appropriate to be used in other areas. So absolutely.
Great. So they can pick on you if they want to.
Yeah, they can pick on us. We're pretty good.
Thanks.
An online question. Can you briefly review what the non-traditional risk factors are, and if there are any others?
Yeah, we're going to go back to the beginning.
Okay.
Oh, sorry. Non-traditional cardiovascular risk factors for women include gestational diabetes, preeclampsia, pregnancy-induced hypertension, depression, breast cancer with radiation, and autoimmune disease such as lupus.
Thank you, Christine. Another question. Did you have a response option on the follow-up question to capture those who do not have a primary care provider? So, for example, those who have been referred from the emergency department.
Like, I'm not sure I understand.
So I guess the question is, like on the follow-up questionnaire, it has them like follow up with a primary care provider, but I guess they're asking about capturing people who are referred directly from Emerge or, you know.
So we're sending the people home with the information, and it does come up on a fairly regular basis of people who are being into diagnostics that don't have a primary care provider. And honestly, I don't have a good answer for that. We just give them all the information, encourage them to go through the provincial websites that offer those links to get them. And just once they get a primary care provider, to bring that information with them, because it is important for them to follow up with that.
The information we send home is about the Women's Heart Health Alliance here at the clinic. We tell them to visit our website, If they're not tech savvy like myself, we do give them a booklet to take home with them. We also give them a sheet about the webinars are offered monthly here at the Heart Institute about women's heart health. And they're excellent topics. Highly suggest you listen to them.
She's fantastic. Great presentation, guys.
Thank you, Sandra, for all your support. And Nazli for being at our side. Bonnie Quinlan for guiding us through the process, and Bonnie Bowes for supporting us. And awesome. Rick, our boss at the back, for putting up with us.
Perfect. Good job, guys. Oh. Fantastic. Excellent job, ladies. Our next presenters, Dr. Nazli Parast and Lindsay MacArthur. Lindsay MacArthur is the advanced practice nurse for cardiology, and Dr. Nazli Parast is the advanced practice nurse for the Ottawa Heart Institute Women's Heart Health and Hypertension Clinics. Both will be presenting today a case study of a woman's experience with cardiac symptoms and journey of treatment.
Okay. Perfect. Do we have them out? Yeah, I have them out. Okay. Whew. All right. Players join. Let's go. So we got one person. Oh, two. Perfect. It's going to slowly get over to start the quiz there because that will take a minute. All right. All right. Oh, still going. Oh, Amanda's sad. Sorry, Amanda. Okay. No. Okay, I'll wait till we get to 141 or close enough too. I don't know why everyone's so sad. I'm sorry, okay? Okay. Let's go. I'm just going to do it. Okay. So question 1 of 5. So if you go quicker, you get more points. So if this was your patient, what would you as a healthcare provider assess? Blood work, so like CBC, electrolytes, creatinine. You're going to do an abdominal assessment, make sure nothing's tender. You're going to look at the vital signs, so blood pressure, heart rate, O2 saturation. You're going to assess how much they're drinking just to make sure that they're not dehydrated. You're going to see how much they're eating, making sure they're not malnourished, or all of the above. And there's a timer, so I'll let it run down and then I'm getting ready to click. Whew, okay. Everyone feeling confident? Amanda hasn't said she's sad again yet, so I feel like she's feeling good out there. Oh, Liz is sad now. The sad one needs to go. Okay, normally it tells me if everyone's answered, so. Okay, 3, 2, 1. Oh, the above. So yeah, you're going to want to make sure that you assess everything for this patient. Just do a thorough assessment with them. So for the leaderboard, Faith. Faith in person or online? Ooh, all right.
Okay, question number 2. While assessing the vitals, which question should the nurse ask? Does the pain wake you up at night? Does the pain happen after you eat? Does the pain occur at rest? Does the pain occur randomly throughout the day? All the above, none of the above.
Ooh.
Aha. So for this, I got you. For this question, I actually put my hypertension APN hat on, and you're not supposed to be asking questions when you're checking vitals. So that was a trick question.
All right, so Louise hopped up on that leaderboard. Whoop. Just so everyone knows, there is no prize. It's just, you get a hug maybe at the end. I'm more than willing to give that. Okay, so go Louise. Okay, so even though we're not to ask questions while taking vital signs, these questions should have been asked at some point during the patient's appointment. Unfortunately, however, these questions were not asked. So this patient was sent home with a lab requisition for CBC, electrolytes, and creatinine to rule out infection and or dehydration. Patient was prescribed Panteloc 40 milligrams twice a day, and patient was encouraged to increase fluid intake and get plenty of rest. Patient was booked for follow-up in 4 weeks.
Okay, 2 weeks after the appointment, patient calls her healthcare provider, stating that her symptoms are not improving. She is now having shortness of breath, the pain is becoming more prominent, and she's feeling anxious. What would you advise the patient to do? Book a follow-up with a general practitioner, continue to rest and encourage hydration, advise she would report to a walk-in clinic, report to go to the emergency room.
I believe in you, Louise. You can keep that leaderboard.
Keep the momentum going.
Yeah. I think we set the timer for a little long. Sorry. Maybe I'll just skip ahead. Oh.
Okay. The answer was going to the emergency room. So, and we will see.
So now Meg. Is there Meg in here? Okay, maybe not. Well, good luck job online, Meg. Okay. So as directed, patient reports to the emergency department. So she explains her symptoms. So she states she's experiencing indigestion, fatigue, and shortness of breath. She also explains that she has been experiencing some tightness in her shoulder blades, which started about 2 months ago. She is noticeably anxious.
While in the emergency department, several tests are ordered, including CBC, complete blood count, liver function test, ECG, electrocardiogram, cardiac marker, troponin, and also chest X-ray to rule out alternative causes of chest pain.
So her test results come back. So her CBC is normal. Her electrolytes, urea, creatinine are normal. Her LFTs are normal. Her ECG shows normal sinus rhythm with PVCs. Her TNI is slightly elevated at 20, and her chest X-ray is normal.
Question number 4. Given these results, how should we manage this patient? Send the patient home, repeat the TNI or troponin, keep under observation, B then A, B and C. Just an FYI, there's no trick questions after that question.
Five more seconds. I feel like everyone answered a minute ago. Yep, so the answer is B and then C. Ooh, Meg, still in the lead. So, patient is kept for observation and repeat TNI is complete. So while under observation and waiting for the lab results, the pain in her shoulder blades worsen and she develops chest tightness. So the ECG was repeated and there were no changes. However, cardiology was consulted.
Question number 5, the last question, people. What would be the suspected diagnosis? Suspected diagnosis.
You got a minute and a half to really think about it. So
SCAD, MINOCA, non-STEMI, coronary artery disease, ANOCA, INOCA. My champions better answer these questions correctly. Gave them too much time. They're gonna Google all the answers.
who's excited for lunch?
Oh.
Okay. I
lost
the mouse again.
Moving forward. Okay, the right answer is ischemia with no obstructive coronary arteries, which you're going to hear more about this afternoon. Dr. Packen is going to explain further about it.
So for the next steps, so we're going to refer the patient for a CT angiogram. We're going to place the referral to the Women's Heart Health Clinic. We're going to provide patient with information for when to report to the emergency department while they wait for their appointment. And we're also going to get the patient to make an appointment with their family doctor within 2 weeks to bridge them to their appointment with the Women's Heart Health Clinic.
From the beginning of this patient's journey, what could we have done as healthcare providers differently to support this patient? This is a cloud, so you can put as much information as you want. We're looking for specific answers in case you're wondering.
So there's already a lot of really great comments which are coming up. So a lot of them are already the right answer. So I don't know, Nazli, if you want to start highlighting some of them.
For sure. So the main thing that is coming in the heart of this these words is listen. That is very true. Listening is the most important thing that you can do. Listen and try to make the connections and allow them to communicate with you what's going on, because that's the only way you can get as much information as possible. And you can see that for this patient, we missed asking about her menopause, her status, if she's in my perimenopausal state or not. So those are things that we would miss if you're not listening actively. But these are all great answers. Almost there.
I know. Okay, so what resources can we offer this patient? So this is another cloud, so just put in your input and then we can just kind of go over what resources are available.
Find out how many people from cardiac rehab attended this session.
So lots of great resources once again that are coming up. Nazli, I don't know if you want to comment on some of the ones that are up there and then we can.
Sure. Well, pretty much everything you guys have said are great resources. Cardiac rehab, peer support. We also have educational material and resources available. We also have education session here at the Heart Institute for patients. So yeah, so everything you guys are saying are to the point. We're going to put these links in the chat box. Basically, it's a guide for women's heart health that we developed at the Heart Institute, as well as the Women at Heart support group. But again, I won't spoil that. I will leave it to Nadine to talk about that further this afternoon. We also have the patient education session that is once a month at the Heart Institute. So anybody, any patient can register. We have it on our calendar at the UOHI calendar for patients.
I can't find the mouse again, but that concludes our presentation. Are there any questions?
Well, who's the winner?
Oh God, yeah, that's right. Shoot. Okay, I'll find it.
I'm very competitive, as you can see.
Oh, there it is. Come on. Man. Oh, yep. Oops, never mind. So, spoke too soon.
Meg is here. Oh, Meg's out! Yay!
Do you want that hug?
Thank you so much, Nazli and Lindsay. We have a little something for you guys for your time and for presenting.
Oh,
for
thank
us.
you.
Thank you. Introduce our next speaker. Our next speaker is Tammy, and she's one of our patient partners. She works as a manager in the federal public service and is a busy mom to 5 teenagers. And she will be sharing with us her journey of getting diagnosed with heart disease. So welcome, Tammy.
Everyone. I don't know if you can hear me well. I'm glad I wore red today. I was debating red or blue, but I think it was a good choice. So I just first want to say thank you to Nazli and the team that is organizing this event. I think it's a really important event. And when she asked me to participate, I didn't hesitate because I received so much good care here at the hospital. And whether it's from the doctors, the nurses, even the people that will wheel me to my tests and offer heated blankets, it's been a good experience in a bad time, and I think it's important to give back. So about my heart story, it's kind of funny when you go through a life-changing event. There's a clear before and after your incident or your diagnosis. And I find that in this case today, what I want to talk about is more of the in-between, because that's where I think we can learn more and improve on. So my heart story began in 2016 when I was about 38 years old. And at the time I was married. I had 3 young kids, age 5, 7, and 9. And I was in the middle of my career. So to sum up, a pretty busy woman. And what happened is I remember having a little bit of chest tightness, shortness of breath, and a little bit of chest pains that would kind of come on here and there. Like chest pain that kind of felt like jolts of lightning, but would only last a split second. So they kind of went on for a few months. And I remember I wasn't that concerned. It was weird. It didn't something that would happen to me normally, but I was really busy raising my kids and stuff. And as a lot of you probably know, moms don't get a day off. So I just kind of waited until it was my regular checkup with my doctor. And that's when I kind of brought it up to him. And so at the time I was relatively, active, fit. I didn't smoke. I drank very occasionally and didn't have a history of blood pressure or high cholesterol or whatnot. So I was, kind of like an average 38-year-old woman. And so my daughter asked me a few questions. My doctor, sorry, they said my daughter, my doctor, and he listened to my heart with his stethoscope, and then he pretty much promptly said, the chest pains are probably muscular, and you're probably suffering from anxiety. So he prescribed me some anxiety pills, which I didn't take because I wasn't convinced that that's what it was. So I have to admit, at the time, I was the whole experience kind of left me feeling very dismissed, like I was making too much out of nothing. Like, here goes another woman, kind of over exaggerating. I'm sure it's just anxiety. So it wasn't a really good experience, but he's my doctor, so I figured he's probably right. And I just kind of let it go. But the symptoms kind of persisted enough so that one day I'm like, you know what, I'm just going to go to Emerge and just check it out really fast. So they did an ECG and blood work, and it turned out fine. So you're okay, go home. So I'm like, okay, so I'll just forget about it. So fast forward 6 months later, and I was biking, returning from work, and I was biking up a hill, and then I got really bad chest pains, and I was really freaked out. Luckily, I was right next to a hospital, so I was like, why don't I bike myself to Emerge? So that's what I did. I'm like, might as well. So I biked myself to Emerge, and then they're like, they did some tests. Again, I always have a normal ECG, but this time, what happened was my troponins were a little bit elevated. So that wasn't they weren't high. They were at maybe 50, but it's still abnormal, right? For someone my age. And, so I remember the doctor telling me it was 2 a.m. I could just hear her voice kind of like Charlie Brown going, blah, blah, blah. And then I heard myocardial infarction. I have no idea what that was. And so I was like, I don't know what that is. I'm going to Google it. And then I'm like, wow, that's actually serious. So I was really freaked out because she was saying that maybe I had like a small heart attack. And at the time I was 39 years old. So this triggered a whole bunch of other tests. And like I got an angiogram done, a CT scan, everything was really normal. So I stayed in the hospital for 5 days. And when I got out, well, they told me I could go because they didn't really think there was anything they could do for me. So I asked like, well, what's the diagnosis? Why am I here? And the doctor said, probably myocarditis. And I said, okay, well, what do I do now? Like, do I have to be careful, you know, or whatnot? He's like, he literally just said, just go live your life. So I'm like, okay. So I tried to do that, live my life, but my symptoms would kind of persist a little bit. And like I would, you know, have chest pains for a few weeks after that. And fast forward to about a year later, and everything comes back again. Chest pains, breathlessness, that was one of my main symptoms. So off I go to the hospital again, and same thing, whole bunch of tests, ECG normal, elevated troponins. So after 5 days in the hospital again, they did a bunch of other tests and blood tests and all that. They're like, well, you can go. At this point, I was like, well, my troponins were still kind of erratic. They were still kind of going up and down, but he said, that's normal. You can just go. I'm like, okay. So I'm like, well, what do you think it was this time? And he's like, oh, it's probably myocarditis again. I'm like, is that normal? Having that twice in 1 year? I don't know. Am I prone to this? It wasn't very convincing. And I don't feel like he was convinced, but I kind of felt like he was just kind of dismissing me. Like, we've done enough that we can, all we can do for you. So we're just going to let you go. So, then what happened was there's like a pattern reoccurring. So I don't know why. A year later, again, I had the same thing happen, same, you know, hospitalized, same pattern. But this time my hemoglobins were high. So I needed transfusion. And then when I asked the doctor, well, what do you think it's this time? You know, the third time, he's like, oh, it's probably your hemoglobins this time that got your troponins up. So don't worry about it. You might have, or maybe you have like a higher baseline in troponins, and that's just you, that's your normal. And I'm like, that's weird because I know I had a normal troponin level a few years ago, but I'm like, okay, you're the doctor, you know best. So things were relatively normal after a while. I kind of forgot about my symptoms and just, you know, lived my life. And then one day I went through like a stressful situation in my personal life, and the breathlessness came back. And I don't know why I'd forgotten what the breathlessness meant, but like it had been lasting a few days. At first you think I'm really out of shape, you know, I should start like working out, but I'm like, oh no, it's worse than that. So sure enough, like a day later, I started getting the chest pains. I'm like, oh shoot, it's, you know, here we go again. I know the drill. So I was feeling really bad this time, and I called my my partner at the time, and I'm like, I think we need to go to the hospital. So this is where things changed, because at this point, I had previously been going to a hospital near my house on the Gatineau side, and this time my partner said, listen, Tammy, he's like, if you can hang on for 20 minutes, we'll just go to the Civic. He's been wanting me to go to the Civic since the beginning. And like, sure, it was like a very long 20 minutes, but I'm so glad that we came to the Civic. So I was admitted again and, you know, did the regular routine tests. But this time I pushed back a little because I was seeing this this pattern occur. And I stressed the fact that this was the fourth time I was being hospitalized with the same issues. And like, this can't be normal. And also I realized that my pattern, like my symptoms were coming, usually like developing a few days or a week after like a stressful event, like a divorce, losing our dog, etc. And I just, this couldn't be like just in my imagination. I couldn't be making this stuff up, right? So luckily, that my cardiologist at the time, Dr. Coutinho, whom you probably know, she really listened, and she ordered another angiogram, which was out of the ordinary because I had one a few years ago that was normal. So she decided to just, you know, push just in case. So the doctor that was performing the angiogram, he's like, everything's normal. Like, why are you here? And I'm like, I explained to him a little bit my situation. So he said, well, let's do a deeper dive. He's like, since I'm already here, he's like, I'll do another test on you. It'll make you feel really bad for a few minutes, and you don't move. She's like, because I'm putting some kind of metal like thing up your heart. And I'm like, don't worry, I'm not gonna move. So it was gross. It did make me feel bad for a few minutes. But it's a really good thing because that's when he actually found something. So does anybody want to guess what it could be? Anyone?
In the morning.
Yes, I was having recurring MINOCAs, but they actually diagnosed me with microvascular coronary artery disease, so MVD or CMD for short. And what my cardiologist explained is that all these years I had actually been having mini heart attacks, and I was being kind of undiagnosed all this time. So that was definitely a big shock. But as much as I was really shocked by the diagnosis, I was so relieved because finally I received like confirmation that it wasn't just in my head, that like I wasn't suffering from anxiety. I was just, you know, I was actually like undergoing something. So I kind of felt vindicated. I was like, I was right. But then my bubble burst and I was like, oh shoot, I have heart disease. You know, this is really serious. I was only 43 at the time. And one of the most frustrating things, if you can believe, is that for the past 4 years, because that progress was like a 4-year undertaking, for the past 3 like stays, I was asking the doctors at the other hospital, like, this could be MVD. I had kind of Googled it, and it kind of sounded like it could be me. And actually, I should say that my mom actually Googled it. So just goes to show you that moms are always right. But they kept on kind of dismissing me and saying, no, you don't fit the profile. It's not MVD, and kind of like stop talking to me about it. So I'm like, okay, I don't know these things. So I let it pass. And so after my diagnosis, I have to say that the Heart Institute really stepped up. I was followed by an excellent cardiologist, cardiac nurse, rehab therapist, and I took part in all of the like support programs that the hospital offers, which was really great. And I have to say that I've learned a lot since my diagnosis, a lot of things that I find are very important to kind of get out there. And I feel like that's a little bit my role now. When I have friends that say, you know, I have these symptoms and stuff, I'm like, have you thought of MVD? You know, so it's just one of those things. So for instance, I know I've heard that patients, you know, that have MINOCAs are often younger, more likely women, and that stress can play a factor. And if we stop to think about it, what's one of the most stressful times in a woman's life is like her 30s and 40s, when everything kind of converges, whether it's career, maybe family, aging parents. So it would make sense that it's a stressful time. And for me, I wondered, like, why was I being dismissed, that I didn't fit the profile? I was exactly at that age and undergoing all those things. So I found that kind of interesting. I also learned how it's important to listen to your body and to be your own advocate. So I agreed. I don't have a PhD in medicine. I'm not a cardiologist, but I've lived in my body for 45 years, and I think I could at least say I have a bachelor's or a master's degree in my body. So be your own advocate, and, you know, kind of listen to your intuition and do your homework. Being your advocate, that's what it means, being informed. One thing, for instance, I realized after is that I actually have a pretty history in my extended family of heart disease. I didn't necessarily know that. I didn't kind of put it all together, but now I'm like, oh shoot, you know, our hearts are where it's at. So in our family, so we have to be careful for that. So know your, you know, your family history. And also how women tend to have heart disease of smaller vessels. So routine tests such as stress tests, angiograms, and ECGs, they're not effective in diagnosing that. And that's why, like, I was always having regular, you know, normal tests in this case. And obviously how women's heart health is affected by our hormonal changes, whether it's pregnancy, menopause, etc. And one of the most important and very obvious is how women and men are different. We're built different, and so heart disease affects us differently. I think that's like a no-brainer, but I'm glad that now more and more in the medical profession, people are doing more clinical trials just on women and men separately, just to see how things are kind of like evolving. Had I had this 15 years ago, I probably wouldn't have been diagnosed, because MVD is still a little bit misunderstood and understudied. So I was very lucky that kind of it happened when it did. And I came, and there was like a women's heart health center as well. And Dr. Coutinho was very knowledgeable about women's heart health. So, but I think what was more astonishing for me in all of this is how, like, I learned 1 in 3 women are affected by cardiovascular disease. So that statistic kind of blew my mind, because I'd always heard about the importance of breast cancer screening, doing pap tests for cervical cancer and all that, but I never knew that heart disease was a leading cause of death for women over 35. And I think that's something that should really be like almost drilled in our head as much as the other ones. It's so important to know that. So clearly we have a lot of way still to go. in terms of increasing women's awareness and heart health. I count myself lucky that there's the Heart Institute right here in Ottawa, and there's top-notch cardiologists and an amazing staff that's dedicated to heart health, and in particular, Women's Heart Health Clinic. That totally rocks. And I think it's really helping increase women's heart health awareness, such as in these events. So thank you.
So much, Tammy. That was so great. Thank you for sharing your story, and we have a little something for you. Yes. Are there any questions in person or online? I see we have one there. Yep. Sorry.
No. Just wonder if you reached out to the hospitals where you were dismissed and passed on updated information.
Thought of it. Oh no, actually a funny story. So one of the cardiologists that had, I actually met him at my son's soccer game last year because his son was in the same team. And he's like, I hadn't seen him in like 5 years. He's like, so how's it going? I'm like, good. He's like, how's your heart? I'm like, actually have MVD. He's like, oh. So I thought of it, just to increase awareness. I didn't do it though. I don't know. I don't know. I didn't want to feel like a complainer or anything like that. It's not. Yeah. Mm-hmm. Mm-hmm. Yeah, it's true. I think it's never too late. I shouldn't do it. Yeah. Mm-hmm. Yeah.
I was just curious, on your previous admissions before you got your diagnosis, when you were discharged from the hospital, were you put on any medications or anything?
No.
No.
No, because they didn't think it was anything, right? So I was like 4 years undiagnosed, having many heart attacks. And in my case, so I mean, MVD is, I guess it affects people differently, but stress really affects me. So I have to be careful, whether it's managing my day-to-day stress or even physical stress. If I do too much, then a few days later I'm going to get chest pains, and that's what's a little bit scary, because you think, well, what happens in the big stresses in life? Like if you lose a parent or something, how do I help? How do I like help myself go through that without getting like another cardiac kind of, thing happens? So yeah. Yes, thank you. Thank you.
Great. So our next presenter is Dr. Emily Paquet, and she's actually going to be joining us virtually. So I'm going to just double check to see that she's here. Dr. Paquet, yep, perfect. There we go. Nice to see you virtually. So Dr. Emily Paquet is a cardiologist, currently doing her 3rd year fellowship at the Barbara Streisand Women's Heart Center, Schmidt Heart Center in Los Angeles, US. And she's going to present to us about MINOCA, INOCA, and ANOCA, and how to manage patients with these conditions. So welcome, Emily.
Okay, on my phone.
You're good to go, Emily.
Do you hear me well?
Yes.
Oh, okay. Do I turn off my phone? Yeah. Okay. Okay. So we're good to start. Okay. Well, thank you. Thank you. First of all, thank you for the organizers, Sandra, Nazli, for the invitation to present to you today about a deep dive into MINOCA, INOCA, and ANOCA. And thank you, Tammy, as well, for sharing your story with us. And I think it will illustrate very well the topic of my talk today. First of all, I wanted to wish you all a happy Wear Red Canada Day. I had the pleasure of celebrating it, the US version, Go Red for Women, a few weeks ago here in LA. And I wanted to share with you our attempt at making a heart shape, which wasn't very successful. But most of all, I wanted to share with you the smiles and the energy and the hope to bring forward women's heart health awareness, care, and research. So the objective of my talk today are to define these odd terms of MINOCA, INOCA, and ANOCA, To provide you with an overview of their investigation path, these are complex conditions with complex causes, so we won't be able to go into depth for all of the causes of these conditions, but just to give you an idea of what is the physician doing. I will provide you with an overview of the current management strategies that we have, and I also hope that you'll understand better the relevance of these conditions for the Women's Heart Health Clinic. So we're going to first talk about MINOCA, and then we're going to talk about INOCA and ENOCA together separately, as these conditions are similar. So first of all, what is a MINOCA? So the abbreviation MINOCA stands for myocardial infarction without obstructive coronary artery disease, or myocardial infarction with no obstructed coronary arteries. So when we, in other words, it can be also said as a heart attack without severe blockages of the arteries of the heart. So when we have a patient who presents with a heart attack with a myocardial infarction in the ER, we send them to the cath lab to do a coronary angiogram. So this is bringing a catheter all the way to the heart, injecting dye inside the arteries of the heart. And then we identify a gap where we're not able to see the flow of the dye inside the artery. And this is where the blockage is, and this is what leads to the heart attack of lacking, of not getting oxygen and not getting blood supply to the muscle that is downstream of that blood vessels. And generally that occurs because of a cholesterol plaque that breaks suddenly, releases chemicals into the bloodstream, and these chemicals will force the blood to clot, and that blood clot is what caused the very acute myocardial infarction. However, in about 6 to 10% of cases that we see a myocardial infarction in the ER, where we don't find this blockage when we go to the cath lab. So that is what we call a MINOCA. Before getting into the possible causes of MINOCA, I want you to keep in mind that the arteries of the heart are like branches on a tree. So you have the bigger branches leading to smaller branches, leading to smaller and smaller, and so on. And similarly, the blood vessels are the same. So you have the bigger arteries leading to smaller branches, all the way down to the capillaries, which are microscopic sized arteries, all bringing oxygen and blood flow to the body. And with regards to the heart, you will have the epicardial arteries, which are the larger arteries that lie on top of the heart. And these arteries are only responsible for 5% of the blood circulation in the heart. And they are the only arteries that we're able to see with our current imaging tests, which are the coronary angiogram or the coronary CT. But you have all these arteries that we're not able to see. So you could have an event that occurred in these smaller arteries that we're not able to see on the coronary angiogram. Or you could have an event that occurred in the epicardial arteries, but that is so subtle that it was missed, or that it's self-resolved by the time we went to the cath lab, so that when we're doing the coronary angiogram, we no longer see where the blockage was. So I like this figure to describe what are the possible causes of MINOCA. So as I've mentioned, you could have a cholesterol plaque that occurred in the smaller arteries of the heart and that led to a blood clot, but we're not able to see it. Or you could have a cholesterol plaque rupture that created a blood clot, led to the myocardial infarction. But by the time we went to the cath lab, that blood clot is no longer present. And if the cholesterol plaque is not severe enough, we may not think that it was the guilty cholesterol plaque for the myocardial infarction. We can also see sometimes a blood clot coming from the heart, inside the heart, being sent down the arteries that feed the heart and blocking the circulation. That could occur in the smaller vessels, or this blood clot also could have self-dissolved by the time we went to the cath lab. SCAD, spontaneous coronary artery dissection, is another possible cause for MINOCA. As some of you know, certainly in the audience, SCAD is a subtle finding that we're not always able to confirm on coronary angiogram. SCAD, I forgot to mention, SCAD is when there's a tear inside the wall of the artery, and that tear leads to accumulation of blood flow inside the wall of the artery, and that the wall protrudes inside the artery and blocks the blood circulation that way. And a SCAD can also happen in smaller vessels that we would not necessarily see on the coronary angiogram. Supply-demand mismatch can also cause a MINOCA. So in cases where there's a very severe increased need of oxygen combined with a very severe reduction in blood flow. An example to illustrate would be, let's say in a car accident, someone who has a very severe hemorrhage. It's a big stress on the heart needs more oxygen, but at the same time, if you lose most of your blood, there's not enough blood to bring enough oxygen, and that can lead to myocardial infarction. Vasospasm is another condition that can lead to MINOCA. A vasospasm is an abnormal constriction of the blood vessel, sort of like a muscle cramps, where the blood vessel constricts and reduces the blood flow. This can lead to angina symptoms, chest pain, but can also lead to infarction. And this can occur in the epicardial arteries, the larger ones, but it can also occur in the microvascular circulation. And finally, coronary microvascular dysfunction, or MVD, is another possible cause for MINOCA. And what is coronary microvascular dysfunction? It relates to abnormal blood circulation in the smaller arteries of the heart. This can be related to different mechanisms, such as insufficient dilation of the smaller arteries to bring more blood flow, or inadequate constriction. It can also be caused by increased resistance to blood flow in the smaller arteries, similar to an old pipe under the sink that has a lot of, that is very rusty, has a lot of debris. The water flow inside that pipe may not be as fluent and as easygoing as it should be. And in certain conditions also, we find a lower number of capillary blood vessels. These very tiny arteries can get destroyed by certain cardiac conditions. So then if there are less arteries, there is less possibility of bringing oxygen to the heart muscle. And I like to add this condition also to the portrait, which is a condition that's been bringing more and more attention in the past few years, which is a myocardial bridge. So what is a myocardial bridge? It is when a portion of the epicardial artery, so the artery on top of the heart muscle, when there's a portion of it that runs inside the cardiac muscle. And then when that happens, if the heart muscle contracts a lot, you can imagine that it can block the blood flow inside that artery by constricting around it. This is an inherent condition that is actually found in many patients, but severe to the point of leading to angina or severe to the point of leading to myocardial infarction is something that is more rare. And it's also something that can be difficult to identify on the coronary angiogram. So we have this patient who presents to ER with a myocardial infarction, or a woman. We bring her to the cath lab and we don't find any blockages to explain what happened. So what do we do next? So we first rule out mimickers of myocardial infarction. So there are conditions that can present very similarly to a heart attack, but that are not actually a heart attack and would be treated differently. The most frequent conditions would be myocarditis, so inflammation of the heart muscle, Takotsubo cardiomyopathy, or stress-induced heart failure, and pulmonary embolism. Once we've ruled out these conditions, then we go and do the investigation work to try and identify what was the cause of the MINOCA, or what would be the most likely cause, to better orient our management and treatment. This investigation process includes obviously a good history and physical exam with a focus on traditional and female-specific cardiovascular risk factors, getting as many as possible details regarding the event and the preceding symptoms, and also identifying other known medical conditions that could contribute or represent risk factors for certain causes of MINOCA. We also do some blood work to confirm the diagnosis of myocardial infarction with quantification of the troponins. We identify contributing factors like anemia, for instance, and we also identify other possible undiagnosed cardiovascular risk factors like high cholesterol or diabetes that was unknown for the patient. We also generally review the images of the coronary angiogram. As I've mentioned, some of the findings are sometimes subtle, and accumulating the history of the patient, the results of the other investigation, and then looking again at the coronary angiogram can help us identify something that was unseen before. The invasive cardiologist can also perform intravascular imaging. So that's using a special catheter that has sort of like a camera at the tip of the catheter that can be either an intravascular ultrasound or optimal coherence tomography, OCT. And this allows us to really image the inside of the artery. And I'm showing here an example of a SCAD, a dissection, where you see inside the wall the accumulation of blood that's pushing on the inside of the artery and causing obstruction to the blood flow. However, these tests require a certain degree of expertise to be done. They are not necessarily available at every center. And because you're using an additional catheter inside the arteries of the heart, there are inherent risks to doing these procedures. So that's why they are not systematically used. And lastly, we can do coronary provocative testing, which is what Tammy was referring to earlier, to evaluate the microvascular function. So what we do is we use the same catheter, the same similar catheter process, and we go down the arteries of the heart. We inject particular medication that will force these smaller vessels to dilate. We see how the blood flow changes in response to this medication, and we can assess if the microvascular function is normal or abnormal if there isn't enough dilation of the smaller vessels. The medication can also be used to try and provoke spasm to identify a vasospasm as the possible cause of the MINOCA. Again, these tests have their risks. We're stressing the heart, we're using additional catheters, and as well, they are not necessarily available everywhere and require a certain degree of expertise to be performed. Generally, in all patients with myocardial infarction, we'll do an echocardiography, but we can also use other imaging tools to help us investigate MINOCA, such as a coronary CT angiography, cardiac MRI, and PET perfusion nuclear scans. And all these tests will aim to identify mimickers or contributing conditions, will help us quantify the extent of the myocardial damage, so the extent of the scar. They will hopefully help us identify a possible cause for the MINOCA, and they can help us assess for coronary microvascular dysfunction. However, unfortunately, in about 15% of cases, despite all the investigation process that we do, patients remain with an unknown diagnosis, with an unclear cause for the myocardial infarction. So what do we do in that case? Well, we accumulate all the information that we gather regarding risk factors, presentation, findings from the investigation, and we try to identify what would be the most likely diagnosis. And we balance the pros and cons of what is the likelihood of the diagnosis being the cause of the MINOCA versus what is the risk of treating that condition. And a good example is the risk related to blood thinners. So if we suspect that a blood clot sent from the heart would have caused the MINOCA, then does this patient have a significant bleeding risk if I start blood thinners? And is my diagnosis likely enough to be worth trying these medications despite the bleeding risks? So we sort of balance both. In most cases where a cause has not been found, we will consider treating cholesterol with statins because cholesterol plaques are the most likely, the most frequent cause of myocardial infarction. Cholesterol plaques are very prevalent in the population, and we know that statins have a very low risk, but can lower the risk of future heart attack and stroke significantly. We can also use angiotensin antagonists, which is a blood pressure class, a blood pressure medication class that includes ACE inhibitors and angiotensin receptor blockers, or ARBs. And these medications in small studies have it's been suggested that these medications possibly improve microvascular function. So for that reason, when the blood pressure allows us to use these drugs, we sometimes prescribe them, even without having diagnosed microvascular dysfunction per se. And we will also treat cardiovascular risk factors aggressively to try and avoid future harm on the heart and to possibly improve the health of the blood vessels of the heart. That includes treatment of diabetes, hypertension, smoking cessation, and treatment of obesity. And we promote heart-healthy lifestyle and cardiac rehabilitation for everyone. And my former colleague, Ms. Van Ryn, is going to talk to you a bit more about that. So a MINOCA is not a benign condition. Fortunately, we know that when we compare to patients who had a myocardial infarction secondary to obstructed arteries of the heart, patients with MINOCA tend to do better. So they have a lower risk at 4 years in this study of having a recurrent myocardial infarction or all-cause mortality. However, when we compare MINOCA to the normal population, so to patients without known cardiovascular disease, we can see that this risk of having a recurrent myocardial infarction or all-cause mortality is significantly higher. So that's why the promotion of cardiovascular risk factor management and heart-healthy lifestyle is very important in these patients. Now switching gears to what are INOCAs and INOCAs. So the abbreviation INOCA stands for ischemia without obstructive coronary artery disease, so a lack of oxygen supply to the heart muscle without severe blockages of the arteries of the heart. And INOCA stands for angina without obstructive coronary artery disease, so refers more to the symptoms of chest pain. And just to remind you, what leads to ischemia or leads to angina is when there's a disbalance between the oxygen need of the heart and the supply of oxygen that is being brought to the heart. And this disbalance can occur when the oxygen needs increase significantly, for instance, during exercise, emotional stress, sickness, throughout the menstrual cycle. And you can also have insufficient oxygen supply if you have an underlying cardiac condition that's affecting the blood flow inside the arteries of the heart. What is the difference between INOCA and INOCA? Well, we will use INOCA when we've been able to objectively demonstrate this oxygen supply need mismatch or disbalance. And to demonstrate this, we can use different stress tests. So that includes the treadmill stress test, echocardiography, cardiac MRI, nuclear imaging, or provocative testing during coronary angiogram. One thing that I find very interesting is that we are getting more and more data on the interest of using treadmill stress testing. What I learned in med school is that treadmill stress test was more or less useful in women because we would often find false positives. So these women would have EKG changes during their treadmill. We would refer them for another test. And on that test, we would find no abnormal or no blockages of the arteries of the heart. So we thought these were false positive, but now we're getting studies showing that in fact, patients who have abnormal ECGs during treadmill, this is actually suggestive of microvascular dysfunction. So I think we will be using these tests more and more in the future as they are not risky at all, allows us to assess the overall exercise capacity and may in fact help us identify microvascular dysfunction, but we need a little bit more research in that field. So unfortunately, our current tests remain limited in terms of their accessibility. Not all of the tests are available everywhere. In terms of their safety, when it comes particularly to provocative testing in the cath lab, there are risks to doing these tests, but also our ability to detect disease and to understand INOCA. There are still patients who will remain with the diagnosis of INOCA angina because we're not able to identify ischemia with our current tests, but yet these patients respond very well to NC angina treatment and they have symptoms that are very suggestive of cardiac angina. So it's possible that we have more to learn about the disease. So our role as a cardiologist, very similar to MINOCA's, is to try and identify what is the most likely cause, what are the contributing factors to explain the symptoms of the patients. And you will see that some of the diagnoses are similar to MINOCA in that you can also find vascular spasm, coronary microvascular dysfunction or MVD, myocardial bridge, and some blockages of the arteries of the heart. So we identify the causes of insufficient oxygen supply to the heart as much as we can. We also identify reversible or treatable contributing factors. And we try to identify triggers and provide strategies to avoid these triggers. So for instance, in patients who have angina that is triggered by emotional stress, well, medication can help, but also having non-pharmacological stress management strategies will also be very helpful to treat the angina symptoms and or prevent them from occurring. And similarly, in patients with microvascular dysfunction who have chest pain when they start to exercise, having a prolonged warm-up will help them in recruiting more blood vessels, dilating the blood vessels of the microvascular circulation, and possibly have less or no angina when they exercise anymore. We also use anti-anginal therapy. We have several medications that can be used to treat symptoms. We also focus a lot on cardiovascular prevention and adoption of heart-healthy lifestyle to prevent future harm on the heart, to prevent development of other conditions that could make the overall heart health worsen. And we refer patients to cardiac rehabilitation. So one finding that I think is very interesting, and this is also recent data coming from the COVADIS trial, where they referred patients with ANOCA to the cath lab to do invasive provocative testing to either identify vasospastic angina or microvascular dysfunction. And they tailored their angina treatment according to which of these diagnoses they were finding in the cath lab. And they were able to show that at 1 year after this strategy compared to usual care, they were able to reduce significantly the burden of angina and to improve significantly the quality of life of these patients. And moreover, they were able to have a better control of other cardiovascular risk factors and improve patient participation to cardiac rehabilitation. Unfortunately, as I've mentioned, we're not necessarily able to refer all patients for these tests, but this is sort of what goes through my mind when I assess a patient in clinic with possible INOCA or ANOCA. I try to identify cues that would have me lean more towards a vasospastic diagnosis or more towards microvascular dysfunction. And then this is what will lead me to try this medication first as opposed to another one, and hoping that we will get better control of the symptoms that way. Again, the prognosis of INOCA and ANOCA is affected by this condition. So again, not a benign condition. In this study, we can see that in patients in the full lines here, those are patients who had microvascular dysfunction demonstrated on a PET perfusion study. And we can see that at 3 years, they had a significantly higher risk of major adverse cardiovascular events when compared to patients who had no microvascular dysfunction on PET perfusion study. We also know that patients with ANOCA have a higher risk of hospitalization for cardiovascular disease compared to the normal population. And interestingly, when you compare to patients who have obstructive coronary artery disease, those without obstruction actually have higher medication needs. And as well, their healthcare and socioeconomic costs are estimated to be close to half of those of individuals with obstructive coronary artery disease. And this is not even considering the adverse impact of symptoms of angina on social life, mental health, partner relationship, and work capacity. So to finish my talk, I'm going to tell you just a little bit more about why we're talking about these conditions in the Women's Heart Health Symposium. I think it's important to underline that MINOCAs occur in about 40 to 50% of the time in women. However, when a woman presents to the ER with a myocardial infarction, she's twice more likely to have a MINOCA than a blocked artery to explain her myocardial infarction. So more frequent in women, and similarly, INOCA and ENOCA are found significantly more frequently in women than men and would affect about 2/3 of women with angina as opposed to only 1/3 of men who have angina. As well, we know that when we send women for provocative testing, we're more likely to find microvascular dysfunction than when we refer men for these same tests. And we also know that women have different triggers for their myocardial infarction or angina. They have different symptoms, they have different treatment tolerance, and they also tend to participate less in cardiac rehab, and they overall have less time for their self-care. So I think this all underlines the importance and the roles for centers of expertise who can really bring patient-centered care and the adequate expertise and access to adequate testing for these patients. There is this very elegant study that was published in 2022 by the team of Dr. Tara Sedlak in BC, and they showed that after 1 year of a group of women being followed in their women's heart health clinic, women with INOCA, ENOCA, or MINOCA, they were able to increase the proportion who had an identified diagnosis or cause for their symptoms or for their myocardial infarction. They also showed that after being recruited in their clinic, women had a reduction in their ER visits and hospitalizations for angina. And these women also had improved control of their angina and improved quality of life, as well as improved control of their other cardiovascular risk factors. And this is likely thanks to the expertise and the access to specialized testing in this clinic. But I think very importantly, it's also related to bringing upfront patient-centered care and also having access to multidisciplinary care because there's a lot of work that is involved in the management and follow-up and treatment of these patients. So I'd like to conclude by hoping that I've disentangled some of the complexity related to MINOCAs, INOCAs, and ENOCAs. Unfortunately, due to time constraint, we're not able to go deeply into all of the possible diagnoses that can lead to these events and conditions. However, I hope I have provided you a good overview of the investigation and treatment path that we take for these conditions. And I hope that I've demonstrated to you the role for centers of excellence in women's heart health for managing these conditions. So I'd like to thank you all for your attention, and I welcome any questions.
Maybe I can start us off with one here. Dr. Paquin, what will ongoing scientific research bring us for just knowing more about MINOCA or INOCA and ENOCA? Yeah, just your thoughts about that.
Yes, so there are currently several studies that are ongoing. I think one that will change, that will affect significantly our management is in the context of MINOCA, where they are randomizing patients to treatment with aspirin and or a beta blocker, which is a medication that aims to slow the heart rate, reduce the contractility, and is a very efficient angina treatment. So we will have data in the upcoming years to know, well, in patients where we don't identify a cause of MINOCA, what are the risks and are there benefits to treating systematically with a baby aspirin and with beta blockers for these patients? So I think that will be very helpful. And as well, there are several ongoing studies to try and identify what are the tests that we can use. Are there easier ways to diagnose microvascular dysfunction? Are there easier ways or algorithms to identify the cause of MINOCA or ENOCA? So I think that's what we're going to see more in the near future, and hopefully get a better understanding of microvascular dysfunction, because we're not able to see these arteries because they're not easily accessible, meaning that like my hand, we can open the hand and have easy access, but opening the inside of the heart muscle is not something that's benign. So the function of these smaller vessels remains quite mysterious, and we rely on surrogates a lot to understand how they work and how they react. And we rely on animal models as well, but hopefully the near future will enlighten us more regarding this disease.
That's great. Thank you, Dr. Paquet. And I think we have some questions online, so I'm going to let Zandra ask them.
Are terms MINOCA, INOCA, and ANOCA used in men?
In men, yes, they are used in men as well. And the term is the same, but we hear them more frequently in women and in women's heart health clinic because they occur more frequently in women.
How widely is MINOCA, INOCA, and ANOCA in the cardiac medical community and in the general medical field? Is this an area where family doctors should have further education?
Thank you for this question. I think yes, and I think it's the role of a Women's Heart Health Education Day such as today. And we have several symposiums and conferences regarding women's heart health to try and spread the word. I think it's something new in that we've tagged a name to it, MINOCA, INOCA. But it's something that's been existing for a long time, and having patients who had an MI that we did not know what was the cause. But now we're coming up with algorithms, with treatment strategies. We'll be coming with clinical practice updates from the Canadian Cardiovascular Society. So I think all these steps will help educate, will help also empower general practice physicians also to participate in the management of these patients.
Last one. Just wondering if a woman is experiencing chest pain, is it still recommended that they chew a baby aspirin and go to emerge?
That is a very a wide question. That it depends on what this chest pain is caused by. I think someone who has no diagnosis, who has acute chest pain and is wondering if she or he may have a heart attack, it could be a strategy to chew aspirin and then to call the ambulance or have someone drive them to the emergency department. That would be the safe way. But I cannot say that all patients with chest pain, if they have diagnosed angina, they are already treated for their angina, they will usually have a treatment pathway to manage their own angina by themselves. And then I don't want to get into the details because this is a patient-specific strategy.
Thank you so much, Dr. Paquet. What a great presentation. We've all learned so much about MINOCA. We're going to just thank you for that. Thank you for joining us, and we'll actually bring our next speaker up as well.
Okay, our next speaker, Helena, is an experienced physiotherapist at the Ottawa Heart Institute and has been a women's heart health champion, a member of the Canadian Women's Heart Health Alliance for many years. She will talk about the exercise consideration for patients with SCAD and MINOCA.
How do I get my slide?
It should be up there, and you can use the mouse just to highlight this and go forward with that.
Okay. I don't see them up there.
Oh, it's you up there.
Yeah, I have 20 minutes to present to you. So once I'm done, you can have a break. So I'll ask you now to sit again. Thank you so much. And thank you for the opportunity, Sandra, to present to our group. So my name is Helena, but most people refer to me as Lainey, and I'm going to speak to you today about considerations for exercise in women with spontaneous coronary artery dissection, as well as an MI with no obstructive coronary artery disease. And I want to let you know that I have no disclosures and nothing that's concerning that conflicts with this presentation, except to say that if you do have symptoms, we do advise you to seek professional medical help. This doesn't replace any professional medical help at all. So in the 20 minutes I have to present to you today, I would like to talk about the highlights of the multinational SCAD registry. I'm going to talk about components of SCAD. We'll talk about known triggers. There's a literature review of physical activity and SCAD. We'll talk about a case study, which is sort of a mixture of a few different people that I've worked with personally. And we'll talk a little bit about a MINOCA study. It's very early days in terms of studying MINOCA and exercise, but I'll give you some indication of where we're at with that. And then we will conclude. So the Mayo Clinic has done most of the research. Oh, sorry. I tried, there was something blocking my slide, so I don't see it up here anymore. Put back here. This is me. Sorry, it's up there, but it's not down here, so I can't see my presentation. Anyway, while he's fixing it, I'll just tell you about this. Highlight this multinational registry that was done by the Mayo Clinic. Oh, before you go, what's his name? The Dr. Pecan is, oh, she's right in the middle of this. So where can I put her? So that Dr. Pecan reviewed this presentation, and hopefully she's still there. Thank you. Now I can see it. So the Mayo Clinic reviewed this data, and the lead author was Dr. Audrey Chosen Suarez, and they surveyed a group of people who had SCAD between March of 2011 and November of 2019. There were 950 participants. The mean age was 47, and 96% were women. 77% attended cardiac rehab, and 70% of SCAD patients had at least one risk factor, either high cholesterol, hypertension, or obesity being the most common of the risk factors. But that's slightly different from what we had thought previously. We always say that SCAD patients didn't have any risk factors, but in this case it did show. Prior to the SCAD, 48% were performing some form of aerobic exercise at least 3 times a week. 32% performed strength building exercise. And so that's actually quite good compared to average population. That's actually very, very good. 93% of these ladies received some kind of exercise counseling, including an exercise prescription. And at the conclusion of this study, what they found was that we need more guidance in terms of SCAD specific assessments. And they obviously wanted us to consider a baseline physical activity assessment, which is what what's our bailiwick in cardiac rehab, and obviously treat risk factors. So it blends very well with cardiac rehabilitation. SCAD-specific cardiac rehabilitation guidelines are needed for optimizing exercise prescription without compromising patient safety. So initially, there's a lot of concern about, how much can we do? Are we going to be safe? What amount is recommended? I'm not sure if this was shared earlier today, but Dr. Sharon Hayes is a leader in the field and published a thorough review of our understanding in 2018. And she's another physician from the Mayo Clinic. No wonder Dr. Katina went there. This study showed that 90% of the SCAD patients that they studied were women, and the average age was 53. and up to 25% of the patients in this study were pregnancy-related SCAD. So they are occurring in healthy women who often had no risk factors, but that had just delivered. So on the figures you see, figure A is a normal vessel. So you can see normal adventitia, media, and intima, outer layer, middle layer, inner layer. And you can see on figure B and figure C, figure B shows an intramural hematoma, so blood clot inside the artery, as Dr. Pacan talked about. And figure C shows that there is an intimal tear with a false lumen, so the blood's flowing through a different pathway. These are two proposed mechanisms for SCAD. We know in our practice that there's often a distinct event that women can point to. They can talk about, it happened when this happened in my life. And so the majority of women will have an emotional trigger that will be the precipitating event for their SCAD. For men, it's more often a physical trigger. They were lifting something super heavy, or they were doing some type of physical work that precipitated the SCAD. In very few cases, there is a severe illness that may have precipitated the SCAD. And then again, about 25% have a pregnancy-related SCAD. I'm just going to step back for a minute and talk about cardiac rehabilitation in general. Dr. Saw's group in Vancouver published a review article in 2021, and in it they state that cardiac rehabilitation is a multidisciplinary intervention for secondary prevention, improving functional capacity, enhancing quality of life, and improving psychosocial well-being in a broad range of cardiovascular disease. It has been well studied over a number of years and is a Class 1 recommendation in multiple guidelines. Class 1 recommendation means that we are really confident in this recommendation. So the Cochrane Group, which is a conglomeration of a lot of reviews combined together, reviewed 63 studies and just under 14,500 participants, and found that compared to no exercise controls, cardiac rehab showed a statistically significant reduction in cardiovascular mortality and risk of repeat hospital admission. Health-related quality of life metrics were significantly improved in the majority of the studies, and overall, the benefits appeared to persist over time with a 21 to 34% reduction in mortality over time. So that's similar to taking your medication. So it's a very significant improvement in your overall risk. So we know that cardiac rehabilitation works, but now we're trying to apply that to this specific group of people. So Vancouver General Hospital led the way in the assessment of this particular condition, and Dr. Jacqueline Saw and her group were the first to demonstrate safety in a SCAD population. They assessed patients at baseline with cardiopulmonary stress testing. They did body composition and depression scores and emotional stress testing. Participants were prescribed 60 to 70% of their heart rate reserve, so their maximum capacity, about 60 to 75% of that, and a rating of perceived exertion, or an RPE, of 12 to 15, which means you're saying that the exercise feels somewhat hard. Gradually, they increase their aerobic capacity. Patients receive psychosocial, nutritional, and stress management support, and their fitness level expressed in VO2 max, which is a volume of oxygen that measures how fit you are, increased by about 18%. So that's actually really good. This research is now widely quoted, and VGH is now a SCAD-specific cardiac rehab center, and they do use all of the above guidelines, except for they adjusted the heart rate prescription to be 50 to 70%. So they've got women to work at a slightly lower intensity for a longer period of time. And they also recommended a blood pressure threshold. So they wanted to reduce arterial stress and suggest that blood pressure be kept at a lower level. So basically they're suggesting that women with SCAD work at a lower intensity for a longer period of time. At the Heart Institute, we use an age-predicted calculation. It's a little bit trickier for us to get stress testing done these days, but we generally use age-predicted calculations unless we really need to do a stress test, and we only test women who are asymptomatic. In this study, though, from Vancouver, at the mean follow-up, at 3.8 years, there was a significant reduction in MACE, and MACE stands for major adverse coronary events, cardiac events, I should say. And so that reduction was 4.3% in the cardiac rehab group versus 26.2% in the patients who had a SCAD but had not attended cardiac rehabilitation. So it's a very significant opportunity to not only improve cardiovascular risks, but also confidence, which is really important. A lot of people that come into cardiac rehab with a SCAD are actually really scared and looking for guidelines and advice about how intense to work out. This original publication was a stoplight tool. So if you can just imagine that the recommended category is in green, and then the caution category is in yellow, and the avoid category is in red, what I'm about to say will make more sense. So Marcia Tweet, who's another Mayo Clinic physician, published a great paper in the European Society of Cardiology journal, and her paper looked at people with spontaneous coronary artery dissection and fibromuscular dysplasia. So fibromuscular dysplasia is a connective tissue disorder, and it affects the arterial wall, making them either too weak or too stiff. It's an associated condition with SCAD, also affects about 90% women, and is unknown in its cause. But it may be related to other connective tissue disorders such as Ehlers-Danlos syndrome. So in this study, what she was trying to identify was what are the recommendations that people can follow when they want to exercise and they have a SCAD. So the goal is to achieve at least 30 to 40 minutes of light to moderate intensity physical activity about 5 to 7 days a week, and at minimum 150 minutes of exercise per week. So again, in the recommended category, we have cardiac rehabilitation, moderate aerobic exercise, interval training, not to be confused with high intensity interval training, but just stopping and starting kind of training, as well as weight training with low resistance and high repetition. With caution, they recommend endurance aerobic training, muscle building exercise, yoga poses without extreme head and neck position. And we recommend that you avoid abrupt, high intensity exercise, peak weights with prolonged Valsalva, so holding your breath while you're lifting, any kind of contact sport, and any kind of extreme head position. So usually, inevitably, someone gets up and says, so what do you mean by an extreme head position? So we mean like standing on your head, right? In yoga, some people might stand on their head. That would be considered an extreme head position. Dr. Pekan reviewed this presentation, and she suggested that we also include this earlier publication for the purposes of demonstrating something that we want to point out here about lacking physician referrals. So the Mayo Group in an earlier publication looked at a group of 269 patients who had attended cardiac rehabilitation. 76% attended most of the sessions, 18 plus or minus sessions. The average age in this particular study was 46 plus or minus 10 years. Again, 96% women, 82% perceived physical health benefits, 75% perceived emotional health benefits. And when we talk about cardiac rehabilitation, we're talking about an array of services. So not likely just an exercise intervention, but also, you know, probably the services of our psychology team and other members of our staff, vocational counseling, that sort of thing. But what's interesting about this particular Mayo Clinic publication was it brought to light some barriers to participation. So in their initial registry, 85 people didn't participate, and their primary reason was a lack of physician referral. And in the study, they also identified additional barriers, including inadequate transportation, no insurance coverage, caregiving or work responsibilities, no energy or a lack of motivation, and just generally feeling too ill to participate. So going back to Dr. Sharon Hayes's scientific statement, she said that providers are encouraged to prescribe a prudent approach to physical activity, balancing the known benefits of exercise with potential risks associated with higher levels of exertion or strain. So basically, we're trying to get you to exercise at low to moderate intensity without causing any additional strain. Referral to cardiac rehab is paramount for addressing exercise-induced symptoms, providing feedback, and individualizing fitness assessments. Arbitrary heart rate and weightlifting limits can sometimes lead to frustration or fear and unclear benefit both during and after cardiac rehab participation. And to that end, let's discuss our case study. So this lady, we'll call her Grace. She's a 37-year-old woman, and she has had her third child. She was previously healthy, and she was a runner. She had a family history of hypertension. She has no known connective tissue disorder or fibromuscular dysplasia. Since her baby was born, she's been getting very poor sleep, as you do, and it's been difficult for her to not lift over 20 pounds since she has a newborn who is in a car seat and a toddler who would still require diapers and still needs her to lift that child up. So I think everyone in this room who's had a child can relate to this type of scenario. She's also under significant financial pressure since her husband's business was drastically affected by COVID. And so suddenly they were a dual income family, now down to living on employment insurance and a little bit of savings. And unfortunately, in this scenario, her extended family lives far away. So she attended virtual cardiac rehab because she was challenged to come on site due to the travel costs, especially the gas prices, but she was able to do virtual care. And while she was on the call, she still had to juggle the care of her children. She was able to access the health library within the virtual care program on her own time in the evenings. And her exercise was mainly walking through her neighborhood with her baby and her toddler and her dog. And she was able to include 2 days a week of doing light strength training once everyone was in bed with a 5-pound weight. So for this lady, we prescribed 30 minutes of exercise 5 times a week, 2 days a week of strength training using a 5-pound free weight at 10 to 15 reps and 2 to 3 sets at a level that felt somewhat challenging to her. There's little space in her life right now for running, and usually she would have a gym membership, but costs are too high for that right now. Interestingly, she was looking for support. She wanted to talk to other women who had SCAD, and I see Helen's joined us at the back. So Helen is one of our leaders in the Women at Heart group. And so we have a specific group for women who have had a SCAD, run by ladies who have had SCADs, and they really do a super job of helping people to adapt and encourage them to, gradually make their way back to living a normal life. But unfortunately, in Grace's case, she didn't have time to see the psychologist, unfortunately. So I'm going to switch tracks because I was asked to speak a little bit about SCAD, and I'm also asked to speak a little bit about MINOCA. And so I'm going to talk a little bit about some studies that have been done on MINOCA. So in this Dutch study, we see another issue with referral and probably another similar barrier, as was mentioned with the SCAD population. We also see that in the MINOCA population. So the green section is the 32% who do participate in cardiac rehab. The red section are the 33% that didn't get referred. And then there's 35% of patients who don't participate at all. But there was a Chinese study looking at 524 participants with MINOCA who randomly participated in an exercise cardiac rehabilitation group versus a control group. And in the exercise cardiac rehabilitation group, they followed a home-based exercise training program 3 times a week during a 3-year moderate continuous exercise training session. They were asked to work at about 65 to 75% of their peak on a bicycle or a treadmill. And after 1 year of follow-up, using the short form 36, which is a quality of life survey, they showed an improvement in their mean physical health score compared to the control group. They also showed that there was a significant reduction in all-cause mortality. A long-term exercise-based cardiac rehabilitation program was associated with physical health and significant reduction in all-cause mortality and MACE in patients with MINOCA. We have lots of work to do in this area, especially with respect to specific guidelines, but I will share with you that most of what we follow here at the Heart Institute are guidelines that come to us from the Canadian Cardiovascular Society and the American College of Sports Medicine. And these are the guidelines that we follow for treatment of myocardial infarction, whether it's MINOCA or acute coronary syndrome. We take a pretty similar approach. We assess their cardiac situation and other medical history. We review the social determinants of health and risk factors. We talk about current, past, and future goals for exercise. We ask about orthopedic concerns, available equipment, and barriers that they might have. And then we recommend what's called a FIT formula. So you'll see that the abbreviation in the middle of the slide represents FIT, frequency, intensity, time, and type. So the ACSM, the American College of Sports Medicine guidelines have changed since the most recent publication, and they've gone down to 3 to 5 days per week. It used to be 5 to 7 days per week. They still recommend 40 to 80% of heart rate reserve if a stress test is ordered, or rest plus 20 to 40 beats if not. We use a simple tool called the talk test. So it's basically, can you carry on a conversation when you're exercising? We know that if you can, you're probably getting enough perfusion to your heart, lungs, and muscles. So that's a very simple test. If you could sing or whistle, it's too easy. If you have to take a breath for every word, you're going a little too fast. So it's a very simple portable tool. The other tool that we use is the rating of perceived exertion, or RPE, and that is where we recommend you work at usually about a 12 to a 15 on the RPE scale, so it feels somewhat hard to hard. In the new guidelines, they also changed the duration of time to 20 to 60 minutes from 30 to 60 minutes. But at the end of the day, what we know now is that sitting is the new smoking, right? So we're just trying to get people to do anything at all, because activity is better than sitting still in terms of your cardiovascular health. But we know that it depends on your interests, your available equipment, and what kind of activity you like to do. And we also know that it depends on the city that you live in, right? Because Dr. Pekin is in Los Angeles and we're here in Ottawa, and we've got to deal with a lot of different temperatures and different conditions. So I just want to leave you with a thought. My colleague, Mary Elena Keast, who's now a retired physio, would say that the science of exercise is easy, but the optimal balanced exercise program that encourages continued motivation, that is really the art of what we try to do. In terms of strength training recommendations, we recommend 2 or 3 days a week, 10 to 15 reps and 1 to 3 sets of a safe, comfortable exercise. We also recommend stretching as often as possible and holding those stretches for approximately a minute. Static or dynamic, doesn't really matter as long as you're doing it regularly. And in conclusion, I just want to say that while further research is needed, we have learned a lot more about SCAD in the last 7 years, and it appears that cardiac rehab is beneficial to the SCAD population. We have much clearer guidelines now and a more direct exercise prescription focus. The barriers to participation continue to exist, though, so physician referral is still a problem. More research is needed for sure in the MINOCA population, and we hope that this presentation will be useful to you personally, as well as to those of you who work as healthcare providers. And finally, I just want to say that the path forward involves participation in research, partnerships, national and international cooperation, and education of patients, healthcare providers, and medical practitioners. We look for new and innovative increased treatment options. And I'm very excited about the work being done by the Canadian Women's Heart Health Centre and the Canadian Women's Heart Health Alliance. And with that, I'll invite any questions. Kristy's.
I was wondering, do you know what is the time frame from when Mrs. Smith would leave the hospital until she would start anything with the cardiac rehab program?
Yeah, it's a little bit longer now than it used to be, but it would be a month or two. Yeah. Tammy. Tammy, get a mic? Just for the people, the online people.
I'm just wondering, for cardiac rehab, is it just when you get your diagnosis, or can you come back, say, a few years later and say, you know, things have changed. I think I still need like help in that respect.
Yeah, so she asked if she could come back to cardiac rehab. So what we try to do is address all your issues in the one visit to cardiac rehab. But if you have a new event or if you have a new diagnosis, then you can come back and have another go around of cardiac rehab. Yeah.
Nadine Elias is the project lead with Women at Heart program. Both will present today on the exciting initiatives of the Canadian Women's Heart Health Alliance and the Women at Heart program.
Good afternoon, everyone. I'm just so excited that I see a sea of red. And it's just such an exciting opportunity because obviously today's Wear Red Canada Day and our 6th campaign, and it's just unbelievable the amount of effort and excitement and passion that we're all experiencing. It's unbelievable. I believe we were trending earlier this morning on socials, and there's events happening all over the place. We just finished our national webinar before I came up here, and we're going to be doing another webinar from 3 to 4 p.m. on the emergency department and chest pain protocol that was recently published. And so if you're interested, you still want to hang out after this and attend that event, you're welcome to do. It is going to be online, and we'll make sure that we put the link into the chat for people to access. But not a worry for those who are in the room today, because everything is being recorded, and we will be disseminating that far and wide. So I'm just very excited. I'm Lisa Comber, as was mentioned by Stephanie, and I am blessed to be the manager of the Canadian Women's Heart Health Alliance, and of course the Knowledge Translation Manager of the Canadian Women's Heart Health Centre. I'm going to be presenting here with Nadine, who is my other partner in crime. We've worked together for many years, and there's some really exciting initiatives that have been happening over the course of, well, I've been here about 15 years, so lots going on. So for the overview, or what we're trying to achieve for this presentation, is to describe the programs and services available within the Canadian Women's Heart Health Centre, talk about the Alliance and all the national initiatives that are underway, and then talk about some resources that are available for patients as well as for providers for ongoing education and support in women's cardiovascular health. So just high level about the vision of the Canadian Women's Heart Health Centre. We are working to change the women's heart health landscape in Canada. And so the centre is dedicated exclusively to conducting women-specific heart and vascular health research, enhancing the care and improving outcomes in the prevention and treatment of cardiovascular disease, and raising awareness in heart disease in women through our advocacy and educational efforts. We deliver local and national initiatives to improve outcomes for women, and our vision is to provide the leadership in development, implementation, and evaluation of cardiovascular prevention and management strategies to improve overall health of women in cardiovascular health. So programs and initiatives, you'll see here there's a wide variety of initiatives that are taking place within the Canadian Women's Heart Health Centre. I believe some of them were touched on today, but we're going to concentrate for this presentation on the Canadian Women's Heart Health Alliance and Women at Heart and the Cardio Prevent Postpartum Program. So
I think we all are aware from today's many presentations in this topic that cardiovascular disease continues to be the leading cause of death in Canadian women, and sex and gender differences and disparities with respect to cardiovascular disease awareness, development, identification, and treatment unfortunately persist. The Alliance, Canadian Women's Heart Health Alliance, was established back in 2018. We had about 55 members when we launched, and it's a volunteer network of experts and advocates to develop and disseminate evidence-informed strategies, transform clinical practice, and enhance collaborative action. It is a very collaborative group and team, and we're all about improving women's cardiovascular health in Canada. So 5 years later, growing in our 6th year now, we have almost, I think we're just shy of 200 members from coast to coast to coast. So it's super exciting that we have representation all across Canada, and I know a number of our members are here in the audience today and online. And so when we talk about stakeholders or volunteer members, it's including clinicians, scientists, trainees, persons with lived experience with cardiovascular disease, and we all work together on multiple strategic, hit the wrong button, multiple strategic initiatives and projects and programs actually. And so we have here just highlighting the 5 themes. So we're all about advocacy. Obviously, we all know today is Wear Red Canada Day. Training and education, knowledge translation, mobilization, health systems and policy, and just recently, which I'll have a slide about this as well, is the research and knowledge generation. What's super novel and amazing is that we have representation from our patient advocate co-chairs as well as healthcare professional co-chairs who sit on in each one of these themes and are directly involved in the overall arching leadership and strategic planning on the executive steering committee. And also, of course, we have a representative from the trainees as well participating on those on the executive steering committee. So I'm just going to get into the granular here and really talk about some of the amazing initiatives that are taking place and that have been taking place over the last 5 years, and specifically on training and education. So we understand, obviously, there's gaps in awareness and education, and specifically in women's cardiovascular health. And so our goal is to educate, increase awareness on all stages. So here's the target audiences that we look to reach out to. High schools. So we're really trying to get to the young, or the next generation, and we'll talk about the initiative there. So high school students and educators, the post-secondary. So we're looking at medical schools, nursing programs, other types of programs, kinesiology, occupational therapy, physiotherapy, midwife, paramedics. The list goes on. We also are looking at the residency programs as well. Healthcare professionals, of course, and then in the workplace, so our community. So I'll go into a little bit more detail about that. The high school project, it's going the heart of the matter. Let's talk about women's heart and vascular health. This was launched about a couple years ago, and it is a lesson plan and toolkit for high school teachers and students. We're looking at grades 8 to 12 or so, and it is a 1-hour lesson plan with PowerPoints. We have an awesome video with a youth advocate, and she interviews one of our persons with lived experience, Nadia, who's a huge advocate, and her son, and what Sebastian's experience was when his mom fell ill with a SCAD during the pregnancy, the birth of her 3rd child, and how he felt about that and how it impacted him as well as the family. And then we go into, of course, the anatomy. We talk about the risk factors. We talk about ways that you can participate in advocacy work. And there's some really great activities. There's a pre and post test assessments, ongoing learning, and then we really hope that some of these students, which 2 of them really came out within the advocacy efforts across, one in Vancouver and one in Ontario, in your London area, and they're just huge advocates now in this space and have done so much even for today for Wear Red Canada. And so I think we're really getting to the younger generations to really help pave the way and for future learnings and opportunities in this space. The Canadian Women's Heart Health education course, e-course, and teaching toolkit. This is targeting healthcare professionals and trainees within emergency medicine, general internal medicine, and cardiology, but of course anybody can access it. They are individual modules available in English and French. They're accredited, and of course they're free. And what's really novel about these and really exciting is that we have a person with lived experience sharing her story regarding each one of these topic areas. This is also a teaching toolkit because all the materials are downloadable and available in terms of the PowerPoints, speaking notes, for we hoping that others will take this information and share far and wide in their own clinical rounds or in their teachings and so forth. So this is a really great opportunity for us, and we hope to expand these modules in future years. We also, this was exciting. I feel like we need to do another celebration that we just finally did our Chapter 9 webinar this afternoon, highlighting next steps and recommendations, challenges, and opportunities and conclusions. There were 12 recommendations that came out from this whole endeavor, this whole project, which is the Canadian Women's Heart Health Atlas. And this is a collection of chapters that were published in the Canadian Journal Cardiology Open, and they are accompanied by detailed infographics, webinars, of course, and of course the publication, really talking about and reporting on the current state of cardiovascular excuse me, disease in women. Our goal with this atlas is to help clinicians recognize the unique aspects of women's heart health care and provide policymakers with information they need to ensure equitable care for women with cardiovascular disease. So more to come, but you're more than welcome to access the chapter webinars online on the cwhha.ca/atlas for more information. And we hope that this is a live document that's going to be updated, or live information will be updated every 2 years, so that this will be the place for you to get the information that you need in this space. Well, we know that there are some gaps in education on sex and gender curricula in our undergraduate programs and medical programs, nursing programs and such. And so what we're trying to do is active recruitment, active outreach to our institutions across Canada to ensure that we are incorporating sex and gender based curriculum into their existing programming. A lot has been done already. We're really fortunate to have a number of our members who are already teaching and are incorporating our information into their current programs and current courses. And we're doing a lot of invited talks too, which is fantastic. And because then that brings up a lot of awareness activities. So a lot of our students that are hearing from us are also incorporating Wear Red Canada and awareness activities at their own academic institutions. So it's definitely picking up steam, and we hope to do more and more of this outreach and relationship building with all the institutions, academic institutions across Canada. Now we have Maria's in the audience, which is awesome. I feel weird. I think you should present this, but this is such an amazing opportunity for us, and this is an awesome pilot project that is being piloted here at the Heart Institute. It's a 3-year project, and it's all about offering a longitudinal curriculum pilot on the development implementation of a formal women's cardiovascular health and cardio-obstetrics curriculum for adult cardiology residency training program. And so this pilot, we're close to completing the first year with some amazing experts presenting on this curriculum. More information, you're welcome to have a look at our website, which details all of the topics that are being covered. The intention is that this curriculum is going to hopefully be picked up by all the adult cardiology programs across Canada. And we're already in discussions with some of our other disciplines that are in need of this kind of inclusion, and that would be family medicine, general internal medicine, emergency medicine, and so this is all in obstetrics and gynecology. So we're already making those relationships. We're already connecting. A lot of our members are already in school, in residencies. We have some people that are already teaching in this area. So we're really setting ourselves up for success, and I can't wait to see the next couple of years what unfolds. Also, for resources to reduce barriers, just want to highlight on a couple, and that is the clinical practice update for MINOCA. This is a partnership with CCS, the Canadian Cardiovascular Society, and the Alliance, and we were spotlighted at Vascular 2023, and this publication is in final review, and it will be published shortly. There's also clinical guidelines and scientific statements specifically on the diagnosis and treatment that were highlighted in Chapter 7 of our atlas. And all of those that are listed here specifically in cardiovascular, coronary artery disease, valvular heart disease, heart failure, cardio-obstetrics and cardiovascular rehabilitation, all of those have been reviewed to ensure that we have incorporated sex and gender specifically within those guidelines. So we're only emphasizing or sharing information that is relevant specifically that incorporate a sex and gender analysis and or recommendations that are included. We conducted a national survey on the current state of cardiovascular care provided to women, and that is going to be hopefully going to be published very soon. And obviously, we're all about having information accessible, so you can see it. You will see an inventory of all the programs and services across Canada, emphasized in an interactive map. And then we're also going to be addressing the gaps and barriers and recommendations to really get a clear idea of where potential barriers for access are and what we can then work towards to hopefully improving those gaps. And then lastly, as I mentioned, we do have a presentation coming up at 3 o'clock this afternoon about women presenting to the emergency department with chest pain. So far, we've already published a clinical summary outlining the issues with women presenting to the emergency department. And then we've just recently did a publication on a protocol, and we are going to be launching next month, I hope, a national survey to assess that baseline knowledge of primary stakeholders, which are those at the emergency department staff, and to get feedback and uptake and interest and feasibility on whether or not we can start testing this new algorithm in the emergency departments across Canada, looking at rural hospitals, community hospitals, hospitals that are teaching hospitals, and looking at a variety of different areas that we can target. And then also we have been recognized recently as the country's cardiovascular health hub for women. And this is through the CIHR, so Canadian Institute of Health Research. They have granted us $840,000 over the course of 4 years to really enable us to do some work in the space of research and cardiovascular care. So you'll see here there's 4 specific objectives that we're looking to achieve, and it's all about scaling our existing evidence-based strategies to improve that overall awareness, prevention, detection, and management of cardiovascular disease, maximize that research impact, build capacity for the next generation of health researchers. We're all about education, training, mentorship opportunities, and engaging underserved populations to identify those gaps and opportunities for future research opportunities and innovations in this space. And now I'd like to pass it along to my amazing colleague, Nadine, to continue the discussion.
Thank you, Lisa. Good afternoon, everybody. Pleasure to be here. So my name is Nadine Elias, and I'm the program manager for the Women Heart program that I'll talk briefly about as we go through the next few slides. So Lisa have been focusing on, closing the gaps when it comes to educations and increasing knowledge about women's heart health. But a big piece of it also is to increase education and awareness when it comes to women with lived experience themselves. So empowering our patients. And that's why we also have created some resources to help women to be more advocate for themselves when it comes to their own recovery after having a heart event. So we have created some multilingual resources in order to help people who are at a higher risk for heart disease. We also developed and engaged women in a cardiovascular rehabilitation network and also created a peer support hub. So when it comes to the multilingual resources, so we want to be able to make sure that we reach to women across Canada, particularly those who are at higher risk for heart disease. So we put it together different resources in different language to address the symptoms of heart attacks for women, the causes for heart disease, as well as the risk factors and way to help them reduce those risks. And that's based on the chapter 2 of the Atlas that Lisa mentioned a little bit earlier. So our target audience are the indigenous, Black, Hispanic, South Asian, East Asian, as well as Chinese, North American women for this specific project. It's a multi-phase project where first phase we translated and adapted the 5 key messages in 15 different languages. And just to name few, English, French, Arabic, Hindi, Chinese, Portuguese, Punjabi, Spanish, and the list goes on, including some American Sign Language and the Quebec Sign Language as well. So the goal is really to be able to build a relationship with the different cultural associations, community health centers, as well as women with women's heart health centers, doctors' offices, to assist them to better disseminate that information within the target audiences. The resources were professionally translated and were also vetted by healthcare providers as well as members of the different community. And all of those resources will be available also on our website, and I believe that will be put in the chat. So when it comes to engaging women in cardiac rehab, we know that it's an important part of their journey to come back to wellness. But people often will identify that they were not referred to cardiac rehab. So that's a gap in, in terms of referral, but also because they were not aware. So what we're trying to do is to help women find the different cardiac rehabs that are available by creating, a map where women in one place could find the different cardiac rehabs that are available for them that could help them on their journey. So to help improve the attendance of cardiac rehab after having a heart event. As of now, we have 64 different cardiac rehab program in our list, and we're hoping that by the end of March, we increase it to 100. So if you are involved in any way in a cardiac rehab within your local organization, you are encouraged to sign up your group so it becomes part of that network and easily accessible to women when they're looking for various programs after their event. But also part of that project, we want to try and enhance the cardiac care, the cardiac rehab providers' professional knowledge and skills in relation to women's experience after having a heart event by providing them professional educational material, training opportunity, and patient resources specific to women that could be used within their cardiac rehab program. There's also the Canadian Women Peer Support Hub. So that's a 2-arm program. So as many of you may know, that women living with heart disease, after having a heart event, need more than just medical care. Peer support empowers women and provides a safe place to meet, bond, share experiences. So it comes in many different forms. So depending on the various programs, it could be virtual, it could be formal, informal, it could be free or in charge. So to help connect, again, women and help them find the support they need, we've created the peer support hub where we have about 20 programs right now in the list, in the directory, where women could find support depending on where they are across Canada. And the intent is to increase awareness and connection for women living with heart disease and vascular disease for their need. One program in particular that I would like to spend a little bit more time on is the Women at Heart program, which was a program that was developed here at the Heart Institute called the Women at Heart Peer Support Program. This program is an initiative that was based on findings that we find back in 2014 about what are women's needs and wants when it comes to the recovery after having a heart event. The program is a community-based program that have transitioned to virtual groups right now since the pandemic, but it's meant to be offering support within local community to help women through their recovery, to find care and support. It also helps reduce and eliminate the barriers when women have to be traveling or going to different areas And it's a 2-hour-long program, and there's 10 sessions in total that are done over weekly and bi-weekly sessions. So it's a total support of 4 months. The groups are usually between 8 and 12 in size, and we require a minimum of 5 to start our group to make sure that there is a good exchange and a good support within the group to help women learn from each other and support each other as they go through the recovery. It is a closed group, so once the group starts together, they stay together because often there is a great bond that forms within those groups and go on beyond that 4 months of support that is part of the program. The program is free of charge and do not require any referrals. So any woman who's looking for support could register for the program and join the different peer support group depending on where they are. Since the pandemic, we've been very fortunate when we transitioned to the virtual groups. We have been able to offer support to women from across Canada, coast to coast, and our reach outside of our area here have increased by 429%. So really, women who are in need are able now to find a resource that would help them and support them. We also have trained 7 leaders across Canada. So our groups now are not just locally within Ottawa, but they could also be local out in Vancouver, in Manitoba, in New Brunswick. So we have across Canada 7 leaders that are able to offer the program in person as well. Managing risk factors, as you may know, after a heart event is important, and we've been talking a lot about secondary prevention, and can reduce mortality by 25%. But there's also reducing risk factor before having the first heart event, and being able to postpone it is 33% of all deaths. So primary prevention is also key, and that's something that we also focus on. So making sure making healthy lifestyle changes matter, and they also add up. So that is why we also have a postpartum program to help women who have been diagnosed with a hypertension disorder or a pregnancy complications, gestational diabetes, to reduce the risk of developing heart disease later on in life. How does that program run? So the Cardio Prevent Postpartum program is a prevention program. It's intended for individuals that are at high risk due to genetic factors or lifestyle. It's a one-on-one health coach support that they receive for 1 year to improve their lifestyle changes. And the program provides a tailored education and programming to help them with behavior change. It focuses on risk factor as well as self-management skills. And part of the program, participants gain access to our virtual care platform, as well as specific workbook and resources for each one of their sessions. So where do we go from here? This is a huge undertaking, from what Lisa talked about to the community groups that we have. We're very proud in what we have accomplished to date, but we want to continue to build momentum and expand our efforts to have more Canadian part of our bigger team. Our commitment to equity, diversity, and inclusions means we value and incorporate every perspective into our work. So making sure that we involve our patient within the work that we do is very important. And there's different ways that they could get involved within the work that we do. Sharing stories is always a good start, if you want to share your story, but also other initiatives that you could be involved in. And this is just few of them. Not everyone always like to share their stories, but they could be involved in becoming a peer leader for the support group. They could become a community advocate to present within their network and increase the awareness of women's heart health. They could also be involved of our local committee or the various committee that we have for Wear Red Canada and organizing different activity on the National Day of February 13th. So it's important to see what interests you, but there is a lot of different variety of activities that they could be involved in. And I believe that's it. So thank you very much, and we're open to any questions.
Thank you, ladies. Does anybody have any questions for Lisa and Nadine? I have one question for you. What do you recommend our participants to do if they are interested in joining the Alliance?
That's a fantastic question. Definitely, I would go on to our website, so cwhha.ca, and if you click on membership, there's going to be a little button, and I think it's purple, and just apply. And of course, it's free. It's all volunteer based, and we're just, I always say, more we can do with more people, and so please don't hesitate. We'd love to have you.
One question online. I am an NP working in the diabetes clinic at Cornwall Community Hospital. I see patients who have gestational diabetes and pregnancy, among other things. How do I refer to the postpartum program that you spoke of, or do patients self-refer?
So the program, the postpartum program do require a referral. So we do have it available on our website as well, or you could simply use the email that is right there, cardioprevent@ottawaheart.ca, to get the referral. The patient could bring it to their doctor if their doctor is not aware, but the doctor could also fill out the referral and fax it to us.
Thank you so much, Lisa and Nadine. That was great. So before I introduce our next speaker, I'd just like to remind everyone just to complete the post-event knowledge quiz and survey, and then we'll actually draw names after this presentation. And actually, our last speaker is Dr. Maria Lopez Laporte. She is a cardiology resident here at the Heart Institute and is an active member of the Women's Heart Health team at UOHI. She will be presenting specifically on managing the women with female-specific risk factors like cardio-rheumatology, heart failure with preserved ejection fraction, and menopausal hormone therapy. So welcome, Dr. Lopez Laporte.
All right, so good afternoon, everybody. Thank you for the introduction. So I have no disclosures. I like to thank all the attendees. It's been a really amazing day, everyone who has presented, and obviously the event organizers. We've heard this quote time and time again, knowledge is power, and I'm really happy that we're all contributing today to really increase our collective knowledge and power about women's heart health. So using a case-based approach, we're going to walk through the following topics. We'll touch upon the world of cardio-rheumatology. We'll describe a little bit what is heart failure with preserved ejection fraction, or HFpEF, in women. And then we'll address the very hot topic of menopausal hormonal therapy and the impact on cardiovascular health. As we walk through all of the presentations, you'll find at the very top of the screen the person who did the talk at CCC Vascular Conference last year, just for future reference if you want to get more details about the topic. So let's get started. This is Lucy. Lucy is 46 years old. She has a long-standing history of lupus. It's been thankfully very quiescent for the past 2 years. She also has obesity, she's premenopausal, and she's never been pregnant. She's a non-smoker, and she's single, she's a social worker, and she actually is a primary caregiver for her elderly mother who has advanced dementia. She presented to the emergency room with typical symptoms of chest pain, feeling of indigestion. Her electrocardiogram on presentation had ischemic changes. On blood work, she had an elevated cardiac biomarker with the troponin. And when we look at her heart with the ultrasound, we see that she had mild left ventricular dysfunction with wall motion abnormalities. When we put all this together, we're very worried about an acute coronary syndrome in this patient. So she went on to have a coronary angiogram, and we confirmed the diagnosis of atherosclerotic plaque rupture in one of her coronary arteries, and she actually required a stent to be placed there. So the question is, why does Lucy have premature coronary artery disease? So the field of cardiorheumatology it's pretty new. It's one of the subspecialties in cardiology, and it really focuses on the care of patients that have what we label as autoimmune rheumatic disorders or diseases, so ARDs. One of the list is quite long, but on the table here, you'll find some of the most common ones. So certainly lupus is the one that we hear about the most, but other things like rheumatoid arthritis, scleroderma, and things like that. These conditions are of interest to us today because they tend to have a pretty strong female predilection. So for lupus, for instance, the female to male ratio is 9-1. So that's pretty intense. Same goes for lupus, is more than 2-1. And earlier today, we heard about what's the link of autoimmune disease and cardiovascular disease. And this has been the matter of vast research. There's many, many layers to it. But part of it is that these autoimmune disorders and cardiovascular disease share common pathways. And one of them, and probably the most important one, is inflammation and all the downstream deleterious effects that inflammation has on the body. The other interesting thing is that unfortunately, patients that have ARDs tend to have a high burden of under-recognized and under-treated cardiovascular risk factors. And we see this often when you have some other health condition, we draw all the attention to that, and then we forget about the other things like the diabetes, the high blood pressure, and things like that. The other piece of the puzzle is that oftentimes the medications that are used to treat the ARDs can also have bad effects on the cardiovascular system. So to try to put all of those things together, I like a lot this image. So as you can see in the middle, we know that autoimmune rheumatic conditions have been associated with virtually all possible cardiovascular diseases. So to walk you through a few of those, we certainly hear a lot about pericardial disease, so pericardial effusion or pericarditis. Down here, atherosclerosis, which is the #1 thing that gives you a heart attack. Electrical instability, so all kinds of arrhythmias, valvular disease, and myocardial disease. And a little plug for our next topic, which is heart failure with preserved ejection fraction. Those things actually tend to coexist as well. So it's a very complex interplay of many factors for these patients. Just to give you a few numbers, so remember, Lucy has lupus. We know that women that have lupus, they are at increased risk of coronary artery disease by 5 to 8 times. So that is very, very impressive. We don't have many conditions that do that. Same goes for rheumatoid arthritis. Patients with RA at a higher risk of atherosclerosis, AFib, heart failure, and so on. And I like to share this table because it's quite shocking when you look at it. So this is a multivariable study that was done many years ago, but the results still remain true. Essentially, what they're looking at is what is the risk of cardiovascular events, like any cardiovascular event, in patients that have rheumatoid arthritis versus patients that have diabetes versus patients that have none of those things. And they did a few models adjusting for potential confounding variables like age, hypertension, other things that give you heart disease. And essentially what they found is that the red box over here is that having rheumatoid arthritis, it not only increases your cardiovascular risk, but it actually does so more so than diabetes. So we've heard about diabetes all day and how bad it is. RA arguably is actually worse for your cardiovascular system overall. So I think, numbers are impressive and we need to be mindful of that. What makes things even more tricky for these patients is that our quote unquote traditional calculators or means for assessing cardiovascular disease, for example, the Framingham risk score, when we kind of think about all the potential risk factors and try to come up with a final score, these tools fail to capture the true risk in these patients. And that's tricky. So for example, in this table, this is using another ARD as an example, which is psoriatic arthritis. And you see that there is a big gap, a big divergence between what we thought the risk was going to be in red versus what actually happened to the patient, meaning the risk is probably underestimated by these tools that we're using every day. So what do we do with that? So the societies of cardiology and rheumatology have obviously realized this and gave it some thought. And there are some recommendations in terms of still using those scores, but adjusting the risk. So for instance, when we talk about rheumatoid arthritis, we say that you should probably multiply the risk you obtain by a factor of 1.5. This is not perfect, but at least it gives you a little extra to make sure we're not missing that added risk that comes with the ARDs. And just a little word here on the top is that this recommendation about the times 1.5 has only been given for rheumatoid arthritis. We do not have that kind of parameter for lupus. So certainly that is a area that we need more research on. So what do we do? What else can we do? So we do have a few diagnostic adjuncts that we can use to help us better stratify our patients. So in the cardiology practice, we can be reaching for things like a carotid ultrasound or a coronary artery calcium score to try to further delineate what is the real risk for this patient. So to put it all together, the care of patients in the world of cardiorheumatology is quite complex, as I'm sure you can appreciate. It starts always with taking care of the traditional risk factors, always talking about lifestyle interventions, and then from the rheumatology side, always aiming for disease quiescence, because every time there's inflammation, the risk is going to be going up. So to summarize this topic, so female predominance in ARDs is very common, shared pathways with CVD, higher risk for patients, and we do need to be aggressive on managing the risk factors. And here, feel free to scan the QR code. That's going to give you more reading about the topic as well. So I'm going to switch gears now a little bit and move to HFpEF, or heart failure with preserved ejection fraction. So again, with a case, this is Sophia. She is 63 years old. She has a higher burden of traditional risk factors, so hypertension, diabetes, obesity, CKD, and she's postmenopausal for a few years now. She has had 3 uncomplicated pregnancies, non-smoker, and she's at home. She takes care actually of her special needs son. She came to the emergency room feeling breathless. She was no longer able to take care of her son. And when we examined her, she had very clear signs of volume overload, high jugular venous pressure, pulmonary congestion, swelling of the legs. When we did some blood work, we saw that there were elevated natriuretic peptides. And when we did the ultrasound of the heart, we see that the systolic function of the left ventricle was normal, but she had grade 3 diastolic dysfunction. We'll talk about what that means. And this other parameter of abnormal longitudinal strain as well. So the question is, does Sophia have HFpEF? And what are we going to do about it? So heart failure is a very, very large topic, obviously. We all know that heart failure is very common. Women represent the vast majority of patients that have heart failure, and we heard already they're at higher risk of having HFpEF. Even though they represent such a big portion of people living with heart failure, they are wildly underrepresented in clinical trials. So again, we're in this loop of we don't have data, we don't know how to best treat them. So these numbers are still quite alarming as well. Just want to take a moment to actually define HFpEF, which is it's hard to do. I'll say a few things. I'll try to piece up a definition together. Certainly, there are some requirements to make the diagnosis. You need to have clinical heart failure. So you need to have signs and symptoms of volume overload. And we need to see that on echo or other imaging that the left ventricular systolic function is preserved. So an EF of more than 50-55%, depending which guideline you're reading. But what I'll say is that many things in cardiology and also in non-cardiac pathologies can present with volume overload and a normal EF. So even though those two things are required, they're not sufficient to reach the diagnosis. You need to make sure that you're not missing some other thing that can mimic this presentation, like, for example, pulmonary arterial hypertension. So as previously mentioned by Dr. Heshka, HFpEF is a above all, probably a phenotype, a way patients present. And they tend to be very much so accompanied by many other comorbidities that we need to be mindful of and look for. So that's probably more confusing than helpful. So one of the things that I use all the time in clinical practice is a score to try to identify which patients are likely to have HFpEF. And I find it quite helpful. This is the H2 FPEF score. It's kind of like an amalgamation of different things. It takes into account risk factors, coexisting conditions, and more objective data like Doppler signals on echo, that when you pull them all together, it increases the likelihood of this patient in front of you having HFpEF. So some of the things you'll see is, what we've been hearing about high burden of comorbidity in this patient. So elevated BMI, hypertension, elderly age, and some of the coexisting diagnoses like atrial fibrillation, and the other two are mostly associated with consequences or coexisting changes in cardiac structure. So high filling pressures or pulmonary hypertension noted on more advanced imaging of the heart. And what is nice is that this score has been validated against pretty objective data, which is actual catheters in the heart measuring the real pressures of the heart in people having HFpEF. So I feel like it's a quite reliable tool. Obviously, you have to use it into context with everything else, but I find it to be quite helpful. So this is an interesting question. Why are women more likely than men to present with HFpEF? What is that all about? And this is a very large, I think it's multifactorial and there's many things involved, but I wanted to highlight a few that I personally think are very interesting. So we can take it all the way back to really sex differences in essentially anatomy and physiology and just normal human development, I would say. So we know that women tend to have stiffer arteries at baseline, tend to have different left ventricular geometry, and the combination of both of those things actually leads to diastolic dysfunction. Diastolic dysfunction, in essence, is just impaired relaxation of the heart. The heart is stiff. It cannot relax properly, and that makes the pressures go up. Whenever you have the pressures go up, the heart has to work harder to achieve the cardiac output that you need to meet your metabolic needs. So all that sounds bad, obviously. So this combination of kind of like anatomical variability in women is probably one of the many things that explains this sex difference. Some other things are related to what I've said many times already is the high burden of comorbidity that accompanies HFpEF, the high burdens of obesity, diabetes, and we've heard this already, but I'll stress it again. Even for the quote unquote traditional cardiovascular risk factors, the diabetes, the hypertension, women do worse at the same degree of severity. And that is quite powerful. So we need to be aggressive on treating those risk factors. And this is also quite interesting. It's been shown that women with the same severity of heart failure, and in this case, HFpEF, they actually experience more dyspnea. So they feel worse. So we need to be mindful of that when taking care of these patients. This is just one word about how to treat this complex condition. Certainly the therapies for HFpEF are completely outside the scope of today's lecture, but I just wanted to highlight that this algorithm is from the 2022 American Heart Association HFpEF update, and it was one of the first guidelines to actually include sex-specific recommendations about medications. This is should/will become the norm in the future in terms of not only doing the research but also reporting sex-specific recommendations. And here it's quite basic what they said in the sense of all women with HFpEF should be trialed on these therapies, and they gave some different cutoffs for men. We can get into that in the Q&A if someone's interested, but I just wanted to highlight that this is what we should be aiming for in being mindful of including sex-specific recommendations in our guidelines. And, we haven't done that yet in the Canadian level. Our heart failure guidelines are still a little bit outdated, 2017. We haven't yet included those parameters for HFpEF. I just added this table. I know it's very busy, but I think it's a good summary in terms of the company that HFpEF HFpEF keeps and things that we need to look for and address aggressively. Many of these things may require referral to subspecialty centers, for instance, sleep medicine to make sure we diagnose and treat sleep apnea. Obesity, which may include referral to bariatric surgery if that's appropriate, and internal medicine, nephrology for other comorbidities as well. So to summarize, HFpEF, very common, more common in women than in men, very debilitating dyspnea in women, and requires very prompt diagnosis of the comorbidities and aggressive management of those. So now this is the last topic I'll talk about today. This is a very hot topic and could probably be a day on its own. So I'll do my best to give some of the things that I think are most interesting and useful. So this is Charlotte. So Charlotte is 51. She has been menopause for about a year. She's had 2 pregnancies which have been uncomplicated. And on questioning about family history, she mentions that there's a history of premature myocardial infarction, but really in a 2nd-degree relative. And she's an ex-smoker, quit many, many years ago, and she works as a police officer, so a very active job. And you get a letter from her GP saying, I need some help, essentially. Charlotte is having a lot of menopausal-related symptoms. So she's feeling insomnia, hot flashes, low energy level. And they had started a discussion about starting menopausal hormone therapy. But Charlotte was very worried because she has this relative who has had an early life myocardial infarction. So both Charlotte and the GP weren't sure where to go from here. And we were asked to assess cardiovascular risk for menopausal hormone therapy. So this is a complex topic. In essence, the role of menopausal hormone therapy to this date is really to treat the vasomotor symptoms of menopause. It should always be an individualized approach. And the main thing we want to see is how bothered is the patient about these symptoms. Just like Dr. Garuba was saying, maybe some cardiologists never thought they would ask about contraception. Same thing applies here. Probably many cardiologists didn't expect to be asking about menopausal symptoms. Just a refresher, these are some of them. Certainly hot flashes, vulvovaginal, bladder, sleep, and mood-related symptoms. Once you have assessed that, the next step is really asking whether even the patient would consider going on menopausal hormone therapy. And if the answer is yes, then the question remains, is this safe for this patient? So the reason why this is tricky is that a lot of the data that has come from MHT, menopausal hormone therapy, is observational. And as you know, observational data is full of confounding. It's hard to tease out what are real associations versus not. So I chose to stick with the highest level of evidence that we have available on this topic to answer the question about whether it's safe or not. And this is it. So the Women's Health Initiative, these were 2 large randomized trials asking the very question of, is there increased mortality associated with the use of MHT? So using the PICO question that we like to use for research, just to give you an overview of who was the patient population. So here we were looking at postmenopausal women, 50 to 79 years old. The intervention was a combination of estrogen and progesterone versus estrogen alone, and the comparison was placebo. And the very question was all-cause mortality, and then later on, cause specific mortality, so things like cardiovascular disease. This table is very busy, but I'll walk you through it, and it has all the answers that we were looking for. So, I don't think my mouse works, does it? I guess not. But if you can see at the very left, it's all the types of outcomes we were looking for. So all-cause mortality is the very top. Cardiovascular mortality is the second one. This is a forest plot. Essentially, it tells you if you're favoring the hormone therapy versus favoring placebo, and you have the p-values on the right side. At first glance, you see all of those p-values are negative, meaning there's no significant difference between both arms, meaning that the use of MHT is not associated with increased mortality. So bottom line would be that MHT is safe from a mortality perspective. But that's obviously not sufficient. We want to see, does it increase the risk of other conditions? So unfortunately, when we look at the data of the Women's Health Initiative trials, comparing again the MHT versus placebo, we do see that there is an increased risk of adverse events in the MHT group, particularly at the level of coronary artery disease, stroke, and venous thromboembolism. However, when we did a little bit more of a nuanced analysis, looking at stratification of these results based on age and onset of menopause, we see that actually the risk of these adverse events is much lower in women that are younger, so 50 to 59 years old, and in women that are earlier in their menopausal transition, so within 10 years. So bottom line, age and time since menopause really do matter and impact the associated risk of MHT. So a very simplified approach that I propose in terms of how to approach this problem, when you're assessing someone that has significant symptoms of menopause, first is making sure that indeed there is a high burden of symptoms, making sure there's no other contraindications. The QR code there gives you a very nice management tool to help you make sure you're not missing all these nuances about those contraindications. Number two, checking the age of the patient and the time since menopause, being mindful that if you're above the age of 60, if you've been more than 10 years in menopause, we should probably not start you on MHT. And then doing, to the best of our ability, a thorough cardiovascular risk assessment. And I'll leave you with this nice summary image about what are the risk profiles that we can see when assessing women for MHT. So if you look at the green light would be certainly the ideal candidate, someone that is younger, that has low burden of cardiovascular comorbidities, that is early in the menopause transition. So to summarize, as anything in medicine, it needs an individualized approach. It does require a comprehensive cardiovascular risk assessment, and age and time since menopause are very important parameters when assessing MHT candidacy. So I'll leave you with a nice quote. This is Ruth Bader Ginsburg. She's one of the only few women that were justice in the Supreme Court, and she was a very strong advocate for women's right. So in her words, real change, enduring change happens one step at a time. So thank you so much.
We just really appreciate your presentation. Just want to see if there's any questions in person or online. Well, I have one that could start our discussion. What should we do if a woman is taking menopausal hormone therapy and has a heart attack?
Yeah, that's an excellent question. We certainly have had that situation. With the data that we have now, there should be a discussion of stopping MHT after an adverse cardiovascular event. There's certainly a art in doing that because there's obviously a reason why that patient was on it. So the way I phrase it is that we explain what the reason is, and the reason is just that you're already at higher risk of having another event. And the main thing I'll say is to ensure follow-up. So either GP or gynecology needs to see that patient to discuss any other options. Depending on what the symptoms are, there may be local therapies that we can use that are lower risk of cardiovascular events, and it just has to be a discussion with the patient.
So much.
Begin with a red. Perfect. Okay, congratulations to you both. Our final speaker, Kira Torko, is the Vice President at Ascent Compliance and currently is a board member at the Ottawa Heart Institute and chair of the Ottawa Heart Institute Research Corporation. She'll be concluding our day with closing remarks.
Thank you. All right, I think I am standing between you and taking action on all of the wonderful things you've learned today. So I'll wrap this up quickly. I know it's been a really great day. It was a really powerful day for me, although I was trying to work. I kept being drawn in remotely to all of the great speakers that were on today, and I'm sure you all have been as well. I think it was much more impactful than perhaps the work I was doing today. I'm really proud to be a volunteer at the Heart Institute, and I think the work that happens here around women's heart health was a key driver for me to take on the responsibility of being both on the board and chairing the research corporation. For me personally, I have a deep passion for this space. My parents and all their siblings and all of my grandparents have passed due to heart disease. So for me, making sure that I'm healthy, the women I know are healthy, and that great research is being done has many facets to it for me. And I work in a pretty stressful environment. I'm an executive in a high tech company, so my stress levels aren't always, what they think they should be. So it's a great privilege for me to be able to contribute to this organization and to this topic today. I think, how many people was it? 200, 300, 400 people who were on across the country today? Close to that, and it's just a force multiplier. I know things I took from this morning. I ran out of my office and was telling people about it, and I'll share some of those experiences as well. And I expect those hundreds of people will do the same thing. I think this is a theme and a message, at least in what I heard today, that was weaved through a number of topics today. Things women are understudied, underdiagnosed, undertreated, undersupported, underaware. And I can't wait until the point in time when I say, over-aware. It's what's a really interesting story just on this. Where I work, I have about 400 team members in Kenya. And I was traveling there just before COVID, and I asked our insurance provider, I'd love to do some women's empowerment sessions about women's health and women's career progression with our team there. And what they said to me was, we don't actually do women's empowerment anymore. I said, what? What do you mean you don't do women's empowerment anymore? They said, we actually do men's empowerment here now, because we've spent so much developing women and putting in place programs for them. The men are now feeling underserved. And I was like, that's the best problem I've heard in a really long time. And I can't wait till I can say that about heart health, that's a really great problem to have. I think we all heard this much today. I heard a lot about the need for visibility, for awareness, for education. And I'd learned a lot today that I'd wished I'd known sooner. One of the very first speakers this morning, I think, talked about, was it I'm going to apologize, I don't remember the name of the speaker, but I think they said 17% of women who are pregnant experience heart issues. Am I getting that statistic correct? And I'm like thinking, wow, all the times I thought I was having heartburn and, all the things, I never once even thought, during my 2 pregnancies that could have been a heart topic, and the last speaker just spoke about menopause, and as I'm making that transition, these are things I really wish, more and more people knew about. And, I was thinking this morning as I was listening, I can't think of a single time where I've been at an event, with women sitting around a table with me, and we've spoken about women's heart disease. Can anyone think of a time? No. It's interesting. And I thought this past weekend, I was actually at an event, and the women talked about their husband's heart issues. And not once during that conversation did I even think, hey, I'm speaking at this women's heart event this week. We should talk about women's heart health. And I didn't even think to do that. And so I went outside my office this morning, and we've got hundreds and hundreds of people. And so I said to the first 5 women who I saw out there, when was the last time you talked about women's heart health with your friends? And how many of those 5 said they had? Zero. How many of them had talked about breast cancer with their friends? All 5 of them. And I thought, wow, we all play a really huge role in changing some of those statistics. And I know that's not real research, and I don't want to undermine the amazing research that the cardiologists and other physicians have shared with us today, but it was just my fun research for today. So as we're wrapping up, a number of topics that were discussed today, clinical aspects of managing heart health, research aspect of improving knowledge in women's heart health, and certainly as the chair of the research corporation here, something that I feel very committed to. And network and joining Women's Heart Health Alliance and becoming a champion. I submitted my application this week to be a member of the Alliance as I was learning about this, and I hope you all have as well. I think what's really important to note is that small increments and small things you do can make a really big difference. I know when I come back from a conference, my staff usually grumble for a little bit because I come back with all these big ideas about all these things we're going to do that I just learned about at the conference. And very few of those actually ever happen. So I encourage you to think about, 1% improvements. What's the 1% thing you can do? If you haven't read the story about the Olympic improvement for the British cycling team, does anyone know this story? It's I'm not going to tell you the whole thing because it's there's a great ending to it. But essentially their coach and leaders decided we're going to change things by 1%. So they improved the pillows that the cyclists slept on. They reduced the weight of the bike by 1%. And I'm not going to ruin the punchline and tell you how many Olympic medals they won 8 years later, but there's a few in there. So I think 1% really matters. So I would encourage you to think about that as you go home today. Am I okay for time? I could talk for a really long time. Such an important day, and there's so much work to pull this together. Anyone who's put together an event knows it's a thankless task until you actually see people putting things into action, which is why I'm encouraging you all to think about that. So a couple of members that I want to be able to thank, and if I've forgotten anyone, it's just my lack of knowledge, not my lack of thanks for your role. So the planning committee of Nazli and Sandra and Lisa and Melissa and Deborah and Bonnie, thank you so much for that. Behind the scenes, the stuff that you don't always see, but is the stuff that makes an event, that makes or break an event. Certainly Jessica, who I understand kept everyone well fed, and Feiyu, who made sure everyone online and everyone here could see and hear everything. Moderators who make the day run smoothly, Sandra, Stephanie, Kristy, and Zandra. So thank you for that. And certainly to all the speakers. I had an opportunity today to hear Nadia and Tammy. I'm not sure if either of the two of them are still here, who told their patient stories today, which I found really powerful and really courageous from them. And I think when Nadia was talking about going into high schools, I thought, why don't you come to my book club? I think that there's a lot of opportunity around that. And the thing I heard from both of them the most that I took from that was just about how important it is to advocate for yourself and advocate for those around you. You're probably way more educated based on your backgrounds and participating today than 99% of your friends and family about women's heart health. So I think we all have a huge role as advocates moving forward. So has anyone here used ChatGPT? So I asked ChatGPT, how should I end, the women's heart health? And it said I should do 6 things. So I'm going to do 6 things, to close out here. And let me tell you, at my work, if you don't use ChatGPT for everything, like my boss is always like, have you checked ChatGPT first? So I thought it was a bit funny I did that today. The first thing it said is that I should ask everyone to make a personal pledge. So maybe I'll just ask for a show of hands, and the same thing online. Did you take something away from today or a call of action that you are going to do immediately? Anyone? Fantastic. I think that's 98% of the room. And for those who haven't, I bet you'll come up with one when you're heading home. For me, I want to make sure our board continues to be well educated. I'm going to talk about this topic with my female friends, and I'm going to know my numbers. When I saw that today on a couple of the presentations, I realized I had no clue who they were. It was like the shoemaker's children that doesn't have any shoes. So I'm going to do those 3 things. And I'd love to hear from you after we're done here, something you might do. It then told me to talk about resource distribution. I have seen like lavish use of QR codes today, which is amazing. And I expect the resources will be available in Sway. Is that where they will be? So there'll be lots of resources available for you afterwards, because I bet your brain is just overflowing with all these insights. The next thing it said I should do is do feedback. You guys will be doing a post-event survey. Fantastic. We are ahead of ChatGPT here. I should do thank yous. Thank yous are done. I should announce some future events. It looks like I've got 2 future events here if you're wanting to continue to be curious and expand your knowledge in areas. And then it said I should tweet. And then I thought, well, I've never tweeted before.